A very good morning to the judges, to my fellow delegates and all the consultants. I'm Dr. Muralidhar Parthasarathi. I'm a surgical oncology resident from Tangam Cancer Center, Namakkal. I'm here to present our study, which is a propensity matched comparison of early surgical outcomes between robotic and video assisted thoracoscopic surgery in non-small cell lung cancer. We know that minimally invasive surgery has transformed lung resections. Video-assisted thoracoscopic surgery, by avoiding rib spreading, enabled patients to recover faster with lesser blood loss and lower pain. So much so that VATS has become the standard of care in early lung cancer surgery. However, the technique has a steep learning curve. Robotic-assisted thoracoscopic surgery provides 3D vision, tremor filtration, and articulating instruments, which provides improved precision which could be useful in more complex resections. As we know, it is, however, costly. There is very scarce Indian data which compares these two modalities, and a propensity match analysis will also be required in this setting so that it would eliminate bias and provide a more real-world evidence. So our aim was to compare the early surgical outcomes between the two modalities. We evaluated for operative time, which was defined as time from skin incision to skin closure, blood loss and blood transfusions required, duration of ICD, hospital stay, 90-day mortality, and lymph node yield. So this was a retrospective cohort from January 2020 to December 2024. Oh, sorry, the slides. We included consecutive non-NSCLC patients who underwent minimally invasive surgery by a single surgeon proficient in both procedures. There were a total of 26 who underwent RATs and 25 underwent VATs. All of these patients have a standardized protocol we follow in our institute, which includes a tumor board meeting, pre-operative optimization, surgery, and post-operative care. After this, we thought of, for eliminating the biases, we did a propensity matching based on age, sex, histology, whether the patient received neoadjuvant treatment, and extent of resection. So our initial analysis of the two groups showed that largely the two groups were comparable with an average age of 60. There was an equitable distribution of the smoking status. Adenocarcinoma was the most common histology in both the groups. The stage was also equally distributed. The average tumor size was around 3.5. Both modalities has 0 90-day mortality rates, and what we found, and lobectomy was the most common surgery performed. Patients who underwent surgery post a neoadjuvant treatment and those who underwent more complex surgery or sleeve resection were more in RATs. So when we analyzed our objectives, it showed that the robotic assisted surgery had a trend towards a lower blood loss and a significantly lesser blood transfusion requirement compared to VATs. The other parameters were similar. However, we then did, after the propensity matching, although the sample size was reduced, this was more real-world evidence making the comparisons better. The operative time was more significantly in the robotic-assisted surgery. The blood transfusion and the blood loss rates were similar. You could see how the propensity matching has changed the final findings. So operative time was significantly longer in robotic-assisted surgery. This was probably due to the docking and higher complexity of surgery that was done. Both procedures were safe, with 0 mortality rates in the two, and they were oncologically adequate as they had similar lymph node yields and R0 resections. This could mean that robotic-assisted thoracoscopic surgery is a safe, reproducible, and feasible option, particularly in complex resections and those post-neoadjuvant treatment. These findings are similar to international studies done by Lampardis et al. And Newertz et al. Both of them who said that robotic assisted surgery had more time for surgery, but the outcomes were comparable. My study does have limitations which include the retrospective design. This was a small match sample size, and we did not do any long-term or cost-based analysis. The retrospective nature meant that we couldn't clearly assess some of the surgical complexities, which were evident intraoperatively. I'd like to conclude that both RATs and VATs are safe, feasible, and oncologically sound for non-small cell lung cancer. RATs showed longer operative times, but no increase in morbidity or mortality. Lymph node yields in R0 resections were comparable. By using propensity match analysis, we were able to eliminate bias and which would and strengthen the validity of our findings. A probable future direction would be that we could do a prospective study, which would be multicentric, and we could include incorporation of a thoracic surgical difficulty assessment scale, which would help us assess intraoperative difficulties and evaluate complexity of surgery better. Thank you.
Good presentation. I just want to ask one thing. What was the reason for margin positive resections in VATs?
So all the three margins were parenchymal resections. So this could probably be a cut margin along the staple line. This was not a margin which was on the, all the three were confirmed to be parenchymal margins.
Okay. And after propensity match, you were left with this. So what were the reasons of the patients who were excluded on that? On what basis?
So the propensity matching allows us to make the two groups more comparable. And we used sex histology and grade as a proxy for surgical complexity, thereby making the comparison more valid.
What do you think gender is a part of propensity matching for
There are some baseline parameters which were included because these were the similar studies were done which included these parameters, but age and sex were something which was common throughout in all similar studies which were followed, so we adopted that.
In other words, does the gender of an individual play any role, or the gender of the surgeon plays a role?
No, there could be not a direct comparison of just the gender alone, but given that there are more smokers who are male patients, that could, which would increase complexity of surgery, would have a result on gender.
So you would include smoking as one of the propensity matching variables rather than gender.
Yes, we could do that.
Just cancel out whether you are a male or not.
Yes, sir.
In your entire cohort, you did not show a difference in timing based on RATs and VATs, but only after propensity matching. Why did you think that would have happened?
So, post propensity matching, the complexity of the surgery, which won't be picked up in this, where these are intraoperative complexities like fibrosis, post-neoadjuvant treatment, or hilar resection, or calcifications of tumor. These were what would probably depicted, and that the fact that these the surgeries included both the docking time as well as the operative time.
Was this all done only for non-small cell lung
Only non-small
cancer?
cell lung cancer.
And what proportion had neoadjuvant therapy?
So around 8 patients in overall, 51 patients underwent neoadjuvant treatment.
Did you notice any difference in complications or complexity in patients who have had NACT versus who have not had?
From this study we weren't, but it is not exactly powered to identify those, because a lot of those differences can be found out as an intraoperative change, not as a retrospective basis when we have to collect that data.
Okay.
Thank you, Dr. Muralidhar. Now I invite on stage Dr. Pawan Nagarkar for his paper presentation on the clinical utility and comparative molecular study on tissue versus liquid biopsy, normal match samples in patients with advanced non-small cell lung carcinoma.
Hello. Okay. So, I'll be presenting a clinical utility and comparative molecular study on tissue versus liquid biopsy with matched normal samples in patients with advanced non-small cell lung cancer. So, why tissue and liquid biopsy match sequencing? Multiple institutional guidelines recommend next-generation sequencing-based molecular assessment of metastatic NSCLC patients. Each method has its own merits and demerits. Be it tissue or liquid biopsy, any single method can lead to incomplete profiling of the tumor genome, undermining the therapeutic decision-making. Also, reliance on tumor leads to delay in the genomic characterization of the patients. Also, many tumor-only approaches lead to overestimation of TMB when compared with germline subtraction methods. Another problem with liquid biopsies that chip variants, which are the biological noise detected in liquid biopsies, can be negated with matched normal sequencing. So we use this tissue liquid biopsy matched normal approach. So objective of this study is to evaluate the effectiveness of tissue biopsy paired with liquid biopsy in identifying actionable mutations in advanced non-small cell lung cancer patients and to establish concordance between liquid biopsy and tissue biopsy. So the question arises, in liquid and solid NGS, are they exclusive, complementary, or additive? So we had a cohort of 469 advanced non-small cell lung cancer patients. They were newly diagnosed metastatic patients, in which we collected 457 liquid biopsy samples, that is blood samples, and 371 tissue biopsy samples, of which 360 were paired samples, that is paired tissue and liquid samples, which were then subjected to next-generation sequencing using a comprehensive genomic panel of 1,000+ genes, after which we performed bioinformatics analysis for calling variants and statistical analysis. So comparing the landscape of ctDNA and tissue DNA, about 33% of the samples were mutation negative, that is no mutation was detected using ctDNA, whereas comparatively in tissue only 22% of the samples were such that no mutations were detected. Another major contributor, TP53, we can see across both ctDNA and tissue DNA were around 30%, but being on the lower ranges in the ctDNA sequencing. Another major gene, that is EGFR, also around 20%, being with the lower scope where 18% in ctDNA. Other actionable mutations such as MET, RET, ERBB2, ALK, KRAS were also detected in both ctDNA and tissue DNA. Now coming to the sensitivity of both the techniques, sensitivity of liquid biopsy was found less compared to tissue biopsy in detection of few variants such as MET, exon 14 skipping, or BRAF mutations. Whereas for ALK fusions and EGFR T790M resistant mutation, the sensitivity of liquid biopsy was more than tissue biopsy, indicating the use case of liquid biopsy for detection of such resistant mutations during the therapy. Also, we identified concordance between tissue biopsy and liquid biopsy for detection of all fusions and all the NCCN guideline genes, which we found for fusions was around 98%, which is very high. And for fusions, and for all NCCN guideline genes, it was around 77%. So another thing that we observed was only 12 liquid biopsy samples failed. Whereas for tissue biopsy, 98 samples failed, which was accounting to around 20% of the total cohort. Other than that, for liquid biopsy, 144 samples were exclusively negative, whereas for tissue biopsy, only 12 samples were negative, indicating that liquid biopsy has more false negative rate. So this data supports that the complementary testing can reduce failure rate and increase the yield of targetable alteration detection. And among those 20% of the tissue where matched liquid biopsy was available, 38% of liquid biopsy showed positive result, providing an actionable genomic insight which can be acted upon. Further, if a liquid biopsy is driver positive or negative, we can make our decision according to another parameter such as ctDNA tumor fraction. So if a liquid biopsy is driver positive, we can start the liquid biopsy driver positive guided targeted therapy. And if it's negative, we can go to ctDNA tumor fraction. If ctDNA tumor fraction is high, then the liquid biopsy negative result is an informative negative, giving us confidence that there was really no driver mutation. Whereas if the ctDNA tumor fraction was low, then we have to go back to the tissue and again try to trace for any actionable mutation. Are we missing anything? So in our cohort, no additional alteration was detected in tissue biopsy cases with ctDNA tumor fraction more than 25%. So liquid biopsy is very definitive in such cases. And additional alterations were detected by tissue biopsy in 54% of the cases with ctDNA tumor fraction less than 25%. Other than that, we also perform match normal sequencing, which helps us confirm true somatic variants, negating out germline and chip variants, and also helps us to validate rare germline findings or different mosaic patterns like mosaic TP53. So in our cohort, we identify 4% germline variants. So in conclusion, molecular testing for biomarkers is performed either on tissue or liquid biopsy. Both tissue and liquid biopsy have appreciable false negative rate, but together they have lower failure rates. And liquid and tissue biopsy show about 77% concordance, and ctDNA tumor fraction gives more reliability to the liquid biopsy. And sequencing of matched normal helps detect rare germline actionable mutations, confidently negating the chip variants. And if tissue fails, liquid biopsy is to the rescue and gives a mutational profile consistent with the tissue to start the treatment. Thank you.
Then when you had a 25% tumor positivity from the liquid biopsy, you are sure. So what was the matching stages in those patients?
Matching?
What was the matching stage at which you did that?
So they were paired samples, sir, at the same stage.
No, you didn't understand. What was the stage of the tumor?
Stage of the tumor, advanced stage, sir, all were metastatic stage 4.
In metastatic disease you did this?
Yes.
When there was no primary or when there was a primary?
There was a primary, sir.
You had a primary,
Yes.
and you had a matched the tissue as well as liquid biopsy.
Yes, yes.
Okay. So I didn't understand how many of them you changed the treatment simply because you found something on liquid biopsy?
So we are
You-
having. Okay.
How many of them had actionable mutations which were absent on tissue biopsy?
Which were absent on tissue biopsy. So in
Which were actionable? The drug should still be available with you.
So, sir, 1 second. So, we actually had exclusive positives in liquid biopsy about 17. And of the 20% of tissue biopsy, 38% of liquid biopsy were positive. So that will also count to around 20 or something patients.
Okay, so that's clinical data you may not have right now.
Yes.
So Pawan, are you a clinician or you work in lab?
I'm a PhD fellow, sir.
Okay, so is it important that whether the liquid and plasma were drawn together, or is it, or it could have come at any time during the course of the treatment?
No, they were matched samples, sir, at same time. So if at the time of biopsy, maybe 1 or 2 days, maybe there can be a gap, but at the
So
same
what
time.
was the sample size?
360 paired, and total 469 patients were there.
So 360 paired samples
Yes,
you had taken,
yes.
and these were baseline samples or at any time during the course of
Baseline,
the
sir,
disease?
baseline. This data is about baseline.
Okay, but because you showed some T790M and MET amplification,
Yes.
though we don't see those things baseline.
So yes, they were detected in the baseline itself, sir. At baseline also
If you
we
can
have
put up that pie chart if you have.
pie chart. It's not presenting.
Do you think the concordance rate would differ depending upon from where you take the tissue biopsy?
Yes, ma'am, maybe, because there is heterogeneity in the cancer cells. So if you take a biopsy from core biopsy and if you miss the core, or when there is
So
another.
these must not have been taken entirely from the lung.
What ma'am, I can't hear.
These tissue biopsies
Yes.
must have been from the metastatic sites.
No,
as
no,
well.
no.
So these are all from the
Yes,
primary
yes,
tumor.
Yes, yes.
So if you're saying these are paired samples, but just by eyeballing you see no mutation detected 22 and
Yes.
it is now 33
Yes.
in tissue you said, in ctDNA you
Yes.
said. Okay.
So there are more false positives in liquid biopsy. So the tissue biopsy pairing helps to overcome that, and the failure rates of tissue biopsy can be overcome by liquid biopsy as it is having less failure rate. So you can have a more comprehensive idea about the genome and you can take decisions
So
based
have you
on
looked, so they say fusions are not, the liquid is not, sometimes they may miss. So do you know what was the concordance rate? And I mean, did it differ between fusions or point mutations or?
Yes. So apparently we had more concordance for fusion than all the NCCN guideline genes.
So it's the opposite of what we usually
Yes.
we say,
So
right?
the reason can be fusions are more rare. So in the 360 patients also, the amount of patients with this fusion can be less, and that's why we are having more concordance, because we were able to detect in that less patient. But if the patients are all like we are detecting fusions, then maybe the concordance can vary.
And the panel you use in your lab, is it like your own indigenous panel, or you, I mean, who, it was validated in your own lab, or how is it designed?
So we have been
What's the
in
platform you work on?
NGS platform, Illumina platform, and the panel was designed in collaboration with OneCell. Yes. Thank you.
Thank you, sir. I now invite on stage Dr. Rohan Kapoor to present his paper, which addresses do T ratio and young age predict long-term outcomes in Indian stage 3A and 3B operable lung cancer patients.
Good morning everyone. So I'm Dr. Rohan Kapoor. I bring greetings from my institute, All India Institute, New Delhi. So I'll be presenting a paper which talks about a basic, we've talked about mutations, we've talked about immunotherapy. So we'll be discussing some basic clinical marker which can be used even in low resource setting. So this is our institutional data on lung cancer. And the title of the paper goes, Does T ratio and young age predict long-term outcomes in Indian stage 3A and 3B operable lung cancer patients? So all of us know, and we've discussed day in, day out, that lung cancer happens to be one of the most leading cancer in terms of incidence as well as in terms of mortality. And even in the Southeast Asian and Indian region, we have very high rates. If you talk specifically about Indian region also, it is one of the leading cancer. In males, it happens to be number 2. And this is our own hospital-based registry, which shows the part where we are discussing the loco-regional spread, which is the locally advanced cancer. They happen to be a part where we can target and our treatment, to which treatment can be catered. So we know that the median age for mortality is shorter in India than the Western world, and surgery achieves best cure. Now, neoadjuvant chemotherapy has shown benefit, and we'll be discussing 3A and 3B, and this is a data which we've presented from the year 2012 to 20. So this will be based on AJCC 8th classification. So we included, patients were included from Jan 16 to December 2020, and they were followed up till December 24. These were non-small cell, stage 3A, 3B. The data was generated by a prospectively maintained dedicated thoracic oncology database. And wherever a follow-up was not possible, a telephonic conversation was done with the patients, and we analyzed the, baseline factors, survival, and prognostic factors. So what is the pre-op selection criteria? Obviously, tumor biopsy happens to be cornerstone. Then we did radiological T-stage, which was done mostly by PET. And we did mediastinal staging for end-stage, which was basically EBUS as our institutional policy. And all these patients received at least 1 cycle of plant chemotherapy. This is the study cohort. We included 101 patients, then who did not receive standard MDT, so we excluded 95. Then patient who did not undergo complete resection, we came out to 89, and final analysis was done of 82 patients. So baseline characteristics, if you see, males were more, age was 56 years, smokers was 74%, most common symptoms was definitely cough. And if you see T stage, basically there were T2, T3, and N2, a lot of them were there. Lobectomy was done in major, then we did pneumonectomy in 23% by lobectomy. And open thoracotomy was done 52, VATS was done in 32, and VATS assisted was done in 14.6. Till that time, we did not acquire robots, so all of them were either open or VATS. So DLT was given, and margin negative were 95%. The ones who were margin positive were obviously given adjuvant treatment. So NACT regimen, according to the national guidelines, majority of them were given Paclitaxel and platinums. And tumor response, as is seen, a stable disease was seen in 32, and 54% had a partial response in case of tumor. And in nodal responses, stable disease was 34 and partial response was 26. So this you see majority were in the partial response and stable disease. Now this is the center theme. What is the definition of tumor ratio? So tumor ratio is basically YPT upon clinical T. So post of HPR, when we receive that T and the clinical T at the initial. So we did a multiple cutoff like 0.75, 0.5. So if we see classically over here, here we've taken the cutoff of 0.5. So patients who had cutoff of less than equal to 5 had lesser recurrence. And this is the median overall survival of all the patients, which was 51 months. Median DFS was 38 months. And if we see, it was a statistically significant of p-value 0.5 when the cutoff was more than equal to 0.5. Similarly, we see the blue one as improved DFS as well. When we wanted to compare age did not show, they definitely showed higher recurrences, but not overall survival. And if we wanted to see the nodal positivity as well, single node or multiple nodes, single nodes obviously fared well. So we concluded that the higher tumor ratio, which is YPT upon clinical T, affected significantly with poor overall survival and disease-free survival. This was again better if we had taken the ratio as 0.75. So just an additional finding that EGFR positive tumor also showed superior outcomes, which is a debatable part in a lot of other literature. So we conclude that stage 3A and 3B carry an aggressive course, even if they are surgical treatable. And in Indian lung cancer patient post-NACT treatment, T ratio plays a major role in both DFS and overall survival. And young age did not affect overall survival outcomes in these patients, suggesting possible effect of neoadjuvant treatment across both the age group. So what is the take-home message? We know that 3A, 3B carry an aggressive course, so we need a personalized post-surgical treatment, and hence we need a clinical ratio. So we developed this tumor ratio, which predict both recurrence and overall survival. What will this do? This will guide tailored post-surgical outcomes, like chemotherapy and immunotherapy, and obviously there is a need for better prognostic markers. So there are no disclosures, and I would like to conclude my presentation. Thank you.
You would have done a T staging prior to the neoadjuvant?
Yes, sir.
And you would have done one T staging immunologically before the surgery to assess the response to NACT?
Yes,
so
sir.
what was the concordance of the C stage before the surgical surgery and with the pathological T stage? So do you have to assess the pathological T, or would the imaging give you an accurate reflection of the T? Because if we use a RECIST criteria, you don't require a pathological confirmation of the T stage for any tumor.
Okay. Sir, that's a very valid point, but what I want to address is a lot of times what we have, especially in patients who have chemotherapy, there is a lot of reaction and fibrosis around it. So we are not able to understand whether it's actually...
That is a problem if you have given immunotherapy, where there is an increase in the tumor size because of tumor infiltrating lymphocytes, which is the actual response. We have that, already we have that immune response criteria. IR criteria they are called in RECIST. So did you measure the preoperative PET-CT tumor size and compare it with the pathological T size, and was there a gross variation? In other words, can we use a preoperative imaging as a surrogate for the pathological tumor size?
Definitely, sir, that's a very valid point. We can use that as well. But for this purpose, we thought that comparing the initial stage with the HPR would serve as a better marker, because all of us know that histopathology happens to be the gold standard. So definitely even the post-treatment PET staging is also a good parameter. But when we go in terms of HPR, that happens to be gold standard. So we wanted to go a step better in that. But obviously we could have done that as well. That's a very valid point.
There are other prognostic factors. You said the lymph node positivity also leads to inferior survival. So this T ratio, did you check on both univariate and multivariate, that it was an independent prognostic factor?
So obviously we did a multivariate analysis for this. That is why that's the result which I'm producing. That's on multivariate analysis. Lymph node involvement is a well-established factor. We also have lymph node ratio also, which is also a well-established factor.
So
but,
that was also significant?
Yes, that is also significant. But for today's presentation and theme, we wanted to talk more about T ratio because even when we go to our pathologists, if we talk about pathological response or complete response, that is concerned only on the T size, not on the N size.
So one basic question. So when you say T ratio, and you're talking about the size on the surgical specimen.
Yes, sir.
That size is the gross size, right? I mean, when the specimen is sectioned and then what measurement is taken. So that could also be, as you said, could be due to fibrosis, or that could be due to reaction around the tumor. Or are you looking at only viable tumor size?
No, we are looking at only the viable tumor size.
So going by Sir's question, so I mean, the same information we can gather from the CT scans, the post-chemo size. Basically, you're looking at responders versus no responders to chemotherapy.
Yes, that is the center theme. That is what I highlighted in the first slide as well. We're not looking for something hi-fi. We are looking for a simple clinical marker which we can basically address a post-surgical outcomes. Yeah. And I agree.
So for non-responders, how many record? I mean, you may not have the long-term PFS, but out of your 100 patients, responders, and your definition of responders versus non-responders is also not RECIST. You're just looking at 50% regression or lesser.
No, sir, initially T stage and N stage, as I showed in my slide, it was done on the RECIST criteria, where I showed that they were partial response and they were stable disease. But in addition to that, we are looking for a clinical good ratio, because going back to our basic sciences in our MBBS days, we've been taught about that history and clinical examination happens to be the center theme. So we are, especially in a country like India, we're looking for a simple clinical predictor which can obviously tell us that whether we require a post-surgical tailored outcome and whether we should be cautious in a specific cohort of patients. That's what I want to highlight today. Thank you.
Thank you, Dr. Rohan. I now invite on stage Dr. Bishwajit Nath to present his paper on an institutional assessment for radiotherapy access and associated financial and logistic challenges in patients with lung cancer.
Hello, good morning to all. Now I'll be presenting about an institutional assessment for radiotherapy access and associated financial and logistic challenges faced by the patients with lung cancer in PGIMR Chandigarh. So as we know, the radiotherapy, which is uniquely applicable across all stages of the disease in the lung cancer, plays a very crucial role in the treatment spectrum. And with medical efficacy of the radiotherapy is well documented, but there is a lack of comprehensive assessment regarding the patient perspectives and overall treatment experience faced by the patient during radiotherapy delivery. In India, with its current population of 1.45 billion, there is a lack of teletherapy machines. There is a deficit of teletherapy machines, which is about 62%, which is far below the recommended. And also the ones, also as far as the simulators and brachytherapy machines goes, there is a lack of 66% and 36% in India. So we have done a cross-sectional survey among 100 lung cancer patients receiving radiation treatment at PGMR between May 2025 to July 2025, May 2025 to September 2025, over a period of 6 months. And the data were collected through structured questionnaires and various aspects of their journey, including the demographics, facility accessibility, waiting times, travel, accommodation issues, and financial burden and satisfaction level were documented. So there were largely the patients were coming from Himachal Pradesh, Punjab, and Haryana, which were far away from our PGMIR Chandigarh. And as far as the availability of the radiotherapy facilities near home was concerned, there were 51% of the patients faced issues with no availability of radiotherapy facilities near their home. And there was 27% of the patients coming to PGMR due to reputations and trust in the institutions, and 16% coming for advanced technology and treatment options. So the secondary and tertiary hospitals, they are largely concentrated in urban areas. So there are only 38% of the radiotherapy facilities which were distributed among only 10.9% of the national population, which were largely in the metro cities in the India. So this distribution in the also the distribution in the private sector facilities between the states and regions even more skewed than those in the public sector. The radiotherapy delivery, the waiting times faced by the patient were largely within 1 to 2 weeks. With few of the patients faced an issue with the radiotherapy starting. In view of there were some planning delays and there were some technical issues and there were some machine issues. And for daily radiotherapy sessions, patient had to wait for mostly for 15 to 30 minutes or more than 60 minutes. The patients had to travel for more than 200 kilometers far away from our institute. So there were 38% of the population of the survey were coming from more than 200 kilometers. And they had to travel for more than 2 hours from our institutions. So the basic accommodation challenges, like they had to stay for a long period of time to be delivered, the radiation therapy to be delivered, and many of the patients faced the accommodation challenges for radiotherapy delivery system. And as far as the financial burden was seen, the unexpected expenses were due to extra stay and cost due to machine breakdown or extra travel due to machine breakdown were about 38%. And the patient had to pay for extra drugs and products for supportive care to alleviate the side effects of the radiotherapy and also for accommodation and travel expenses. And it was 86% of all those patients, they were being covered by the government programs like Ayushman Bharat, HimCare, and state programs and chronic disease certificate programs, and the financial support for their financial supports. And there were 18% of the patients did not receive any salary during undergoing radiotherapy, while undergoing radiotherapy, and 13% of the patients had to leave their job during their treatment, and the rest of the patients had to take medical legal leave for their radiotherapy delivery. In spite of all those issues with accommodation issues or any additional costs like travel and accommodations, patient had a very good satisfaction with the treatment delivery in our institutions. Concluding, this audit highlights the substantial financial burden and logistic challenges faced by the lung cancer patients during the treatment. And the availability of the cancer care facilities in India is markedly uneven, which is being described previously. And with a concentrated advanced care specific centers leading to overburdening and strain on the resources. And this disparity adversely affects the quality of care and patient outcomes, specifically in lower middle income countries in our India. And this highlighting the need for a more equitable distribution of the cancer care resources. Thank you.
Very nice presentation. In addition to all this, you need to prevent radiation oncologists from turning into medical oncologists.
You should, just suggestion that you should have mentioned what is the cost of treatment at the institute. So that would have, better helped in understanding. Another thing is the socio-economic status of the patients who were taken and the literacy.
Yes.
also, education level also.
So the burden which you have showed is actually in spite of them being supported and funded through Ayushman Bharat or whatever scheme. And so I mean, it was actually a good opportunity for, if possible, even now if you have those phone numbers, you could actually go back and look at the financial toxicity and that out-of-pocket expense, and also you've said here like loss of job, or not only for the patient, even for the caregivers.
Yes.
And yeah, so
What you need are more PGIs. Unfortunately, we have more aims.
Yes, sir.
Which questionnaire did you use for assessing the financial burden? Did you use any validated questionnaire?
Yes, ma'am.
Which questionnaire? Was it self-framed or did you pick up some validated questionnaire?
Actually, it was self-framed.
So it should not be done in a self-framed. We have validated questionnaires.
Yes.
There's a cost questionnaire for assessing the financial toxicity or the burden, comprehensive scale of financial toxicity. So, you know, if you have to publish your results subsequently, so until you have a validated questionnaire which has been used for this study, it doesn't make much value for it.
Thank you, Dr. Bishwajit. I now invite Dr. Rohan Kapoor again on stage for his paper presentation on when immunotherapy meets the scalpel, surgical complexity and technical challenges after neoadjuvant immunotherapy in resectable non-small cell lung carcinoma, an Indian institutional experience.
Good morning again. This is a presentation which talks about the recent advances when we have neoadjuvant chemoimmunotherapy in our place. So it is titled When Immunotherapy Meets the Scalpel. So we'll be discussing about the surgical complexity and the technical challenges after neoadjuvant immunotherapy in resectable non-small cell lung cancers. So background. So the landmark trial checkmate 816, which was published in April 2022. Since then, and there have been multiple other associated trials, there's been a paradigm shift in the treatment in the past 10 years. And all of us know that approximately 20 to 25% of patients who receive a diagnosis of non-small cell lung cancer have resectable disease. 20 to 25% only. And out of them who undergo curative surgery, 30 to 55% have recurrences and ultimately die of surgery. So neoadjuvant chemotherapy can be used for treatment of patients whose diagnosis is at stages that warrants adjuvant chemotherapy. However, the absolute difference in 5-year recurrence-free survival and overall survival with neoadjuvant chemotherapy as compared to surgery alone was only in the tunes of 5 to 6 points. So neoadjuvant immunotherapy comes into role. This is particularly the checkpoint inhibitors, which we know. They have refined the treatment paradigm. And we've discussed about the checkmate 816 and 67 trial throughout the course of the conference. So all of us know that they produce pronounced inflammation and fibrotic changes, as we discussed in the previous presentation as well, complicating the surgical dissection and post-operative recovery. So we have very few limited results from Western data in terms of 2 or 3 papers, but in Indian experience, it remains limited in spite of us being a country which has a lot of burden of TB. So hence I present our institutional data on this study. So we included patients of age 18 to 75, resectable 2A, 3A, and selected single station 3B. Who was surgically resectable, who had good performance status. Surgery was performed 4 to 8 weeks. And there was a surgeon-related post-operative difficulty score, which was a 5-point Likert score, which was based on hilar dissection, adhesions, fibrosis, and deviation from the planned resection. So we included patients from April 24 to April 25. We plan to follow them up. They were of the following stages. Minimum follow-up of 6 months was done. What we analyzed was baseline factor, change in preoperative plan, and intraoperative difficulty in terms of addition to chest wall, hilar fibrosis, mean OT duration, blood loss, and mean ICU stay. So this is the selection criteria which we've already discussed. And patients should have received complete cycle of planned preoperative chemotherapy plus immunotherapy. So primary endpoint was complete surgical resection rate, and secondary endpoints included major pathological response and 90-day and 180-day mortality, completeness of resection, type of resection performed, what is the MIS conversion rates, number of pneumonectomy, chest wall resection, surgeon difficulty scores, and then obviously the intraoperative factors like blood loss, duration, and ICU stay. So what did we expect? There were a lot of unplanned extensive resection in terms of chest wall resection, pneumonectomy, and vascular recon. So intraoperative difficulty score, it was done by a dedicated team of thoracic surgical oncologists. We have only 2 surgeons who are basically catering to these surgeries. So it was a combined score by all of them. So the results, if you see that mean age was 59 years, and pre-operative plan, we have post-operative plan. Then neoadjuvant immunotherapy, nivolumab was used in 15 cases, pembrolizumab was used in 2 cases. Median time from first surgery to treatment was 47 days. And MIS conversion rate was 10 in 17 patients, which is 58.8%. So if you see, this is the chart. So I show that a lot of patients who were initially planned of lobectomy, extensive procedures were done, 2 open and closures were done. 1 was planned for lobectomy, but pneumonectomy was done. In 2 patients, chest wall resection was done. 1 was planned for lobectomy, bilobectomy was done, and pulmonary artery C was done. So complete R0 resection was in 15 out of 17. Closures were in 2 out of 7. Major PAT-CR was in 10 out of 7, which is 59%, and there were no 90-day or 180-day mortality. Pneumonectomy was performed in 1 case, chest wall resection in 2, conversion to open was in 10 out of 17 cases, which is 58. Mean difficulty score was 4.4, and hilar fibrosis was seen in 13 patients out of 17. The estimated blood loss was 206, duration of surgery was 208. We did not have grade 3B, however, we did have 3A. And ICU day was 1, and hospital duration was a median of 3. So this is the open closure. We see multiple pleural deposit. This is another second where we see it was densely adhered to a diaphragm and IPL. This is the case where it required pulmonary artery sleeve resection. Now, obviously, to complete, we did a propensity matching with patients who received NACT. We did 1:2 sampling, so 34 patients of NACT group. And if you see over here, after balancing, the standardized mean difference of less than 0.5 was seen. And if you see conversion to open, it was 76% in immunotherapy, while it was only 41%, having a significant p-value. Dense chest wall additions was 65 versus 26, significant p-value. Hilar fibrosis was 53 versus 21, again significant value, and so did operative time, surgeon difficulty score. And PAT-CR we had 58% versus 18%, which is again significant value. So we conclude that a complete resection R0 was achieved in nearly 90% of the patient following a neoadjuvant therapy, and major pathological was in 59%. And despite a high conversion rate and frequent dense addition, surgery was feasible and acceptable blood loss and operative outcomes. So what is the take-home message? That obviously more than half of the patient required a conversion from minimal invasive procedure to thoracotomy. But since we had a high R0 resection, so it is feasible surgery. And of course, we have to be prepared for tailored surgical intervention and conversions. And there was acceptable morbidity and no mortality, since we did not have any 90 or 180-day mortality. And we have to have pre-operative anticipation, and surgeons should be prepared for conversion and en-bloc resection, including vascular resection. So NAI may improve resectability and outcomes, and this is the final conclusion, that though we have more adhesions and fibrosis, but since we have more R0 resection and complete pathological response, harder the surgery, better the cancer control. Thank you.
So the response and cancer control was due to the chemoimmuno, right? Not due to surgery.
Yes.
So it's opposite of your conclusion.
Sorry.
No, so it's so basically you're saying a 53% PAT CR,
58%,
but more
sorry.
than 50% conversion rates that you have planned a bigger surgery than what you started off with.
Exactly.
Did you do a pre-op PET in these patients? Or?
All of them, sir.
So was that misleading in many situations? Because you said a lot of fibrosis, a lot of inflammatory reaction.
So
Because
exactly.
So did your I mean you went ahead with a bigger surgery? Was that because you were misled by the PET?
No. So, of course, for routine staging, we did a pre-op PET and metabolic response was checked by the post-chemo-immuno PET. So, stages where there were a lot of upstaging as well, like tumors which were stage 2 were up stage 2, 3 and 4. But ultimately, we saw pathological response in that. So this is what I want to highlight in this paper, and especially in an Indian setting, that we have to be well prepared in terms of surgical difficulty. So, but the message is that we should not think of skipping surgeries in this patient, because ultimately we're having R0 resections, because we thought that probably we would have an involved margin or a positive margin, or we went ahead to take a little extra margin, but all of these surgeries showed an R0 resection as well as a pathological, majority of them pathological response. So that's what I want to say, and that's probably the only Indian data which shows all of these things. Thank you.
Thank you, Dr. Rohan. I now invite on stage Dr. Vedant Shripad Vaidya to present his paper on the clinical profile and outcomes of rare EGFR mutation in non-small cell lung carcinoma, insights from a retrospective cohort study.
Good morning, honorable judges, respected faculties, and my dear colleagues. I am here to present my study titled Clinical Profile and Outcomes of Rare EGFR Mutation in Non-Squamous Cell Lung Cancer, Insight from a Retrospective Cohort Study. We know that exon 19 and exon 21 are most common EGFR mutations. However, there is a subset of population which has rare EGFR mutations which are other than exon 19 and 21. So these mutations are known to respond poorly to standard TKIs. They are rare population with limited previous data and lack of randomized trial. So with this background, we came with the objective of studying the specific clinical pathological characteristic, molecular landscape, treatment pattern, and survival outcomes of patients with non-squamous cell lung cancer with uncommon EGFR mutation. It was single-center retrospective study carried out. The patient population included between January 2015 to May 2025. The data was collected from the institutional records, and EGFR mutation testing was carried out by 2 different modalities in different time period. 2015 to 2021, it was conventional PCR. 2022 to 2025, it was droplet digital PCR. Analysis was done using SPSS version 27.0. So out of 817 patients tested together in this time period of almost a decade, 34 patients were identified with uncommon EGFR mutations, which is approx 6%. And if we look at the different diagnostic testing which was used in different point of rate, conventional PCR came with the 2.9% positivity rate for the uncommon EGFR mutation, whereas droplet digital PCR had increased the number almost 1.6 times to 4.6%. Coming to the clinical features, females accounted for 41% of the population with median age around 59 years. 88% had stage 4. Most of them had a performance status of 1 and 2, and biopsy was a diagnosis methodology used. Adenocarcinoma, as expected, is the most common histology here, and brain mets at baseline were around 20%, which is generally seen with the EGFR other studies. So out of 34 patients tested for a rare EGFR mutation, we identified 5 exons. The single mutation was found in 41% of the population, whereas 59% had a compound mutations. And among those compound mutations, 2 patients had a ALK positivity as well. The compound mutation detection rate were almost doubled with use of droplet digital PCR as compared to that of conventional PCR. 64% against 33%. And if we look at the individual exon mutation percentage-wise, so in the descending order, the rare EGFR mutation comes like exon 20, 18, and 14 with 68, 62, and 3% respectively. Compound mutation positivity rate was seen 20% with exon 18 and 20 together, and exon 18, 20, and 21, it was 13.5%. Of the 34 patients, 16 patients received EGFR TKI, of which 75% received gefitinib, and only just it was 2 patients is receiving the afatinib and osimertinib. With this, we achieved patients achieved a median overall survival of 16.7 months. So if we look at the comparing the conventional and droplet digital PCR, we found that uncommon EGFR mutation positivity rate increased 1.6 times with use of droplet digital PCR as compared to conventional PCR. Rate of compound mutation positivity doubled with that of use of droplet digital PCR. And the predominant use of gefitinib, which is like almost 75% of that use, was guided by the limited access to other agents. But we know that gefitinib has limited clinical activity against the most common EGFR mutations. Our results were consistent with the previous studies done. The 3 of the studies are from India. Chowgule et al. is 2013 study where they found the exon 18 and 20 mutation rate as 7 and 3%. Indonesian study says 1 to 10%. There is a study from Tata in 2020 where they found 6.5% of uncommon EGFR mutation positivity rate, which is similar to our study. And their overall survival also were quite similar, 15.8 against that of 16.7 months. Then there is 2022 abstract by Manan Prasad et al., where they found 99 patients with uncommon or compound EGFR mutations in India. And there they reported a median OS 11 months, which was lesser than which we found in our study, which is 16.7 months. So with this, I conclude the use of droplet digital PCR increases the identification of uncommon EGFR mutation, as well as the compound EGFR mutations. Most patients received gefitinib due to limited access to other agents. Thank you.
Thank you. Did you try chemotherapy when you had an uncommon mutation?
Yes, sir. The majority of the population ultimately end up in having.
You did not show that data at all.
This study, we highlighted just the use of TKIs and the limited availability, because we have the data from Lux Lung post-hoc analysis where the afatinib use showed the median progression-free survival of 16.5 months.
I'm not talking of the TKI. In many situations, when you have something which you cannot target, you can add chemotherapy. So that's a very well-known. The second thing is, how do you know that the poor survival is only because of the uncommon mutation and not because of an evolving mutation?
True, sir. Not just to add to that, the compound mutation was associated with ALK in two patients, and as well as there is a positivity with common mutation also. The compound mutation had a positivity with the common EGFR mutation, which is TKI sensitive. So definitely the survival is contributed by this as well, sir.
Yeah. So what's the main limitation of your study?
True, sir.
What is the main limitation of your study?
So
do you think on the same sample, if given a chance, you can look at uncommon mutation in a better way?
Yes, sir. The methodology of testing itself is one of the limitations here.
Yes, you would, yeah. Is afatinib not available in
it's not available in the free of cost. The medication which I am talking about is free of cost, which we provide to the patient at Jipmer.
Because we have a generic afatinib, which is almost the same cost as gefitinib.
So we provide medication that's free of cost. So with that, we are achieving the survival of 16.7 months.
Okay, thank you.
So it's an institutional hospital policy, something like that you have to just give which is available.
So those patients who are affordable, definitely they can.
But afatinib is...
So what madam is asking you, did you have patients in whom if they were affordable, you gave something different and they had a different survival?
So 2 + 2 patients received afatinib and osimertinib in this uncommon EGFR mutation board. Thank you.
Thank you, Dr. Vedant. I now invite on stage Dr. Vishnu Kumar to present his paper on the impact of TP53 co-mutation on clinical outcomes in EGFR mutated advanced non-small cell lung carcinoma.
Good morning, judges and delegates. Myself, I am Dr. Vishnu Kumar from Nizam's Institute of Medical Sciences, second year residents. My title is Impact of TP53 co-mutation on Survival in EGFR Mutated Metastatic Adenocarcinoma Lung. EGFR mutation seen in 30 to 40% of the metastatic adenocarcinoma, and it is the most common targetable driver mutation, and the impact of TP53 co-mutation and survival is inconclusive in the TKI era with the available equipoise evidence. To address this research gap, this study was planned. My aim is to evaluate the clinical impact of TP53 co-mutation on treatment outcomes in patients with EGFR mutated metastatic adenocarcinoma. My objective is to determine the frequency of TP53 co-mutation and to compare the progression-free survival and overall survival in patients with EGFR mutation alone versus EGFR TP53 co-mutation. This is a retrospective study done during the May 2019 to April 2024 in Department of Medical Oncology, NIMS, Hyderabad, and this was approved by Institutional Ethics Committee. My inclusion criteria is newly diagnosed metastatic EGFR mutated adenocarcinoma who are more than 18 years age and who are received at least one cycle of systemic therapy, which include chemotherapy or TKR both, and data available in the medical records. Methodology is data were collected in the case record forms, which includes demographic, clinical, laboratory details, including EGFR mutation along with TP53 co-mutation and treatment and follow-up. And for continuous variables, mean with standard deviation and median with range was used. For categorical variables, frequencies and percentages was used. For survivals, Kaplan-Meier curve survival analysis was used. For comparison, log rank test was used. Coming to the results, total 620 patients were diagnosed with advanced non-small cell lung carcinoma during the study period, and out of which 55% were adenocarcinoma. Among them, 152 patients underwent EGFR testing, 80 patients via PCR and 72 patients via NGS, out of which 16 patients were detected as TP53 along with EGFR mutation. And the next common mutation in these patients is ALK followed by PI3CK mutation. Coming to the baseline characters, median age is 59 and 2/3 of patients were males and also are smokers, and 85% of the patients were with ECOG PS of 0 to 2, and most common metastatic site is pleural effusion, bone followed by lung followed by adrenal, and among them EGFR most common subtype is 19 deletion in 50% followed by L858R mutation. And the patients received, 2/3 of patients received Geftinib with or without chemotherapy, and followed by 13% of patients received Afatinib and Osimertinib, and one patient received chemotherapy because that time the report was not available, so we have given the chemotherapy. Coming to the survival, if we see the first graph, the median OS at 95% confidence, median PFS at 95% confidence interval is 17.6 months. Compared to the EGFR alone mutation, there is a numerical benefit of 2 months with p-value of 0.41, which is statistically not significant. And the overall survival, 21.7 months in TP53 alone group, with compared to the EGFR alone, 30.4 months with p-value of 0.84, which is statistically not significant. The frequency of EGFR TP53 mutation in this study is 22%, and compared to EGFR alone, there is no difference in PFS and OS. One study where Agarwal chart done in USA, the frequency is 62% and associated with inferior overall survival. In another study, Germany, the frequency is 49%, and it is associated with negative outcomes in terms of survivals. And in our study, less frequency may be due to ethnicity and baseline characters, and less number of patients underwent NGS testing, and there is no difference in PFS and OS in this study because the TP53 characteristics and allelic ratio was not mentioned. And in one study, Anurag Mehta 30% showed co-mutation, which is found in relevance with our study, and the recent evidence from the FLARA-2 trials showing exploratory analysis benefit of combination therapy in PFS and OS compared to the osimertinib alone. However, most of the patients in this study received TKI alone. The limitations of my study is small sample size, less number of patients underwent NGS, and TP53 mutation characterization were not done, and it's a retrospective study, and most of the patients received TKI alone. And to conclude, I would like to conclude with this. Our study showed no difference in the survival in EGFR TP53 co-mutated patients when compared to the EGFR alone mutated patients. The future directions, more number of prospective large sample multicentric studies are needed to assess the prognostic value of TP53 co-mutation in contemporary
Can you
era.
please go back to the third or the fourth slide which you showed the flow chart? Hold here. You had 620 patients, 341 were adenocarcinomas, but you said only 152 underwent EGFR testing.
Yes.
What happened to rest of them? Here, see this.
Yes,
341 were adenocarcinomas, out of which you said 152 only underwent EGFR testing. So what happened to rest of the 200 patients? You tested in all of them?
No, sir, only 150. With the available data, we found only 152 patients. EGFR testing was done, out of which 80
So
patients.
in all of them you tested for TP53 or no?
No, sir, only 72 patients only tested, those who underwent NGS.
Okay. In those 72, you are comparing it with the whole group, or between in that 72 who are TP53 positive and TP53 negative with the same technique?
No, sir, actually the 152 underwent EGFR testing, 80 patients via PCR and 72 via NGS. In those NGS only, TP53 was identified, sir.
Yeah, so in that group only you are doing the entire analysis.
Yes, sir.
So you use the same technique and you are in that EGFR positive with TP50. All of them are EGFR positive.
Yes.
With and without TP53 you are studying.
Yes, sir. Yes, sir.
Okay, so but your survival figures are also for this group only?
Yes,
Or
sir.
for the 72 patients only?
Yes, sir. Yes.
Oh, okay. Why do you think the survival is the same?
Maybe it is a small number of studies, sir. And we have used TK and chemotherapy.
You use chemotherapy in all of them?
No, sir. Only one patient received chemotherapy.
That doesn't should not, one out of 72 should not actually do anything. So in 16 patients, out of them, only one you have used. Okay. In the other patients, did you use chemotherapy in those who were?
In EGFR patients, we use TK with chemotherapy in few of them. Around 30% of the patients, they received combination therapy, sir.
So I'm also a little confused. So 152 had the mutation? No. 152 patients had EGFR. How many total patients had EGFR mutation?
152, sir.
152. Okay. And that 72 you had done NGS. So I think your conclusion from this whole thing should be that if you do NGS, about 22 or 25% of patients you will find co-mutations.
Yes.
And we know co-mutations carry inferior prognosis, but in your situation you're not finding, maybe because of low sample size.
If we include
And you also picked up an ALK in a patient with EGFR mutation.
Yes, sir.
So how did you treat that patient?
Same, we will use the...
So if you have both EGFR and ALK.
No, ALK, we have to give the ALK target first because it has lot of...
You gave dual TK?
Sir?
Did you give dual TK?
No, sir, single TK.
Single TK?
Yes.
So would you change your practice if you find out TP53? You're giving TKIs, right?
Yes, ma'am, but close monitoring is required because lot of early resistance and... Here it not. In future, we have to follow up closely, and if any emerging resistance.
You don't believe your data?
No, sir. More prospective studies should be required.
Right. Thank you.
Thank you, Dr. Vishnu Kumar. I now request the judges and all the presenters to gather on the stage for a group photograph. We now begin session 1 of day 2. To chair this session, may I warmly invite our esteemed chairpersons, Dr. Nidhi Gupta and Dr. Ramba Pandey. We begin with a case-based panel discussion. For this, may I invite the moderator, Dr. Virendra Tiwari. I also invite the distinguished panelists, Dr. Srijan Shukla, Dr. Abhijit Talukdar, Dr. Divya Khosla, Dr. Mastan Bhasha, Dr. Krishna Mohan, and Dr. Nageshwar Reddy, to kindly join us on stage.
The panel that we are going to discuss is about locally advanced lung cancer, and we have only half an hour. I think that is very short a time to discuss. I have compiled 3 cases, but I think at the max we can do 2. So without taking much time, I'll start. I would like my panelists to be short, may not be sweet, but that's fine, but try to be to the point so that we can finish as much slides as possible. So this is the first case, 65-year-old female, no comorbidity, good effort tolerance, presented to OPD with CECT, right lower lobe mass, biopsy, squamous cell carcinoma. Dr. Divya, so suppose now we'll consider that we all are in same OPD and we have an MDT. So Dr. Divya, how will you go ahead? What other staging workup will you ask for?
So first is the baseline investigations need to be done, and the pulmonary function test, and the next would be a PET CT to rule out the distant metastasis. I would like to see if only CCT chest has been done or CCT abdomen has also been taken, but PET CT workup. And if you're talking about locally advanced, then an MRI brain would also be done.
Okay, so yeah, point well taken. So that is what we did. We did PET CCT, we did MRI brain, and at the same time we did cardiac as well as pulmonary function test also, so that there is no delay if we do one after another. Now this is PET CCT. Mediastinal window. Large right lower lobe mass. Lung window, rest of the parenchyma was okay, no metastatic lesion. Fusion images, no significant adenopathy, but FDG avit, right lower lobe mass. Dr. Abhijit, so now you have seen imaging. What is your opinion, resectable or not?
Yeah, at the first go, it looks like a locally advanced right lower lobe mass. So as you said, performance status is good only. So we would do a bus mediastinal staging.
Okay.
Also, and of course.
No, my question is resectable or not?
It is close to the vessels, so it is a locally advanced disease. So upfront
little
is
bit
not resectable.
difficult right now. So suppose if you are planning for a surgery upfront, like with this imaging, what will be your approach? It will be minimally invasive or open?
So personally, for these kind of central lesions close to the major vessels, I would do an open approach.
Open approach, yeah. Yes. So the idea to show is that to begin with, tumor may be bulky, but as you said, we'll need some sort of treatment, then we'll look how the approach changes. So Srijan, Dr. Abhijit pointed out one thing, we'll do invasive mediastinal staging. Do you agree with that in such cases?
Yeah, 100%.
So we did that, and EBUS is negative, it is N0. Now, these are the management option. Dr. Mastan, so suppose now how will you go ahead, Dr. Mastan? Yeah.
So if it is
EBUS we did, it is MRI, PET CCT, clinical T3, N0 stage, fit, PFTs are also okay, resectable lesion.
Okay. So we need to do EGFR mutation.
Okay.
So if it is EGFR mutation, they can go upfront surgery.
Hmm.
If it is EGFR wild type, they can consider for NICT along with immune check inhibitors, followed by surgical assessment.
Okay. So I'll come back to surgeon again. Dr. Srijan and Abhijit, both of you. You did EBUS. Now Dr. Mastan says that he wants some sort of treatment. So you did EBUS. The report is either N2 or N0. So either it can be clinical T3 N0 or clinical T3 N2. Is your management going to change?
In this patient, it's a fairly large mass. At least we are not considering upfront surgery as a modality here. This patient needs neoadjuvant therapy. Only purpose of mediastinal staging here is to rule out N3. Whether it is N0, N1, N2, I think in all three aspects patient goes
PET
for.
negative, so are you expecting it to be N3? Very few subset of patients, yeah, you are correct, maybe less than 5% may turn up into N3. So that is one point you want to rule out with invasive staging.
That's all.
Dr. Abhijit, anything else which
because the primary tumor, the location of the tumor is close to your major vessel. That's the concern that we have.
So EBUS, one thing he said, rule out N3. Another thing is, even if patient turns out to be N2, you need to prognosticate patient. That is very important, because after neoadjuvant chemo plus IO, we have seen there is a significant downstaging at the nodes also. Close to 30% patient becomes PCR. So you will not be able to counsel patient or tell what to expect from treatment. T3 N2 has a different outcome compared to T3 N0, whatever said and done. Now I'll come to our medical oncology colleagues. Dr. Krishna, neoadjuvant we all agree to as far as current imaging and patient profile is concerned. How will you go ahead now? It is a squamous cell carcinoma and locally advanced.
So so neoadjuvant part, which in the clinic, which we have been seeing, my surgeon is also there, my surgical oncologist. So we are of late we are eager to incorporate immunotherapy after seeing the results of the surgical outcomes. So wherever possible, we try to incorporate the immunotherapy, not only
so chemotherapy plus immunotherapy. But do you want to do molecular analysis? What Dr. Mastan said. Squamous also.
That is the baseline, of course. That's
squamous
where
also.
we start. Squamous cells we do EGFR, because we have seen patients who harbor EGFR mutations in squamous cells, about 10% of them.
So suppose patient turns out to be EGFR positive, then will you consider chemo or chemo plus osimertinib like Newadura?
We'll do only chemotherapy.
Only chemotherapy so far. Okay. Dr. Nageshwara, Dr. Reddy, so now one of the drawback of chemo-immunotrial is that there is a significant dropout rate. Around 20% of patients do not, reach to the operating table. So what is your practice and how much, what is the dropout rate that you see in your practice? Is it 20% lower or higher?
This particular protocol, neoadjuvant chemoimmunotherapy, at our center, we are following it only for few patients only because of the affordable patients. But given a chance, even that 20% dropout rate, I would like to go ahead with neoadjuvant chemoimmunotherapy only.
So thing is that these are all multi-center trials and drop rates of around 20%. So idea is that to counsel patient what to expect and what is the protocol of treatment. They need to know that neoadjuvant chemotherapy, immunotherapy followed by surgery, followed by adjuvant, that we'll see later. But that is the complete treatment protocol that they need to stick to. So sorry, there are some, it's not has come well, they very well. This is post chemo plus immunotherapy. Patient received 4 cycles of platinum doublet chemotherapy, but with 3 cycles of nivolumab. This is the imaging lung window, and this is the fusion images. Tumor has almost disappeared. Now Dr. Mastan, patient is in MDT, and you see this lady now, patient says that I am very comfortable, I am happy. I have, I see red report also, there is no visible disease. Now what will you tell patient?
I think we can do ctDNA possible, and also I think we have to consider for surgery, it seems.
Okay, so
Even
is
though
there
after
any role of organ preservation as we talk in all other site here also? Patient is affordable. She says, I can take immunotherapy for 1.5 to 2 years till I'm tolerating. So that is not a problem. So is there any evidence for such treatment? Dr. Divya?
I mean, you consult the patient if the patient preference is not to be operated, can be
No, she's
continued on
saying whatever is best for me,
So
go ahead and
best
do.
is
Go ahead and do
should
that.
go to surgeon.
But I'm affordable for immuno. I can take if that is working.
So best is to take surgeon's opinion.
So there is no evidence so far to continue, on immuno alone, even if patient has responded very well. Our both chairpersons are also, I think, radiation oncologists. So, madam, now suppose this patient comes to OPD and says that, can we go for anything non-surgical? Then how will we go ahead? Can we post chemotherapy plus immunotherapy? Is CTRT acceptable treatment option? If she says that no, I don't want surgery.
First option will be surgery only because we do not want to compromise with the treatment outcome. But if the patient doesn't want to go for surgery, then we'll have to wait some time and then start with the definitive CTRT. Immunotherapy, so far
So
we are
it
not
will be
giving
like
along
a
with
de
the
novo case,
radiation.
full dose chemotherapy, matlab whatever CTRT we usually give to a.
Yeah, if the patient is not agreeing for radiation or surgery, then so far we are not giving immunotherapy in the concurrent setup.
Okay.
So we have to go for
chemotherapy
the CTRT.
and chemotherapy and radiation. So thing is that why I have put this case that there is no evidence for organ preservation so far. Even if there is a good response, we need to go ahead and operate. Now, Dr. Abhijit, you saw scan pre-treatment. You said will prefer open. Now, how is your approach going to change, or is it going to be open only?
Because squamous cell central tumors, my philosophy is always central tumors. At this experience, I always go for open.
So even with this imaging, Srijan?
Because there is a response, but
Okay.
temptation is always there
perfect.
to go
It
for
is-
vets, but I
yes.
prefer open.
Okay. Srijan?
I think we'll give an attempt of minimal access in this patient because there's a good response. Actually, on the upfront imaging, the bronchus intermedius takeoff after the upper lobe seemed very close, but after neoadjuvant, it has completely gone away. So I think minimal access should be possible in this patient. Obviously, if we know that it's neoadjuvant chemo-immuno, if you find it's a lot of fibrosis there in the hilum, conversions are known to happen.
Yeah, so we should be ready for conversion, but minimal invasive approach can be attempted.
And I think
open
both
is
these
also
points,
acceptable.
both these scenarios should be told to the patient before we initiate any therapy.
Yes.
So one was, we have to tell the patient that if there's a chance that you'll have complete response and still the treatment will remain surgery, so don't be in the mindset. So they have to be told that from day one.
Yeah,
and the
correct.
second is that it might be an open surgery, but it's still all right.
Chances of conversion are there. Now, Dr. Krishna, patient has undergone surgery, and this is HPR, T0, N0. Complete response at primary, and obviously nodes were negative, turned out to be negative on final dissection also.
So, presuming that there are no molecular alterations.
Yeah.
So
Negative for EGFR, negative for ALK.
So if I had given nivolumab to start with, I will stop here.
Okay.
And keep the patient on observation. Because I think many of the times, I think I'll make up which protocol to follow is I think planned on day one only. I think I would want this report is there, even if this report is not there, if you have started with the 4 cycles of neoadjuvant.
So you are saying checkmate 81C6, patient has received neoadjuvant nivolumab, good response, stop. Okay, no financial constraints. Still. Dr. Nageshwar.
Yes, sir said one scenario. The next scenario is the patient had received pembrolizumab. I would like to continue the full 1 year.
But Nadeem too had given 6 months of nivolumab.
I mean, this, it's about 816 protocol. Checkmate 866 protocol. According to Checkmate 816, whatever treatment the patient has received so far, it's totally fine.
Nadeem is only phase 2 study.
Yeah. But there also, if you see 3-year OS was 82%. If they say that why not continue nivolumab for 6 months, 1 year more, I may get better survival.
There is no comparison between the both Nadeem and Checkmate 816.
So PCR, MPR, you tend to, if there is a discussion with patient, we can stop. But if there is no response, would you continue if this was T2, N0?
Probably I'm
tempted to continue. Yeah. And obviously, ctDNA will have a role there, I think, if it is persistently positive.
Though we still don't know how to interpret and use it in clinical practice.
So that is a coming up evidence. Yeah. Now we'll go to second case. This is a 53-year-old male with right side chest pain. Again, good general condition, good effort tolerance. Right upper lobe mass, biopsies, adenocarcinoma. This is PET CCT. But on inquiry, so the point is that history taking is very important. You can see imaging, but when we ask patient, he complain of tingling over ulnar aspect of right upper limb. Now, Dr. Abhijit, PET CCT MRI NF, or will you ask for something else?
Yeah, because it's a apical tumor, we would like to see the apex, so we need a MRI to find for any nerve involvement.
Correct. So that is what we did, MRI neck with focus on brachial plexus. And this is the report, C8T1 root and trunk division infiltrated by tumor through the chest wall. Now, Dr. Divya, Srijan first, what do you think, resectable, unresectable?
Before that, what was the biopsy?
Adenocarcinoma.
Adenocarcinoma. So, first point is, if I see a apical tumor, the first thing I'm thinking is small cell and not adeno. No, so I have to be very sure that is adenocarcinoma.
Adenocarcinoma, yeah.
Because the size is does not suggest locally advanced, but the local invasion does. Patient already has symptoms, so the brachial plexus is infiltrated. Not thinking about upfront surgery. Also discussing with my patient if we can have a non-surgical route altogether.
Not thinking of upfront, but after some sort of neoadjuvant, are you contemplating with infiltration of?
So with brachial plexus invasion, not really. Difficult, I would prefer a non-surgical approach in this patient.
The idea is that unresectable upfront is unresectable, resectable is resectable. With any sort of downstaging, it's very difficult to say that unresectable is going to become resectable. So Dr. Mastan, how will you go ahead now? What will be the treatment here?
I think we can
MRI brain negative, good functional status, no other significant comorbidity.
Okay, so if it is surgeon says unresectable, we can go for concurrent chemoradiation.
Chemoradiation. So now this is like Pacific. So will you ask for an NGS here before starting chemoradiation?
Sure, definitely will ask.
So here also more so because histology is adenocarcinoma, better to know EGFR and ALK status at least, and chemoradiation. Now, Dr. Reddy, so patient has received chemoradiation. After that, there is a good response. Now, what is the next line of treatment for this patient?
Yeah, and see, it depends on, again, the driver mutations. If there aren't any driver mutations, then I would like to consolidate with durvalumab following the PACIFIC trial. If there are any accidental mutations, say for example EGFR, then would be using LARA protocol with osimertinib. And of course, if there is ALK mutation, there is no good data. But given the poor progression-free survival, I mean it's around 6 months only, I would like to consolidate out of, I mean this is not as per the guidelines, I would like to discuss with the patients either immediately after CTRT or at progression. I would have like to have a discussion regarding the ALK inhibitors.
Okay. So depending upon NGS, we'll consider for immunotherapy or other targeted therapies. Now, if we see resectable superior sulcus, we have very old trials. One is intergroup, another from Japan, which is that neoadjuvant chemoradiation brings a downstaging followed by surgery, gives a good outcome, decent outcome. Now, with immunotherapy, do you think that that treatment option or treatment line is going to change with chemoimmunotherapy? So idea of NACT-RT was downstaging. There they found that major pathological response and PCR rate was close to 50%, which we see with immuno also. So doctor, I need everybody's opinion. So do you think there is a need to change in treatment protocol from NACT-RT to NACT-IO followed by surgery for a PANCOST?
Yeah, extrapolating the data, we can integrate both chemotherapy and immunotherapy in the neoadjuvant setting before definitive surgery or chemotherapy.
Yeah, madam.
Right.
Here, we always start neoadjuvant CTRT with the intent that we may escalate it to definitive CTRT if the disease does not become resectable. So I think with that intent of giving neoadjuvant CT immuno, again then you are at a crossroad if the disease is not resectable.
Suppose it doesn't respond that well, definitive RT option is...
Yes, we can do it, but as per the available
Yeah,
data.
so I agree. There is no clear-cut guidelines so far that we can change treatment. But that is one thing I think worth attempting after discussing with patient, because anyway your definitive radiation option will still be there if patient is not responding that well in PanCoast also. So now this is a last case. I think we'll finish faster than I expected. Right lower lobe. This is only imaging. I have not put clinical details and all. Right lower lobe, 7 and 4R, both positive. Dr. Mastan, multistation N2. Okay. We have ruled out EGFR ALK status.
So in case of multistation N2, I think better to go with definitive CTRT instead of surgery. So I think we need to discuss in MDT and we need to take surgeon opinion also, because for multistation N2, I think
surgeon has already started nodding. That's fine. Dr. Divya, your opinion. It's
So multistation N2, preferably concurrent chemoradiation.
Chemoradiation. Srijan?
So I think I think the most common issues or debates happen in our MDT when we are deciding treatment on PET CTs. We should not be deciding treatment at PET CTs.
7, 4R positive.
So once we've ruled out N3, it's multistation N2, it is resectable N2, and clearly the surgery is going to be a lobectomy.
Yes.
If the patient is fit, I think neoadjuvant chemo-immuno is now the standard of care. I know multistation N2 is the risk factor here that we are worried about, but with chemo-immuno, we have not dissected that subgroup that it's going to be, it'll have worse prognosis, but I'm not sure if neoadjuvant chemo-immuno with surgery will fare worse than definitive CTRT.
Dr. Abhijit, your opinion?
I also agree that we should rule out N3 disease by EBUS, and this is a low volume disease, though multistation, so we'll give neoadjuvant treatment, and then if response is there, we'll go for surgery.
I agree with the Srijan, because the relatively common thing which we discussed in our tumor boards.
So neoadjuvant chemo IO can be attempted, followed by response assessment and surgery. So there are a lot of, yeah.
I think patient age, performance status and preference, everything has to take in consideration.
So patient is tumor resectable, unresectable, and patient fit or not fit. This should be an upfront call, and then only we can embark on treatment. Not fit for surgery, unresectable, there is no question about neoadjuvant chemotherapy, immunotherapy, and then reassessing.
Dr.
So
Virendra,
that point is not.
One small doubt, Prashant here. So, I mean, multi-station, I agree. Just want to add on, if it is multi-zone, multi-station, how would the panel look at it?
Yeah.
I mean, Virendra, you don't have to take the questions.
I will not. Yeah.
I think lymph nodal size also matters.
Yeah, so 2R is also positive. Right lower lobe, 2R positive.
So what 2R becomes is 2R for us will be the highest mediastinal lymph node. Now the issue is in the ISLC R0, R1, R2 description, if a highest mediastinal lymph node is still positive after neoadjuvant therapy, that is, and even if you have removed it and it's still positive on your final histopath, it's not an R0 resection. It's one of the criteria that makes it R uncertain. So if it's 2R positive and it's the highest lymph node that you're going to address surgically, you have to make sure that it's negative after neoadjuvant therapy, or you need to discuss strongly for a non-surgical definitive chemo-RT with immuno approach.
Same thing, I will continue, Dr. Divya, Dr. Mastan, and both chairpersons. So right lower lobe, 4R, 2R positive, how easy it is to irradiate?
With With the technology available, you can easily spare the rest of the lung parenchyma because it's easy to do a VMAT, volumetric modulated arc therapy. You give constraints and you come out with the best plan. So if it is positive, I would rather go upfront with chemoradiation rather than neoadjuvant chemo-IO.
Yeah.
I too agree with Dr. Divya. Given this situation, I think definitive CTRT upfront should be planned. And with the technology available in radiation, nowadays there is upcoming role of SBRT for the primary. If there's a small primary in the lung, SBRT to the primary and mediastinal IMRT. So both we can combine. In fact, we are doing a trial also in our center. So where we are giving the SBRT to the primary and mediastinal IMRT. So that can be combined.
Separate field, you are saying?
Yeah. So both can be treated separately.
So I'm not sure whether there will be any significant benefit of skipping the intervening part, giving RT to 2R and then
here
primary.
The benefit is in the sparing the intervening lung parenchyma. Because here we can see the lesion is quite peripheral.
Yeah, it is peripheral, right lobe peripheral lesion.
So most of the time when the lesion is peripheral and we have to treat the mediastinal lymph node also, the intervening lung also receives a significant dose and that is the main concern.
So that is what even
why this study is coming up.
Yeah, so we have come across in MDT with our radiation oncologists that it is difficult for them also. And we have enough evidence which says that now, now it is not about single station, multi-station N2. It is about resectable versus unresectable. The whole treatment thinking or thought process in MDT is slightly changing. If patient is affordable, I think still with the current evidence, chemo-immuno is an acceptable option. And what Srijan said to R, if that turns out to be positive, are uncertain. When you are giving radiation, in that are uncertain because there is a small chances that a node higher than that also can be positive. But when you are giving radiation, you are also covering till that point only. So treatment, outcomes stay same, whatever you choose.
I think in such a situation, there's a very important role of mediastinal restaging after neoadjuvant immunochemo. Because if still your the highest mediastinal lymph node is positive, then it should definitely not be considered for surgery. But how feasible a mediastinal restaging is after you've done an initial staging, I mean, that's up to you.
Yeah, Srijan, restaging, you have done EBUS.
Correct. So mediastinal restaging after neoadjuvant therapy, when patient has a response, we don't need it.
Yes.
The only exception to that would be that highest mediastinal node. There's no other, if that node was your concern to begin with and it was positive on the initial staging, that's the staging. That's the node that you'll be worried about. The other issue is with chemo-immuno, you can have pseudo progression of the lymph nodes, which the MDT should not see it as a progression because of the immuno.
Yeah. So sensitivity of restaging mediastinum is poor. Whatever we do, either it's EBUS or mediastinal sampling, it is close to 30 to 40%. And what Srijan said, if disease is resectable and nodes, even if there is a pseudo progression in your surgical field, there is no worth in pushing for a restaging. But suppose on PET, follow-up PET, you find a contralateral mediastinal node, then you need to restage to rule out whether that is positive or negative. Thank you very much. It was a very good discussion. Thank you all for giving inputs. Anybody from audience wants to ask to our panelist and chairperson, please go ahead. Thank you. Thank you. Thank you.
I request the panelists and the moderator and the chairperson to stay back on the stage for a group photograph. Thank you for such a thought-provoking discussion. We now transition to the next part of the session, which is a debate. To moderate this debate, I call upon stage Dr. Madhaba Ananda Kaur. I also invite the participants of this debate, Dr. Darlong L.M. and Dr. Prahlad.
Good morning, all. I am thankful to Prashant, and I am sorry first that I am delayed. This is the first debate we should have taken before this case discussion, locally advanced. But this is heartening to see so many delegates, senior faculties, and highly accomplished faculties are there. This is a never-ending chapter in lung cancer management. This is end to disease. This is with newer development with radiotherapy and surgical technology assessing accessories. Now very clear that is the multimodal management for end to disease is there, stage 3 end to disease. But single out if you do, that is the only single zone multi-station or multi-station single zone nodal disease, surgery versus radiotherapy. Still few people think that like surgeon, I am a surgeon, I should not go to a bias like you can cure everything with the surgery. And one way we are telling that the tumor biology you have to address, simultaneously with the tumor volume factor. Another locally advanced single node but infiltrating the vessels. And multi-station, single zone, nodes, non-bulky, bulky, lot of things are there. We should listen both accomplished faculties and the professionals, one is a surgeon, another is radiotherapy. Then we'll discuss and how they are taking this with all evidence, how we'll take a decision, then up to first, the oldest and the senior most, Dr. Darlong. No need to be introduced. There's a first role of surgery for end to disease. Darlong, first stage.
Good morning, everybody. Thank you, Prashant, for having us here and for such a wonderful meeting. First of all, thank you. The first meeting, the panel discussion has already shown how important surgery is. I think that makes my work much easier also. And so I'll be speaking on the role of surgery in N2 disease. Greetings to you from Rajiv Gandhi Cancer Institute. And so it's important, I mean, basically the history of N2 disease. It's important that this is an MDT disease. I mean, how important the group works. So the best way to go back is to go to the Swiss group. This is the SAC group, which is basically MDT based and it's funded by the government, where all the oncologists work together. SAC 16 denotes basically the study of N2 disease in lung cancer and followed by the years, that's slash. So I'll go into the SAC 16. In 96, it started. SAC 1696 is a phase 2 study wherein they looked into 3A disease, where the 5-year overall survival was 37%. This was in 96 study. So it's very, very good for those times. And mind you, this time the pneumonectomy rate was 49%, a mortality of just 3%. And that needs to be taken note very much. What was the outcome? Obviously, they found that downgrading to N0, N1 was a good factor, as well as R0 resection. With this thing in mind, they were prompted to go for more local aggressive radiation. So they added radiation to 2 study groups, that's basically in the 1600 and the 1601. So if you see to 1600, in that case, they gave chemotherapy followed by radiation, and they went to surgery, and the other arm, they went straight for surgery without radiation. In this group, they found that there was a downstaging in terms of R0, end stage, and PCR. And again, the pneumonectomy rate was still 3%. The mortality did not increase. And if you see the OS benefit, there was no benefit of adding an adjuvant RT in the pre-op setting. So it was known to them, the small group, but well-organized group, that there is no role of trimodality management in entry setting. So it was basically a bi-modality treatment right from the beginning in those times. So this is the 1601 trial. Again, this is something they extend beyond that. They went to more inoperable disease of those times, the T3, T4, N1, N2, and even some cases of N3 disease. They were again subjected to chemotherapy followed by radiation, and again went for surgery. And this is the schemata you can see of the patients in that small group. There were some N3 disease, and maximum of them were basically some T3 and T4 disease. And this is again, if you compare with 1600 and the two things, there was again pneumonectomy rate of 21%. This was quite high of those time, because it was only 96 that the Ginsberg group came up with the what we call lobectomy as a standard of care. So in those times, pneumonectomy was fairly common. And they did not find any difference in the EFS and the OS in the two group when they compared the more extensive disease, some case of N3 disease and T4 disease. So in a follow-up of 10 years, surprisingly, there were still some cure rates up to 20%. And the main cause of that was basically second primaries. And they still went on to have some recurrence even after 5 years in the local site. So this group again pulled up all those cases of their study, looking at specifically T3, T4 disease and N2 diseases. And in these, they found about 159 cases. And again, from where they pulled out, and they found that the resection rate in this advanced disease was 80%, and a 7% 90 days mortality rate. It was very, very much fantastic in those days, with a very high rate of pneumonectomies, and a 45% 5 years overall survivor. If you see the lymph nodes group, if they showed that N01 is the one which fared maximum good amount, and N2 diseases were quite less, so we cannot, multiple station N2 were less, so we cannot make an inference, but they did not, the curve did not drop down very drastically. So there was definitely a role of surgery in those cases. And by 2022, this is the SAC group, what they compiled all those data, that is a Swiss group, and they supported surgery for stage 3 lung cancers. And this is the picture that we always keep getting, the EORTC intergroup trial, wherein surgery has been condemned 49.7%. And the selection was such that they were mainly unresectable stage 3. We all know the definition of resectability is still debatable, and most of the cases of EORTC group were unresectable. And even in, we all know it, the benefit of surgery was null because of the high mortality. The surgeons killed their patient because of a very high mortality with pneumonectomy at 26%. This is something very, very shameful to us, but I think this is something we have not been doing more anymore. It's very, very less nice. And in the subgroup analysis, they found that lobectomy was definitely the standard of care. It was recommended for stage 3 setting in those areas. So is it relevant for me to talk about this in the era of immunotherapy? The Pacificas trial has shown that, they can get 42% OS in those unresectable disease, but we need to be looking into it very carefully, because about 983 patients were enrolled, 713 was randomized, there was a drop-off of 27%, and these are not represented in this graph. So 42% is a bit too high, it is much lower in the real world. So now comes the immunotherapy in the era of surgery. I think this is one area where the medical oncologists do agree now that surgery is the way ahead in resectable lung cancer, and this is how we can improve our care. And the question is now, is it just neoadjuvant or is it perioperative? This is something the debate has to continue on. We have the Checkmate trial, neoadjuvant chemo-IO. This is the purely neoadjuvant, which with nivolumab, it shows a median follow-up of 68.4 months. And the 5-year OS we have it basically 65.4 versus 55%. This is quite a huge jump. And we have the Nadim perioperative chemo-IO. This is something from the Spanish group, and this was specifically looking into the multi-station N2 disease. They have a 5 years PFS of 58% and a 5 years OS of 63.0 in the intent to treat population. And we have the Keynote 671, which has shown an OS improvement result with pembrolizumab at a median EFS of 57.1 month and a 48 in 4 years. OS rate was 68% over 56 months, and has been approved basically by FDA. We all know it. And this is an EGAN trial. We are still looking into it. The primary endpoints are EFS and PCR. EFS at interim analysis at 2 years was about 63%. And if you see in terms of the PCR, pathological response, it was 17.2% over 4.3%. That's a difference about 13%. And we have the Checkmate 77T. It's basically the perioperative setting of using nivolumab 30 months EFS was 61% versus 43. We're seeing a trend for longer EFS and an OS trend in these cases. And again, we have the Neodora, this is the TKI setting in which we use asymmetry in the peri-op setting. And the results are still awaited, but they all are showing a very good trend. So this is just a schemata to see, all those trials involved. You can see here that mortality, which we all are scared about, is quite on the lower side. It's 1%, 0%, 3%, 6%. We don't have it for a checkmate or for a Neodora. And if you see the R0 resection rate, they're quite high, 83% to almost 100% in the Nadim group. And pneumonectomy rates, I think this is something which everyone is worried about. You can see here they have come to about 16%, maybe about 3 to 4%, but still the mortality has been very much well taken care of. So I think the challenges of surgery in N2 is basically that we need to have a definition of resectable N2, which is the main thing which falls on the surgeon, and it is this thing which will decide how we go about. And it definitely is a state of mind. It is very, very much surgeon dependent. And I would conclude by saying that resectable stage 3 disease is very much center dependent. It's important that the confidence of a clinical oncologist is there on the surgeons. It is highly surgeon dependent, and obviously it's always the MDT which decides how we go about it. In this way, like with the Swiss group, which has given such good results, that we can be having great results in such a scenario. Thank you.
Thank you. Thank you, Ralan. Now we'll listen to the radiotherapy. Dr. Prahlad.
Thanks, Prashant and Sandhya for fantastic hospitality. I had a great darshan yesterday, and unfortunately we couldn't come back last night. And when I was at the darshan, and it was 4 a.m. by the time we got back, and I was telling Harita ma'am also that, you know what, this morning debate doesn't suit me. Let me just concede to the surgeons. I will give the victory to the surgeons last night. That was my thought when I was not yet back at 4. But then this morning, after tasting the prasad in the morning, again, I have renewed vigor, and we radiation oncologists will not give up so easily. And I will. Oh. Sorry, the font has changed. I hope not much has changed. So I'll start with an opening remark. I'll save some time. The opening remark is that randomized controlled trials, phase 3 randomized controlled trial is only way to overcome selection bias. All other studies that we will hear or discuss or deliberate about will come with an inherent selection bias. And Dronacharya, this is way back, now we are back to Mahabharat, we are watching Mahabharat, we are watching Kurukshetra again. And in Mahabharat also, back in Mahabharat, there has always been a bias. It was a foregone conclusion that Arjun was the better archer, and Karna was not given a fair chance to prove himself. But that is previous Yuga, this is Kali Yuga. Karna did not have data, but we radiation oncologists, we have data. So what is the first data? I am taking new trials which are published after 2005. The first one is a randomized trial. This is the EORTC randomized trial, where they gave neoadjuvant chemotherapy, induction chemotherapy, followed by either chemoradiation or surgery for the N2 disease, stage 3A N2 disease. 90% of the patients underwent surgery, a good number of patients also, 150 patients in each arm, 90% completed surgery. Post-op radiotherapy was even given to 40% of the patients, and still, if you look at the median and the 5-year overall survival, it was only in the range of about 15%. And after neoadjuvant chemotherapy, when they were randomized to either CTRT or surgery, the EORTC trial concluded that surgical resection did not improve either progression-free survival or overall survival. So then comes the second, thank you. Next comes a little more modern paper. Again, we are paying attention to the 5-year overall survival, sir was also mentioning that it is a very modest 14-15%. Then comes a little more modern paper in 2009, where they said chemoradiotherapy, and then after neoadjuvant chemoradiotherapy, then we will randomize surgery versus no surgery, surgery versus continuation of chemoradiotherapy. So this was cisplatin, etoposide, and radiotherapy. And then at that time, after the 45-gray radiation, we stratify at that time, and we randomize at that time in the surgery versus no surgery arm. 200 patients in each group, which is a good. This trial was completed satisfactorily, and the median overall survival here again slightly improved. The median survival was not different. So when you took stage 3 N2 disease, and we gave upfront chemoradiation and we continued the radiation, or after chemoradiation we took up for surgery, again if you look at the overall survival, no difference in overall survival between the two arms, and the 5-year survival had slightly improved to around 30%, 25-30%. This was 2009. And then we come to a little more modern data, 2015, another phase 3 randomized trial, where they were taken resectable patients were randomized after. This was after neoadjuvant induction chemotherapy, 2 cycles. This is in the paclitaxel arm, in the era, paclitaxel era. So cisplatin, paclitaxel, then chemoradiation with cisplatin, vinorelbine. And then when this was sadly not completed, still 120 odd patients on each arm were analyzed, and after about 6 years, when they did the 5-year overall survival and progression-free survival, they said there is no difference in 5-year overall survival or progression-free survival. It is in the range of around 40%. The 5-year survival was 34-40%. And what they said is slowly with improving chemotherapy and radiotherapy and surgical techniques, both strategies are equally acceptable for this good prognosis group, that is those patients who underwent chemotherapy and then chemoradiation, and then they were randomized to either surgery or completion of chemoradiotherapy. So taking into account all of this data, what NCCN, and we all follow NCCN, at least most radiation oncologists, we all heavily dependent on NCCN, and this is 2026. This means this is what is going to get carried forward up to next year. They said evaluate, do a thorough evaluation, and once you have identified that it is an N2 disease, you can see if it is N1, no questions asked. If it's operable, please operate. If it's not operable, you can still go for definitive chemoradiation, which is category 1 recommendation. And if it is N2 disease, T1 to T3 N2 disease, category 1 recommendation, definitive chemotherapy with radiotherapy, followed by durvalumab and or osimertinib based on the driver mutation. So what is this study, this durvalumab study? So now we have 5-year overall survival outcome from the PACIFIC trial, and here again we are talking of unresectable. So these patients, they were passed off from their MDTs as unresectable patients, and then they were taken up for chemoradiation followed by durvalumab versus no durvalumab. And here for the first time we see the 5-year overall survival is in the range of, okay, the 5-year overall survival in the blue curve is in the range of around 43-44%, and the 1 and 2-year survivals are good, 80 and 60%. It is better. So the addition of adjuvant durvalumab adds overall survival benefit rather than just chemoradiotherapy alone in the unresectable patients. Now, do we have real world data? Real world data of 1,800 patients. Again, here you can see the 12-month overall survival. 1-year overall survival is 90%. So this is only of this was published in 22. There are several more real world data which have shown that 1 and 2-year survival in the unresectable chemoradiation followed by durvalumab. These trials have shown very good and promising improvement in overall survival. What about the osimertinib? This is the LAURA trial. This was discussed earlier. Again, chemoradiation followed by osimertinib, and in this the overall survival, the 3-year overall survival is 85%. 3-year overall survival is 85%. This is really very promising. So this is what you would see normally. This is a 2025 paper from Japan. This was before the PSM, the propensity score matching. So even there is bias, when you just look at it, surgery versus chemoradiotherapy, this is how it would look. Surgery would obviously look better even in a recent 2025 paper, after the propensity score matching. So this is what randomization does. When you randomize, you overcome the selection bias, which would inherently creep in when because you would take up only the resectable cases, and then they would fare better. And after propensity score matching, it shows that chemoradiotherapy is okay, just as good as surgery. And even in this study, the patients who were not taken up for surgery were either because they were N3 or they were multi-station. So even in a non-randomized paper, there is a bias that only non-resectable patients are being taken up for chemoradiation. And even in these patients, here you see that the red and the green curves, that is the surgery and the surgery plus or the chemoradiotherapy with durvalumab, these curves are hugging, the survival curves are hugging, and if they both are better than chemoradiotherapy alone. So now we discussed a lot about the 9th edition, and this addition of single station N2 is what single station N2 node is called N2A and N2B, and that has got all the surgeons excited about the new inclusion of this in the staging. But I would like to remind all surgeons that we read this full paper of from the IASLC and their recommendation to the AJCC for changing the staging, and what they have clearly said, and in nowhere in this paper does it say surgery. It only says the prognosis is better, and it is a well-known thing in any cancer. Lesser number of nodes, even in breast cancer, 1 to 3 nodes is better prognosis, that is N1, 4 or more is N2. Similarly, in lung cancer, single station N2 node has a better prognosis. So it is a purely prognostic term. It is not yet predictive. So what do our experts, majority of them are here. Prashant Garu is also here. What does Prashant Garu say? So he has hosted us, he has provided us great food, he has provided us darshan. So now we have to listen to him. What does he say? So he says, on the right we will look. So consider surgical resection, or we'll start with the left. In the N2 disease, chemoradiotherapy or surgery. So chemoradiotherapy or surgery are the available treatment options for stage 3 disease when there is N2 disease. And we have to take into account all the number of stations, number of zones, bulky, non-bulky, all of that was discussed earlier. And so the 100% agreement is that surgical resection in bulky unresectable disease should not be considered. So bulky, unresectable also, if there are multiple zones, multiple nodes, should not be considered. We all know in a TB endemic country like India, it is so hard to identify whether it's a single station or multiple station. PET scan is not reliable, the SUV values are not reliable. EBUS, EUS is hard to perform. A combination of EBUS, EUS is rarely performed. And so that bias cannot go away. Even the bias has not gone away across several international papers and international guidelines. Even in several international guidelines, if you see all those guidelines there, the line for radiation is longer than the line for surgery, but still always in spite of randomized trials showing, there is still always, if there is a potential to resect, still consider resection, and even then you can see the radiation line is longer across several international guidelines. Lastly, we do not have data for the functional outcome after surgery or radiotherapy in stage 3 setting. So I've just pulled out functional outcomes and the drop of functionality, the FEV1, ME, MMEF 25 by 75, and they have shown that in the SBRT group, the functional loss after radiation is much less than compared to surgery. So alveoli saved is better than alveoli resected. So in conclusion, randomized trials of N2 disease have not shown superiority of surgery over radiotherapy. The trials favoring surgery have a selection bias, I have already shown. Chemoradiotherapy plus durvalumab or any ICI, still other ICIs have not yet been proven, but at least chemoradiotherapy plus durvalumab may be equal to surgery. N2A disease, which I have already mentioned, is hard to prove, is only prognostic. As per AJCC right now, it's only prognostic, it's not yet predictive. And chemotherapy with radiotherapy may preserve organ and function. And so finally, in this yuga, this is now Kali Yuga, and if this is the new Kurukshetra and if the new Kurukshetra is N2 NSCLC, Krishna will be saying N2 में मत करो वत्स. Thank you.
Thank you, Prahlad. See, two things you have said that now I am putting both of you that you have both reviewing the literature and giving the evidence, but what is the current scenario like immunotherapy, radiotherapy, surgery? No one has discussed the patient factor. If both are deciding keeping patient factor, tumor factor, biology factor, you present someone, Dr. Dalang, you want to defend few points, what Dr. Prahlad told? Give it 2 minutes. Let's say you tell, then one more chance to Dr. Prahlad, then I will conclude what I'll give my expert opinion and any things from the also audience will take. Patient factor and tumor factor, local. Yeah.
Patient factor, yeah, we all know, I mean, N2 setting is basically, it's a locally advanced. So the patient has to be basically fit. I mean, in terms of functional cardiac pulmonary function evaluation, he has to be fit. And in terms of the nodal thing, this is where, I mean, we still need to define find a definition of what is potentially resectable. We know single station N2 is very clear. Discrete nodes are very clear, but potentially, I mean, the limb nodes which are bulky on the bulkier side, infiltrative, we all know these are not resectable. So this is what we need a consensus on basically from the surgeon side to clearly define what is a potentially resectable N2 disease.
So only 2 rebuttals. First one, in the intergroup study, you said those patients who underwent lobectomy did better than the pneumonectomy. The mortality rate in the intergroup trial was almost 20 to 25% in the those patients who underwent pneumonectomy. So they said those who underwent lobectomy did better. So what my rebuttal is that if you have removed your bad patients who underwent pneumonectomy and then you want to compare, you have to remove the bad patients from the radiation side as well. You cannot remove only the bad patients from the surgery. The patients who needed pneumonectomy had bigger tumors, had worse tumor close to the hilum, which required a pneumonectomy. Such patients would have done badly in the radiation also. So you can't only remove from one arm and compare and say that if patients who did lobectomy would have done better. And in the immuno arm, it is okay. In the immuno arm of the checkmate Pembro, you have shown good data worldwide of 5-year survival reaching 50-60% also, 50-60% also. So again, there is a bias. These are operable patients, and the data that I showed for durvalumab is unresectable. The data I showed for osimertinib is unresectable patients. So there already the bias has already crept in, and therefore naturally the resectable patients who go for chemoradiation, go for surgery after immunotherapy, the survival will be better. So unless there is a real randomized trial of chemoradiotherapy durvalumab for even single station or multi-station versus chemoimmunotherapy followed by surgery, until that randomized trial, which is obviously hard to conduct and get, there will always be intrinsic biases from the surgical team, radiation team, and multidisciplinary. If it is a democratic multidisciplinary tumor board, good. If it's 1% dominant, it's hard to get in favor of radiation. Thank you.
Thank you, Dr. Prahlad and Dr. Darlang. No, this is another one. See, overall, if you see, this debate will go on and going on. And all the trials that's not specifically compare, if you will see what is the surgically we have improved, like VATS, multi-port VATS, single-port VATS, and simultaneously that is the other side, this is the specific IMRT, SBRT, and targeted radiotherapies. Because both, I am not discussing the chemotherapy, this is the loco-regional treatment, given the controversy like radiotherapy or surgery. Depending, this is when we are discussing all these things, never these papers they discuss what is the patient condition is there. And what even single station disease, how infiltrative it is. All this reflects the biology simultaneously. easy to resect or easy to give the radiotherapy to kill the disease. As long as you know, this is the how that tumor biology, how we can kill by the radiotherapy, that is the zero cycle, all these are there. But keeping all chemotherapy, giving radiotherapy versus surgery in N2 disease. Target is if you are going for the R0 resection, then that has the advantage. Whether when we are going for the R0 resection by surgery, which nodes we can do the R0 resection. And simultaneously, laterally, when we are giving the radiotherapy, what we are doing that radiotherapy is effective, bulky or non-bulky disease. If bulky, how effectively it is curing the disease or giving chance to the next. If you will see, this is a very clear non-bulky single station operable disease. This, the all trials have shown that the surgical intervention has the better survival. No doubt this is all the things. But coming into the multi-station, bulky disease. That way that controversy going on, this is the trials, this is depending upon the patient extent of the disease, bulkiness, you know. Most important, then you have to individually discuss with the patient. And you have to be very open, what is your complication rate, what is the post-RT sequelae or complications, how much the survival we are giving, and how free we are talking to our patients. Then these conditions where this type of controversy, this is a typically tumor board decision with shared division with the patient. That is still this is going on. We have to wait, like Dr. Sonil is here, what is the thing the TMS going on? Sonil was doing one sort of trial, that is the N2 disease. We have to assess the tumor biology factor is there, tumor factor is there, patient factor is there. And individual expertise. When we are talking like that, we can do the surgery clearance, how expert we are. Someone is very good in the single port they can do, even open we are not so sure, but the trial is saying we will to do this disease, resection. That way, this is the, with precision era, you have to approach very judiciously and without any conflict of interest, how better we can give the benefit to the patient. Thank you so much, and thank you both the panelists. And as long as the N2 disease, this is a multidisciplinary approach. Leave it chemo immuno, surgery versus radiotherapy, depending upon your setup, your multi-professional sitting together and how freely you are discussing and what best you are giving to your patient. Each individualize the patient, patients, at times you feel that patient telling you decide, sir. Then there's coming to bigger responsibility to you both sit and how you communicate with each other and your centered data. It's not like I will follow the Delhi IMS, I will follow TMS. Your data, where you are practicing, what is your expertise, how you are giving the best to your patients. That is the carrying the result. Thank you so much. Next.
Thank you for such an interesting and insightful session. I request the moderator as well as the presenters of the debate to stay back on the stage for a group photograph. We now move on to session 2. I invite the chairpersons, Dr. Ravi Shankar and Dr. Tejeshwar, on the stage. I now invite Dr. Vanita Narhonha to talk about a subject that requires thoughtful judgment and individualized care.
Thank you, everyone. A thoughtful discussion. I'm not sure I'm up to this task, but thanks, Prashant and Lakshmi, for this invitation. So in the next 15 minutes or so, I will talk about managing patients with compromised PS. And now this is something that we see all the time in the clinic, and we don't really have great data for it. Okay. So learning objectives in the next 15 minutes or so is defining patients who have compromised PS and what are the causes. We'll talk a little bit about the treatment evidence for chemotherapy, IOs, and targeted therapy. We'll see what the official guidelines say, and then we'll try to understand how to apply the decision-making framework. So what is poor PS? Now, all of us are very familiar with this. It's kind of a catchphrase, right? Poor PS. What does that include? So traditionally, it would be PS3 or 4, sorry. PS3 or 4, but it has kind of spread to this PS2 as well. So PS2 to 4 is traditionally now considered a poor PS. And how common are poor PS patients in our practice? So globally, about 30 to 40% of patients with non-small cell lung cancer who present have a poor PS. But what about our patients? So we had done this analysis of about over 3,000 patients who presented to Tata Memorial. And here as well, we found that 34% of our patients had PS 2 to 4. Now, my sense is that this is a bit of an underestimation. A lot of our residents, and some of my residents are sitting there, a lot of our residents write PS1 even though you see that the patient is in the stretcher. So we kind of like write it as a, just routinely or a cut-paste thing. So my sense is that it's more than 30, 35%. I don't know. Ullas, stop chatting. How many of your patients have PS3, 4 in your practice? But yeah, my sense is it's about 40 to 50%. But what we have, I think, in the literature is 30 to 40% have PS3 to 4. So poor PS, again, is like a catchphrase, right? What causes it? And it's critical to differentiate whether this poor PS is because of the disease or because the patient in general is frail. So is it because of disease, the tumor burden, patient has acute dyspnea, fatigue, etc.? Or is it pre-existing frailty? Is the patient just has a lot of comorbidities, cachexia, old age? If the patient is an older patient, so in the geriatric age group, then performing a geriatric assessment is very helpful to find causes that are treatable and to intervene in those causes. So bottom line is that performance status is heterogeneous, and not all poor PS patients are the same. So let's go and let's look a little bit at the evidence that we have for giving systemic therapy. So particularly focusing on chemotherapy and immunotherapy in these patients. And all of us have seen patients who come in on a stretcher, and we always have this knee-jerk reaction to give a little bit of chemo, right? Maybe carbo UC2 or like low-dose paclitaxel. And I was looking through the published papers, and I realized that in 2013, we had written this case report for patients who came in with PS3 and had benefited from some low-dose chemotherapy. This was the landmark randomized trial done by Lillenbaum's group, in which the question was whether these patients who had PS2, now so this is PS2 patients considered as poor PS, do they benefit from intensification? So they had compared single agent PEM to PEM plus carbo. It was multi-centered randomized study in 205 patients. All patients had ECOG PS2 but adequate organ function. And they found that the combination significantly improved response rate, median progression-free survival, and median overall survival. So this was a positive study, but the drawback was that there was, of course, a significant increase in toxicities, and there were several treatment-related deaths. So this, although a positive study, did not actually catch on in practice. What about PS3 and 4 patients? So now the randomized study was done in PS2 patients. What about PS3 and 4 patients? So we had audited our practice because again, in our practice, we give a lot of low-dose chemotherapy trying to salvage some of these patients. So what actually happens to them? So between Jan 21 and March 23, there were 127 patients who had PS3 or 4. 87, so majority were PS3, so 87% were PS3, but 13% were PS4. And we tried to divide them based on whether they had molecular markers, positive or not. So molecular positive, molecular negative, and the molecular plus minus is unknown, or patients who had a molecular driver but were too sick or unable to afford receiving a biomarker-directed therapy. So maybe just focus on the molecular positive patients, and 100% of them managed to receive systemic therapy. 64% of them had escalation of therapy, and their median OS was 17 months. But in the patients who were able to get an escalation of therapy, they did better. So they had their median OS was 24 months. This is a study done by Prabhat Malik at AIIMS, in which this was a phase 2 study, in which they took patients who had PS2 or greater. But again, these were patients who had specifically tumor-related poor PS2 or greater. So they had to have a CCI, so the Charlson comorbidity score had to be low, had to have a good albumin, good hemoglobin. So a lot of these factors which would eliminate somebody who was in general frail because of non-tumor related things. 87% of these patients had PS3 to 4. These patients were treated with low-dose weekly paclitaxel for 3 doses, and they found that the PS improved in about 50% of those patients. So 24% PS improved by a month, and 15% of the patients improved beyond that. So total about 50 of them, 50%, half of them improved their PS. Their grade 3-4 toxicities were very manageable, only in 20% of patients. Median PFS was 3 months, and median OS was 6.8 months. And in general, the quality of life improved for these patients. So we have taken this concept forward, and now we are currently conducting this phase 3 randomized study. This is an ICMR grant has been received for this. And the study is being conducted at AIIMS and TMH. Would be very happy to collaborate with anybody who would like to join. So in this, we are taking patients who have PS2 or greater, and then patients are being randomized to receiving the same impact program. So they receive weekly paclitaxel for 6 doses, and then if their PS improves, then they get intensified to pacli plus carbo. If their PS doesn't improve, they continue on pacli. And the other arm, which is the interventional arm, is seeing whether adding immunotherapy helps these patients. So they start on Nivo as well as Pacli. They receive weekly Pacli. And then if their PS improves, they continue, they get carbo added. So they get Nivo, Pacli, and carbo. And if their PS does not improve, they continue on Nivo and Pacli alone. So switching gears from chemotherapy to immunotherapy. So does immunotherapy work in these poor PS patients? And most of the pivotal trials have only included PS 0 to 1 patients. Several systematic reviews and meta-analysis have been done. Real-world series have been published. Some PS2 patients can benefit. Outcomes are definitely worse than patients who have good PS, but there's a lot of heterogeneity. There are toxicity rates that have been reported, but certainly much less than for chemotherapy. So acceptable toxicity rates. But when we talk about giving a chemo-free regimen, but giving aggressive immunotherapy like combinations, so Nivo-Ipi, they have very high toxicity rates in these poor PS patients. We had published a case report way back in which when immunotherapy first came, we always thought this was an attractive option. And, the patient is quite compromised. Let's try immunotherapy. And then we realized it doesn't work because it needs time to work. But it does work in some of the patients. We had published our real-world data for patients with poor PS who received immunotherapy. The median OS was very poor, so 2.9 months. But there was a proportion of patients. So you can see there seems to be a flattening of the curve. So at 1 year, 27.3% of patients were alive, and they seemed like they continue to be alive. PS2 patients did better, median OS of 3.7 months. PS 3 to 4 patients had a median OS which was less than 2 months. And this is the landmark study, the Ipsos study, in which they studied whether single agent atezo would work in these patients who had a poor PS, and we had conducted the study at TMH as well. Dr. Kumar is the third author. So they had two cohorts of patients, patients who had PS 2 or 3, or patients who had good PS but was 70 years or older. So they had to be older and have PS 0 to 1, but have comorbidities or other reasons for which they were ineligible to receive platinum-based chemotherapy. So all patients in this study were ineligible for platinum-based chemotherapy. And these patients were randomized to single-agent atezo or single-agent chemotherapy, so vinorelbine or gemcitabine. So they found that single-agent atezo led to a significant improvement in median OS, an improvement in response rate, less toxicities, and better quality of life. So this is some of the data that we have for chemo and IO. What about the official guidelines? So NCCN clubs PS2 with 0 and 1. So all recommendations for patients with PS2 are the same as the recommendations for PS 0 to 1. And you can see, so for patients with adenocarcinoma, patients with PS 0 to 2, they recommend all of the usual options. So chemo IO, combination chemo IO. For PS 3 and 4 patients, their recommendations are best supportive care, or you can consider atezo based on the Ipsos study. And similarly for squams, it's the same recommendations, the chemo IO, or for PS 0 to 2, PS 3 to 4, either best supportive care or single agent atezo. Coming to the ESMO guidelines, so ESMO has separated them out. So ESMO guidelines also gives like a broad kind of a cafeteria option. So PS2 based on the PD-L1 status, so PD-L1 low, they recommend either platinum-based chemotherapy or single-agent atezo or single-agent chemotherapy. PS3 to 4 with any PD-L1, whether it is adeno or squamous, they recommend best supportive care. In patients who have squamous, for PS 0 to 2 and a high PD-L1, they recommend single-agent IO. Patients who have PS2 and low PD-L1, they recommend platinum-based chemotherapy. 3 to 4, any PD-L1, they recommend only best supportive care. So putting the guidelines together, and in the text of all of the guidelines, ASCO, ESMO, NCCN, all of them say that the data is very limited, recommended. So this is kind of our cop-out option, right? We have multidisciplinary discussions, recommend individualized decisions, but bottom line is test for drivers, regardless of performance status. Both ESMO and NCCN recommend best supportive care for PS 3 to 4, but NCCN additionally provides the option of single-agent atezo in PS 3 patients. Targeted therapy is much easier, right? It's not toxic therapy. For patients who have oncogene-addicted disease, targeted TKIs can produce rapid and meaningful responses, improve the PS. So biomarker testing in all patients is mandatory, and outcomes in these patients are worse because these are very sick patients, but all of these patients benefit. So we had earlier tried to develop a predictive score to try and understand which of these patients would actually respond. I'll skip over this in the interest of time. And we are currently conducting this randomized control trial. So we know that an oral TKI works, right? And a patient who comes in even with PS4, they will benefit from an oral TKI. But for example, you have a patient who has PS0 and EGFR mutant lung cancer. In this day and age, in general, we may not consider single-agent oral TKI, right? There are always a combination option. So what happens to these patients who have PS3 and 4? They have all been excluded from the trials. So we are trying to understand that in these patients who have poor PS, and they get started on a TKI, and then their PS improves to 0 to 1, maybe, would those patients benefit from intensification? So in this study, we are taking patients who have poor PS. We start them on an oral TKI. And then if their PS improves by a month or so, then they get randomized. If the PS doesn't improve, they are screen failed. If their PS improves, they get randomized to continuing the TKI or to intensification with addition of carboplatin. We are currently actively recruiting at 2 sites. And Dr. Lakshmi, I hope that we will very soon be recruiting at Tirupati as well. So finally, just to put things together, how do we decide treatment for a patient who has poor PS? So always look for reversibility. So look for dyspnea, pain, brain mets, vertebral mets. Try to improve all of that. And if that improves, then take the next step. Always test for molecular drivers. If that is positive, start a TKI. If that is negative, and if the patient has a high PDL1 and perhaps disease-related PS2, consider single-agent IO. If the PDL1 is low or unknown, you have a whole variety of options ranging from single-agent chemo to combination chemo to single-agent ICI or to best supportive care. So couple of seconds more, when not to treat aggressively, when the poor PS is because of irreversible comorbidity, multi-organ dysfunction, very limited life expectancy, prioritize best supportive care. So key takeaway points, poor PS patients are heterogeneous. You have to treat the patient, not the performance status number. Always test for drivers and treat with TKIs. Single agent ICI can be considered. Chemo, either single agent or doublet, can palliate symptoms and can improve survival, but with greater toxicities. And early palliative care and honest goals of care conversations are essential in these patients. Thank you.
Thank you, ma'am. I request Dr. Vanita ma'am and the chairpersons to stay back on the stage for a group photograph. We now move on to a panel discussion. I invite the distinguished panelists, Dr. Krupa Shankar, Dr. Harita, Dr. Karan Sood, Dr. Sujit Kumar, and Dr. Preeti Agarwal. I also invite on stage the moderator, Dr. Ullas Batra, to talk about where we stand on EGFR mutated lung cancer. This panel discussion is sponsored by AstraZeneca.
And I think we have a panel of distinguished panel here. Welcome you all. So just to give, in between experience to some newbies also, can I also invite a very new junior faculty, Dr. Senthil Rajappa, also to come and join us on stage. I'm sure Dr. Senthil will learn immensely from the experience that he gains today by sitting amongst us. And don't be scared, Dr. Senthil. We are all friends here. We will all talk about science today and nothing else. Okay, fantastic. So, managing EGFR mutant non-small cell lung cancer prior to 2025 was very easy. Life was very easy. You can actually just, it was almost like piece of cake or a piece of laddu for Dr. Senthil, as he normally says. But now in 2025, managing EGFR mutant non-small cell lung cancer is actually like this, or maybe like breathing in air in Delhi. And I typically said, ये EGFR mutant नहीं treat करना है आसान, इतना समझ लीजिए, आग का दरिया है और डूब के जाना है, or more, you're living in Delhi, you have to breathe the air every day in the winter months. So we'll start with a case over here. We have a 55-year-old male who is a non-smoker, diagnosed at stage 4 non-small cell lung cancer, lung carcinoma. Site of metastasis right lung with contralateral lung nodules, mediastinal supraclav lymph node with bone metastasis, something which we see almost every day in the clinic. So I'll start from here, Dr. Harita. What is it that you normally do? Do you do a single gene testing? Do you do an NGS for everyone? How do you do? Since the coupons are available. Fantastic. So I think NGS is something which almost all of us will say. So I have 3 questions to discuss, because the first one was, what is it that we try to gain between a single gene versus NGS testing? Let's say I do a single gene testing and everybody else does an NGS testing. Do you get to see more EGFR mutants? That is one. If I do a hotspots panel versus a CGP panel, do I get to even get more? Second question that we will discuss is, what about liquid biopsy and tissue biopsy? And the third we will obviously discuss about is role of co-mutation. So let's just ask Dr. Karan. So my first question is, let's say I am doing a PCR based testing and you are doing an NGS testing. Same patient comes to us, same patient comes, or 100 people come to us, 100 people come to you. Do you think you will detect more EGFR mutants, or what is it that you are gaining by doing an NGS? Only for EGFR I am talking about. Forget the ALK and everything right now.
If you're doing an NGS, then we see more co-mutations. We see a better landscape of how the EGFR is.
No. I am asking simple. Out of 100 people, 30% of people will have EGFR mutant, right? If you do a PCR, do you get 25? If you do an NGS, do you get 35?
So NGS definitely will give you more information than a PCR.
Fantastic. So you will pick up numerically also more numbers? Okay, Sujit?
Sir, I think with current testing platforms, I think the mutations will be the same, apart from the co-mutations which will be there like P53. I think the type of and quality of mutations are the same. I had a personal experience when we had to send because the EGFR was not there and we had a larger panel, it picked up EGFR duplications and all, but I think most of the times the EGFR quality quantity remains the same.
The quantity remains the same, the quality remains different. Okay, fantastic.
So I think we detect numerically more as well.
You will detect numerically more. So when in doubt, ask Dr. Rajappa. Dr. Senthil, in your little experience of treating EGFR, what do you think it is?
I think it definitely picks up more than what you would get in a PCR.
Okay. So this is what we found out. This was a very initial study of 500 patients. And so what happens is in PCR, you have only the specific primers for that. So definitely numerically, it will pick up more mutations. Definitely co-mutations it will pick up. More towards the exon 20 mutations it will pick up, but some rare deletion, insertion 19s and some other it will pick up. Also depends upon whether you are doing a COBAS or a, the other one, the Therascreen or something else. So definitely there is no doubt that the NGS will pick up 8 to 10% more EGFR mutants numerically, quantity and qualitatively. Now Senthil, this question goes to you. Numerically we have said this. Now let's say I'm practicing in Delhi, and I am, and everybody is very fond of sending a Guardant and a Foundation. So between a good hotspot panel versus a CGP, what is the advantage that, something like this will give you, small, medium, large, and if you do an Excel panel, between a large and an Excel panel, will it make a difference?
As long as the depth of sequencing is adequately done in a hotspot panel, you will pick up almost the same as what you would get in a CGP.
Absolutely spot on with that. So, so for me, a good hotspot panel, if done properly, with a good depth and breadth of coverage, will pick up almost the equal amount of mutations as will be picked up by that. A CGP will not really add in the number of exon mutations because the mutations are considered towards 18 to 21. If you've done a good panel, it should not. It will definitely give you more co-mutations and stuff like that. So that is there, which is we are here. Second comes about liquid biopsy. Madam, I'll start again from this side. Liquid versus tissue. Do you ever send a liquid biopsy? And if yes, when? When you don't have tissue or something. Dr. Karan?
Sir, ideally tissue biopsy is good, but I would like a baseline liquid as well.
So you think liquid will add to more number of, again, numerically it will increase, because that's something which I really wanted to discuss today.
So, sir, first of all...
Not in EGFR. Now I'm talking about the entire spectrum of disease now.
Sir, looking for the tumor microenvironment, my tissue biopsy is more important. But how does the tumor actually behave? How is it shedding, and what is the baseline shedding? I really want to know it up front, because that's how I stratify my patient.
Okay, so this was a study by Sanjay Popart's group, which basically again found out that if you do both a tissue and a liquid together, you definitely have 32% additional alteration which were picked up by the liquid NGS. 17% alterations more were picked up by tissue NGS. So if you do both, definitely you will pick up more alterations. For EGFR, I'm not saying, this is again for more alterations that we are talking about actually over here. Definitely we would probably want to do I showed you small, medium, large. We will definitely want to have a Coke along with that also. And so tissue liquid definitely picks up. Okay, let me ask Dr. Sujit. Liquid positive, tissue negative.
We should treat whichever is
tissue
positive.
Positive, liquid negative.
Definitely, because the low volume disease may not have.
So we treat if either one of them is positive, it doesn't really make a shit difference. If one is positive, treat. Definitely both are important, but you know the cost of the treatment, only legends can actually afford that amount of money. What about the role of co-mutations? Senthil, I'll ask you this. So let's say you have a TP53 mutation. Back in DM, Dr. Bapsi madam used to ask us, is it prognostic or it is predictive? So presence of a co-mutation, is it a predictive factor towards something, or is it a poor prognostic factor? That's all that it is all about.
I think so far the data is strongly towards the fact that it is prognostic.
Correct.
There seems to be some emerging data that it might be predictive, but personally I'm not very convinced that it is predictive at this point in time.
Absolutely. So, I mean, I would totally agree. It is more of a poor prognostic factor. Whether it will predict towards going on towards a Mariposa regimen or a Florida regimen depends upon which symposium are you talking about. Since I didn't know I was speaking for a symposium, I'm not saying anything right now. But right now, to me, a co-mutation is almost like a bad thing. Like you have a popcorn, you have a Coke, you have a burger and your fries also. Poor prognostic factor, predictive, I don't know as of yet. So these are the three diagnostic dilemmas that I had. Single gene versus liquid versus short spot. Definitely NGS is better than single gene testing. CGP may not be better, especially for numerically, but yes, quantitatively, if you have to look for co-mutations, yes. Liquid versus tissue, liquid plus tissue is definitely more better than either alone. Role of co-mutations, definitely poor prognosis factor. This is where exactly we stand over here. So let's come back to this case now. This patient has basically come back with we got an NGS done for this patient, and it is L858R with P53 mutation. Sujit, do you do, I think, since you are a proton center, you will do MRI for everyone. For the physicians also sometimes over there, let's find out what is going on around over there.
No, sir, we do MRI for everyone anyway.
Yes, sir, yes, we do MRI brain for everyone.
Sir, okay. In spite of the center, I think MRI brain is mandatory, sir, EGFR mutation.
So we also do MRI brain for everyone. Stay along over here. So this patient is a PS1, lung, contralateral lung, lymph nodes and bone, and has some 4 small sub-centimeter lesion in the bilateral frontoparietal region. This patient has been seen by the radiation oncology team first. And they say absolutely CyberKnife, SRS, proton, everything is absolutely, there. The patient is, since it has gone to Apollo Proton, obviously is willing for a 3rd generation TKIs over there as well. So the radiation oncologist tells us, I will give, by the time he arranges for the medicines to come in 2-3 days, we will give SRS to all the 4 lesions, and then you give your osimertinib. The medical oncologist, he has at a second consult, we say, no, you start with osimertinib tomorrow, we will talk about that later. Or we will talk about the Flora 2 and Mariposa combination later. What happens over here? What happens? Is there evidence for this? What happens in your center?
Sir, here in our center with sub-centimeter brain nodules, we don't treat with radiation.
1 centimeter.
Sir, unless there is a significant edema or symptomatic, we usually start osimertinib. In his case, with L858R and P53, I would start osimertinib plus chemo as the first
We will come to that over there. Okay.
Sir, definitely no radiation at this point.
I agree. No RT.
So Dr. Karan, my point here is, what do you lose by giving radiation? Just 4 sub-centimeter lesion. Is there a data which has actually compared SRS followed by OC or OC followed by this? What is the harm in giving radiation? You might just release some new antigens, abscopal effect, although we are not giving immunotherapy right now.
Absolutely, sir. I mean, giving SRS at this point of time we should actually go for osimertinib, but SRS at this point of time would not be helpful.
Okay. So you don't have these issues of pehle aap, pehle main does not happening over there. At least in this panel over here, everybody wants to go ahead with osimertinib.
And I actually looked at the data which was there. Okay, I think we have just, so there was actually a trial which had given OC followed by SRS followed by OC or OC followed by SRS, and that actual trial actually showed that if you are giving a third generation TKI, either OC or you in ALK positive, you do not treat a patient who is asymptomatic, and local therapy may be postponed over there actually with this. Okay, now let's move to the year 2025. This was 2023 where we were giving a single agent osimertinib. Now let's move to the year 2025. I'll go to Sujit again. Sujit, how do you decide whether you want to go ahead with the first or second generation TKIs, or let's say patient is affordable for osimertinib, whether you want to go for Mariposa or FLAURA2 or single agent OC? How do you decide?
The co-mutations help, and the type of EGFR mutations help,
okay,
and the visceral and disease burden helps, sir.
Okay. So which are the patients you will want to give single agent osimertinib in your practice?
If the patient's PS is, as we were discussing, PS is 2 to 3.
PS1.
PS1.
55.
So exon 19 deletion.
Exon 19.
Yes. And patients who do not have liver or brain mets.
Okay.
And then
we all keep, Senthil, how would you probably decide between a single and a combination, and then between combination, how do you decide between FLAURA2 or Mariposa?
Okay, first question, I think any patient who's fit to take chemotherapy is willing to take chemotherapy and has got a common EGFR mutation in today's day and age should go for combination, because both the studies have shown clear overall survival benefit, point number one. There have been so many post hoc subgroup analysis,
torturing
all
of the
unplanned,
data.
correct? You show one here,
enough.
one there, just for people who want to pick and choose. But I think the data is very clear that wherever you can do it, you do a combination rather than single agent. For me, I am more common. In fact, I have not used Mariposa at all because you anyway don't have lazertinib. But even if you had lazertinib, I would be tempted to do FLAURA2 most of the time, almost all of the times, because I don't see a clear advantage for Mariposa 2.
Numerically, 3 months more, that is 50 and counting. And
I think it's to do with crossover being allowed, crossover not being allowed, and so on and so forth. So I would, it's expensive, certainly terribly toxic, I would think. I've not used it. Again, we've got some experience with chemo plus AMI, and I'm not a great fan of that combination. But I think we are in the era of combinations.
So which are the patients, Dr. Harita ma'am, which you will use a single, and I'll get this question to you, which are the patients in which you will give a single agent osimertinib? Okay, do anyone of do this ctDNA test to actually find out, ctDNA positivity at diagnosis, and if the patient does not really clear of the ctDNA at 2 months, is any one of us doing that, or is it only in the trial regimen setting still that?
Only very frail patients like we were discussing who cannot take chemotherapy for some reason, we would go for a single agent osimertinib.
Absolutely. I think there was a very nice discussion this time in ESMO that basically they said that, if you have negative ctDNA at diagnosis, or you have cleared your ctDNA, and if you do not have any p53 mutations, obviously in a fit patient, will you not consider combination? Otherwise, combination chemotherapies are the way, combination chemo and target therapies or a combination target therapies is the way. That's a slide I just took from there, which basically says if a patient has no brain mets, no p53, no ctDNA, then is the only way then you are going to give them a single agent. Otherwise, in a combination, a good PS, brain mets, TP53, L858R, all the ones are actually going ahead with that. Toxicity, I think, is something which is very, very important. We need to talk to them. I mean, amivantamab is not, although it's not a symposium, but amivantamab it's a good drug. No doubt about it. We have got people, we were a participant in Mariposa 2. There's a patient who is still living on, after 4 years of progression on that. It's a good drug. I think when the subcute thing comes, it will be good. But we need to manage the skin toxicities. We'll be very good friends with the dermatologist. That is something which is very, very important. But right now, I think combination is really taking the cream right now. Which one? We will talk about that later. So this is where in the last 10 minutes, we'll have some fun. This patient responded well. So patient again has lung. Patient has lung and bone and bilateral lung nodules, medicinal lymph nodes. He was continued on osimertinib. MRI brain, the lesions have disappeared. PET scan now says the only disease which is active basically is in lung and some metabolic inactive bony lesions. after 6 months of osimertinib. Sujit, will you want to consider, again the radiation oncologist has just come back from ESMO and they said, okay fine, you didn't let me give radiation to the brain, now I want to give radiation therapy to the residual site over there. And this was the North Star study design, which actually took both polymetastatic and oligometastatic and induced oligo disease in the trial, and they gave some amount of local treatment, and they showed that the PFS was 17.5 versus 25.3, which is exactly what you get with, almost what you get with combination. Your thoughts on this?
Yes, sir. In clinical practice, at 6 months, if there is a single site which is oligo-persistent, we do discuss regarding giving an SBRT to that lesion, and that is part of our practice. We do consider.
So if the patient had brain, no, just hold on this now. A patient had 4 small brain lesions. Patient had lung, 1 liver, 1 adrenal, and 1 bone. Induced, and after 6 months, only lung is remaining. Induced oligometastatic disease was the term which was brought up in that discussion again and again. You would be comfortable giving that?
Definitely the burden of disease is more. It would have been, if it was a single lung lesions with multiple bone, it would have been better, but still if it's a persistent disease, we do consider for a local RT.
Fantastic, so do we. But timing is there. We'll go this side, yes, madam.
So I'm not comfortable. Still not comfortable giving RT to them in a polymetastatic side or an induced oligometastatic disease.
Fantastic. That is why no. Junior fellow we will ask later. We'll go to Karan this side now. So 1 is 1-1. The elections are hotting up. Polymetastatic disease to start with. Induced oligometastatic now. Karan.
So sir, we will treat with the local therapy.
2:1. The guys are definitely more this thing. Madam.
As of now, we are not sending for local therapy, especially when there is number of sites of metastasis or more.
So ma'am, why are we not sending? Because we are not convinced about the science of it, because there is no OS advantage as yet, because the data which has been, so this was the data which was there. If you have less than 3 sites and if you have more than 3 sites, the benefit is obviously decreasing. And the second thing to me also, there is no OS data, 1. The previous trials have shown conflicting results, 2. There is, the second more thing is, what is the timing of the data? Is 6 months good enough? You know, what these people did was, they at 3 months, 6 months only they did it. Should I be doing it at 18 more months and get the, select the best biology of the disease? That's the doubt which come to my mind actually in this. Dr. Senthil, your thoughts on this? Should we be chasing the star?
Not yet. I don't think so.
Okay. Why?
I think the first problem is with the primary endpoint.
Okay.
I think if you go about radiating all sites that you can radiate, obviously you will have a PFS that's better.
Correct.
This is a study where you should have had overall survival as the endpoint. I would have also liked to see an arm where you're treating only oligoprogressive sites as and when they happen, which is what we really do in day-to-day practice today, and then shown that people who took radiation, oligo, whatever, after your treatment.
Oligo-persistent.
Oh, correct. So all those
10
confusions.
oligos now.
So for me, I'm not happy with the primary endpoint. I would have liked to see an arm where you treated at the time of oligoprogression and then you showed that the overall survival was better when you proactively did it. That's what I would have been happy to see.
We have been a big proponent of this, but we don't do it at 6 months, 18 months. Somebody's doing beyond 2 years, 2.5 years, still persisting. And at that time, there is always a school of thought that what exactly are you treating? Anyway, it is not disturbing you. So I totally agree with Dr. Senthil. Not really convinced, but it's an option. And to me, the only thing which I think is there are 10 professional ways to say I need more time. I think we have got 3 of them right now, 3 and 1, 4 more, 6 more ways to say we need more time to really discuss about how exactly is it going. Now, the same patient, it's in 2023. The patient has been tolerating well and now has got a progressive posterior cervical lymph node. So this is the report which basically comes, where you really have to look at the reports over here. And this says the left pleural effusion has come down, left lung lesion has come down, left posterior cervical lymph node, mild increase in size and activity. This was there before. I will show you the pictures also. This was where we were initially, then this, and then there is a posterior cervical lymph node over here. So now this patient is a real-time patient. I think if Darlong was there, he would remember. What would we do? We will continue osimertinib. Some of us will say it's just radiological progression, mild metabolic increase, let's not do. 3 महीने बाद देखते हैं. You will biopsy the upper deep cervical lymph node. As I normally say, कुछ भी हो सकता है. Maybe it's a tuberculosis, sarcoidosis, it could be anything. You can have biopsy and send for NGS. There are a lot of precision medical oncologists who are unfortunately not there right now and give some precision directed therapy over there. You can actually give radiotherapy to the oligoprogressive site. Says, you know, we believe in MDT concept, you know, we will discuss and we will do everywhere. You want to change the systemic treatment, it's say, you know, it's time to give chemo dena padega, ho gaye 12-15 mahine ho gaye. So we'll start from that side, ma'am. No, we'll start with Karan right now. Karan ka mic hamesha kharab ho jata hai. Yes, Karan.
So definitely I would want to biopsy this and know what it is, and I would also like to supplement it with a liquid biopsy at this point of time.
So biopsy and second and third point.
Yes, definitely. So I like to see what my options are with the targets.
Okay, fantastic. If the biopsy is positive, what will you do?
Take it to the MDT.
Take it to the MDT. We are sitting in MDT right now over here.
Possibly, if it is the only site and ctDNA is negative, would try to take it out.
Fantastic.
Or maybe talk to the radiation and go for a SBRT.
Okay, ma'am, this side, ma'am.
So yeah, I send for MGS, and if the previous pattern is same maintained, we'll continue with osimertinib, considering it's a mild progression.
And will you give radiotherapy to that progressive site?
We could still wait. It's just one node.
We could still wait. So that is why democracy exists, in spite of what people saw in Bihar. Yes, Sujit.
So we should do a biopsy. We had situations where small cell carcinoma has come in such situations. So we should do a biopsy. Now, if it's an excision biopsy and there is no other site of disease and it confirms to be adenocarcinoma, definitely we should send for an NGS to see whether there is any mutation change and whether there is a need to change osimertinib based on the mutational profile. So if it is the same, there is no new mutations, no resistant mutations.
I'll give you this thing now. You do a biopsy, it is positive. And you send for NGS, it actually says there is a MET amplification by FISH. Then why not give radiotherapy to this, only clone, and continue with osimertinib, and you can give the OC plus whatever combination later.
No, in this case with MET amplification, which is one most common cause of resistance, I would consider either continuing osimertinib with addition of chemo. If we can afford amivantamab, I would consider shift to amivantamab.
Okay.
So there is a oligoprogression.
There is a oligoprogression.
And there's a MET amplification in that.
No, not yet. That is the next slide. Right now it is not yet. That is going to come later.
So there is a oligoprogression.
Oligoprogression only, okay, fine.
And the patient is completely asymptomatic for that.
Yes.
So I'll biopsy the lesion, and if there is no new NGS, no molecule or mutation present, I will rather continue osimertinib, and we'll see later 3 months
and how the patient will say, why did you do a biopsy?
We wanted to see.
That's what I wrote over there. Sab theek hai. You know, I mean, everything is absolutely all right. Okay, let's ask the Dr. Rajappa's opinion on this. Yes, so the Dr. Rajappa.
Since you bought into Darlong, I'm assuming Darlong went and removed it.
No, so
we
didn't
anyway,
actually.
Never mind, it's okay. So I would do a biopsy.
And this is a real case. I'll tell you what we did.
Okay, so we'll do a biopsy. If the biopsy is showing disease, we would just radiate. I would not be very pushy on sending it for an NGS immediately. I generally do an NGS if I've decided to change systemic therapy rather than just doing.
You should start reading, Dr. Senthil. Your standards are coming down. You're actually looking at what I would do. This is not right. You should read more. You should go to the next level. Okay, this is exactly what we did. We did biopsy, came as adenocarcinoma. We didn't do NGS because we were not planning to change the treatment. We said we'll keep it for the one. We decided to give radiotherapy to the oligoprogressive site. After that, we continued with osimertinib. We will forget about that. So after 4 months, patient we'll start Dr. Preeti from here only. Patient had systemic progression with some 2 new bony sites and 1 new adrenal mets. And we again took the patient to MSc, and the radiation oncologist was very keen. No, I can give radiation here also. And Sujit is shaking his head very like, this is absolutely okay. We will not give radiation to this. We will change our treatment on this. And we sent a MET amplification, which actually came as positive. This is, I thought there will be residents over here. This is my favorite slide, not this, the one which is going to follow next. The way you look at the resistance mechanisms are on target, off target phenotypic transformation. If you don't know how it happens, just remember this. So this is an off target mechanism. You're holding the girl's hand and you look at somebody else, that is an off target mechanism. You're holding a girl's hand, something happens over there, that's an on target mechanism. Senthil is trying to look and sense into this also. Or if you change your phenotypic transformation, Shah Rukh Khan becomes Jawan, that is a phenotypic transformation, or it goes to small cell carcinoma. So, ma'am, Dr. Harita, let's say this goes into, no, not this. Let's say you have a small cell transformation. How will you treat this patient?
We treat according to the...
so, we will give etosis. Will you continue osimertinib? Will you give only etosis? Or will you add immunotherapy? People in Delhi are very fond of giving immunotherapies, you know. I mean, half my prescriptions are there which says that, okay, don't give this. What would you do, ma'am?
So, as of now, only cecitopicide.
Only cecito, Karan.
I've not treated any but cecitopicide.
Cecitopicide. No immunotherapies? Thodi si? Low dose? Okay, Sujit.
So I had a similar situation, treated with cecitopicide, had response, but as usual within 3 months progressed again.
The transformed small cell doesn't really look better.
Etoposis.
Okay, fantastic. So there is some data of giving immunotherapy in addition, which is hardly 1.5 to 2 months. We need to remember a TSCLC, that's a transformed small cell lung cancer, is not similar as a de novo small cell lung cancer. So even if you're not able to give immunotherapy, that's absolutely all right. Probably this is there. Again, order for a broad-based panel NGS. Okay, a hand on your heart. Karan, do you actually get something once you progress and do a biopsy on osimertinib, or this is just hearsay, all this data which is being shown over here?
So not always, sir. It's about 25 to 30% of the times that you'll get a target.
Okay. So this patient, let's say it did not have any old mutation. I think we will just want to give amivantamab or chemotherapy, that's the Mariposa 2 regimen. Immunotherapy, okay, fine. This patient will go to Karan you. This patient's EGFR was whatever we had, he had a PDL1 of 90%. Progression. Would you want to give a keynote 189, PEMCARB, or you would want to give an ABCP?
So it's an EGFR?
EGFR mutant progressed?
Progressed.
No NGS, nothing has come onto that.
Sir, ABCP.
ABCP. Again, I mean, it is very clear that only immunotherapy or immunotherapy based combination doesn't really work in that. If you have to give, it basically works over here. The next big show, you know, Harthina, Vanita is there, who did the discussion for Tony Moggs, and that was a very nice thing to hear, Dr. Vanita. Clinically insignificant and statistically significant. I mean, hats off to you for saying that. I'll just show the data. This was the Harthina trial, which basically said HER3-DXd was compared against PEMCARB, and it actually found out there was absolutely no difference. So no ADC as of yet, which has really shown this thing. And this is what exactly called as Naam Bade and Darshan Chote. And you know, I mean, you come up with something of that sort and nothing really comes on this. So I think we will just finish this off and tell you conclusions. I think not all progressive disease require change of treatment. You can have a, thing. You should always do a biopsy. Send a broad-based panel NGS. Immunotherapy plays a very limited role. ADCs are coming up. We have a clinical trial of sacituzumab trimetican, which can be referred. That is one thing which has shown some data on that. And with this, thank you. Thank you all my panelists for a wonderful discussion.
I have a question, sir. Just one question. If there is a small cell transformation and there is multiple sites of disease, does it happen that some of the sites turn into small cell and the other sites still have EGFR mutation?
Correct. So I asked this question to Professor Tony Moggs once, and he said he does not use etosis. He says he actually uses Paclitaxel based combination in that, because some of the adenocarcinomas some of them might just be adenocarcinomas, so they use Paclitaxel as a salvage regimen on that.
That is the same actually, the lady whom I was explaining. Cicito failed and then we had to go on Paclitaxel, all the sites actually responded.
Yes, so there could be something, but you know, you have to chase. So then they give 3-weekly Paclitaxel on this. So with this, thank you. Thank you everyone for a fantastic discussion. Thank you.
Thank you to the panel for their valuable insights. I request the panelists, the moderator and the chairpersons of the session to gather on stage for a group photograph. We now move on to session 3. I invite the chairpersons, Dr. T. Venkatesh and Dr. Vamshi V. We now have another panel discussion on the comprehensive management of oncogene-driven metastatic lung cancer covering mutations other than EGFR. I invite the moderator for this discussion, Dr. Senthil Rajappa. I also invite the distinguished panelists, Dr. Vanita Narhone, Dr. Rajiv R., Dr. Ashay Karpe, Dr. Prashant Ganeshan, Dr. Bhavesh.
Okay? Yeah, okay. Right. Okay. Morning, everybody, and thank you, Sandhya and Prashant, for having me here. Privileged to be here. So our topic for this morning is driver mutated advanced non-small cell lung cancer, and everything else that Ullas has said but that. So that's the topic of our panel discussion for today. So we'll just go through one case, and we'll keep changing the mutations that happen in the same case, and then see how differently we would handle depending upon what the non-EGFR mutation is. So, pardon me? We'll make it complicated then. Okay, so just all do liquid and solid biopsy. We'll just move on. Okay, wherever possible, should we say that? Okay, Rajiv, Ashay, okay, all of us will prefer to do both wherever possible, but I know in the real world it's not possible all of the times, but that's what we would like to do. Okay, so here is our case. So this is a 60-year-old non-smoker, 5 centimeter mass in the lung with significant mediastinal lymph node. Those were biopsied. They were positive for disease. And there is a solitary brain met which is cystic, and you see it on the scan. Sorry for the quality of those scans, but it's a solitary brain met that you are seeing. The spectroscopy shows that it's a creatinine choline peak that is elevated. So that's where we are with this patient. So biopsy of the mass showed adenosquamous carcinoma, TTF1 and P40 both were positive. The PD-L1 TPS is 40%. And on the NGS, the HER2 is amplified, 21 copies. Prashant? First question. So we'll take this talk questions for all mutations, and then we'll see how to apply this for this patient. So prognosis-wise, good, bad, ugly with chemotherapy. 21 copies of HER2.
Hello?
Yeah.
So I think the response to treatment varies between mutations and amplifications.
We'll come to this. We'll start with this patient and then we'll go to mutations and amplifications.
Okay, your first
I've just asked you 21 copies, prognosis.
I'm not sure.
You're not sure about, okay. Never mind. Bhavesh?
I believe it is bad unless and until we can give something targeted.
Bad unless and until we can give something targeted. That's a nice way of answering. So when generally we are talking about prognosis, we are talking about good old chemotherapy and prognosis. Vanita, prognosis?
Very poor.
Very poor. Okay, so there's data all over the place. There are some studies which show retrospective, of course, all of them, that prognosis might be a little poor. There are some studies which show that prognosis is not very different. So there's no hard data to say that there's poor or good. All HER2 mutations, we'll come to amplification in a moment. Okay, since Prashant wanted to answer that question, we'll give it to Prashant. All HER2 mutations, or let us start by asking, all HER2 alterations, mutations, amplification, overexpression, these are three different things. So are they all the same or are they different?
They are different because when those studies have included them all together, some of them, but the responses seem to differ between mutations and amplifications.
Response to what?
The HER2 targeted therapy.
HER2 targeted therapies, okay. Is that response also different between TKIs versus ADCs, or all of them have the same activity across alterations, HER2 alterations?
It differs between the TKIs and the ADCs.
Okay. So, Rajiv? Okay, we'll start by, if there are some students in the crowd, we will start by asking what is it that you use to pick up an amplification, what test do you use to pick up an amplification, what do you do to pick up, overexpression and mutations?
So I think it depends on which stage you're doing it. If you're doing on upfront, then it will be
Yes,
part.
stage 4 upfront. Here's your patient.
So, because as you rightly told, if it is a co-mutation, then the drugs that we use are different. If the IHC is positive, then
we're not co-mutation and HER2. How would you treat it differently?
No, I'm just telling that.
No, we have forgotten the EGFR. Ullas has left the hall.
You're not.
Yeah, Ullas has left the hall. So do the EGFR mutations. So we are now talking about a de novo patient with an HER2 alteration. I gave you an example of 21 copies. We picked it up with NGS. Just to complete that thread, mutation, amplification, overexpression. What technique do you use to pick up each one of these? That's the question.
Yes, so usually FISH testing to find out the amplification.
Very nice.
And if there's overexpression, we can do IHC and
Lovely.
find out.
And then mutation is picked up by PCR, NGS, or whatever technique you routinely use to pick it up. Akshay, we come back. Prognosis wise, we said we just don't know. Poor or same is not good for sure. And what about drugs that you use in each one of these? They're all the same, they're different. What would you use first line in this patient?
So basically, in this particular case, both, TPS was also, tempting, you see 40%, but HER2 overexpression. But here I will not use IO. Here,
you will not use IO, okay.
So here
any specific reason you would not use IO?
So basically across all the, studies you will see that HER2 new expression is very marker for poor response to IO. I mean, they don't respond well to IO.
HER2 is poor response to IO. This is single agent IO or combination with chemotherapy?
So here I would like to use, if the patient is affording TDX, I would like to use.
Okay. Vanita, if you were to design the Destiny upfront study, would you have allowed use of IO in the standard arm, or would you have said, no, IO does not work in patients with HER2 mutation, so I would not want to waste resources adding IO to that arm? Because the Destiny study has got IO chemo versus TDXT.
I would have probably added IO. I don't know that I agree. It is an oncogene addicted tumor and probably does not respond, but some of them do respond, right? Like the MET and BRAF. So
right.
Most of the studies that the subsequent line studies, the Destiny Lung 1, most of those patients had received chemo IO in the first line. So I don't know whether they respond or not. Traditionally they shouldn't, but we give it.
Right. So that's a nice answer. Traditionally they don't, but we tend to give it because these belong to a group of these belong to a group of alterations where we typically would not expect immune checkpoint inhibitor to work. But if you see all of these studies, including the Libretto, which was very criticized, right? It's a cold tumor. Generally, you would not expect it. They randomized patients to chemo IO versus the TKI. But that having said, it's okay. You're not totally off the book if you wanted to use IO for a patient like this upfront. I mean IO, I'm talking about chemo plus IO. I'm not talking about IO as a single agent. So both Akshay and Vanita have their points and both of them are correct. Prashant, just a point. I see this very commonly happening in the community. ERB2 exon 20 versus EGFR exon 20. People tend to confuse both of these.
Yes, it happens quite often. And
yes, can you just quickly tell us?
They're completely in different genes. So this is in the EGFR and the other one is in the HER2 gene. They look similar. When you had a very quick look at your report, you tend to confuse them. And even treatment-wise, the exon 20 insertion, you go with the current the best case could be something like amivantamab, and for here you use the HER2 targeted treatment. So the treatment is completely different. Earlier also there were some TKIs, but then they went out of favor for the...
right, so very nice, very nice. So this is something, when you look at exon 2, so for want of time, the most common alteration that you would see in HER2 is again an exon 20 insertion. ERBB2 exon 20 insertion is what they would report it as. All of us tend to jump looking at that exon 20 insertion, and thanks to J&J, we end up thinking about amivantamab, which is exactly what we shouldn't be doing in a situation like that. So they're totally different, though EGFR belongs to the HER2 family. It's HER2-1 or ERBB1 is actually EGFR. They're totally different. Their chromosomes are different. You know, there was a nice discussion after Vanita's in ASCO, and that was titled "Same Pin Code, Two Different Addresses." That was the title of the discussion. You know, I thought it was a very novel, innovative way of, you know, helping people to remember that these are some totally different ones. Okay.
All those titles, even I was very impressed, apparently came from ChatGPT. So this
is
an
it?
inside
Okay,
story.
I thought it was very nice. Okay, Prashant, you seem to be the HER2 expert here, lovely. Why is it that TDXT works better, slightly better, in mutations compared to overexpression? Some preclinical data. I mean, we don't have data in the clinic.
I don't know the answer to that.
Right. We think, or rather there's some preclinical data to say that the internalization is better in patients who have mutations compared to overexpressions, and that seems to be the slightly better activity that TDXT has in mutations compared to overexpressions. Anyway, so it's one drug, two biomarkers, and the two biomarkers here are overexpression and mutation. First line treatment, still the standard one remains. In a patient like this with brain mets, any one of you would be tempted to use TDXT in the first line? Or you would just do radiation or excise that because it's cystic and symptomatic and then do IO plus chemo or chemo alone? Bhavesh?
I think standard treatment, we'll keep TDXT as second.
We'll keep TDXT as second. Vanita, in a patient like this, would you push the TDXT ahead because of brain?
Tempted, but as Bhavesh, I agree with Bhavesh.
We're all tempted to do it, but we will stick to the book. So the first line treatment remains chemo plus minus IO, and when these patients progress, they go on TDXT. So that would be the standard treatment, assuming that patients have access to TDXT and all of that.
How about if you have had sevapatinib or zongertinib?
Lovely. So I thought I will ask you, what do you think, gazing at the crystal ball, do you think zongertinib or sevapatinib will overtake TDXT and get to the first line, I wouldn't say faster, but would be better in the first line? What are your thoughts?
I hope yes, they are oral drugs. Probably, I mean, if we had an oral drug and an IV drug with similar efficacy, we would all prefer the oral drug, right? So
right.
I hope so.
And cross comparison seems to be lesser toxicity with the TKIs compared to TDXT. So what we were referring to is there are multiple TKIs that are being developed for these patients. And those TKIs seem to have better activity than TDXT, lesser toxicity, maybe better CNS penetration, we don't know. And as Vanita rightly said, it's oral, so it's always going to be easy and convenient to use. So we think that there might be a change in the way we manage these patients, especially if TDXT moves to the first line, the TKI has also come to the first line. Okay, so that's where we will leave HER2. So quickly to revise, we've got three kinds of alterations that you get in HER2. As Rajiv said, NGS or PCR for mutations, IHC for overexpression, and FISH typically, or NGS copies that you would get for amplification. These are totally different. The commonest one is HER2 exon 20 insertion. That's where all these drugs work best. There's a very small proportion of patients who are non-tyrosine kinase domain mutations where you would find with HER2. There, the activity actually seems to be a little lower for these drugs compared to what you would get in the exon 20 insertion mutation. So that's all I know about this. We go to the next one. Here is the same patient with lazy doctor, right? The only change is MET is altered. Ashay, what would you do?
So basically, MET is altered. We have to see what is if it is a mutation, amplification, or expression.
Lovely. So mutation, amplification.
So because that is something where we would like to take a call about the treatment.
Okay. So how would that alter your first line treatment in this patient? Mutation versus amplification. Suppose I say 10 copies of MET versus MET exon 14 skipping. Would that impact the way you manage this patient?
Maybe I'm like, everything boils down to the cause. If MET overexpression is that even I can, you know, he's not affording capmatinib, bortezomib, even I can think
So
of
if he
crizotinib.
offers capmatinib in the first line for a MET overexpressing tumor, would you give capmatinib?
Yeah.
You would give capmatinib, okay, never mind. Anybody else got a difference of opinion? All of you would give capmatinib? Vanita is not agreeing with you, Ashay. Yeah. You need to ask
You're
her
saying
why.
not a mutation. You're saying an overexpression.
It's an overexpression first line. This is the same patient. One brain met with a T2 N2.
Maybe possible. I would discuss it. It's not as good as giving it if it were a mutation. I would discuss it or give chemo.
Okay. Bhavesh Prashant? Chemo. Discussion. Chemo IO. Chemo IO. IO no. IO. Right. IO plus minus. Okay. Vanita, standard cutoffs. You did the discussion, so you should be the expert on this. For MET amplification, we'll come to exon 14 skipping in a moment.
So I guess in different tests, different cutoffs, 5, the MET to SEP7 ratio greater than 5 or copy number greater than 5. So this I'm telling you based on this new approval of this
Telisotumab vedotin. Telisotumab. Okay, lovely. You brought up that. We'll talk about it in a moment. Okay, so again, you know, these are all not the same. So this got so much of material on this slide, but the point is, again, just like HER2, you've got 3 ways of picking up or 3 kinds of alterations in MET. For the first line, remember that the only alteration for which we would use a TKI, standard approved, would be MET exon 14 skipping. Okay? If you have even 25 copies of MET, unless somebody says, no, I don't want chemo at any cost, and then off-label use of a MET-targeted therapy, otherwise you would not use it in the first line. You would go to the second line, and that typically happens in the EGFR, you know, progression clinical setting. So you've got 3, nobody exactly knows what is the cutoff to say MET is amplified. As you know, Vanita said, some will say 5, some will say 10. In fact, the Sachi study, if you had used the first generation TKI, 5 copies. If you used osimertinib in the first line, 10 copies. Look at within the same study how you can twist it. Yeah, Rajiv, go ahead.
No, we were part of the Savannah study. So
you're part of the Savannah study.
So there was a lot of
Savannah is very
updates
similar
on
to
the
Sachi.
cutoffs points, and there it was 10 and 90.
Correct. Okay, so look for MET exon 14 skipping in the first line. If you get a MET exon 14 skipping, capmatinib, if your patients can afford. Here is a situation where there may be some activity of IO. Okay, as again, you know, Vanita said earlier, 2 places where it would be okay to use an IO is a BRAF and a MET-exon 14 skipping. Amplifications seem to be slightly different. So, especially if your patient is a smoker, because there seems to be a predilection for these mutations also in smokers. So, it's okay to use an IO. We spoke about standard cutoff. Prashant? Yeah. Right, correct. KRAS, and I've got a slide on that. In fact, we've got a KRAS quiz coming up, so we'll come to that in a moment, right? Sandhya, whoever gets the KRAS quiz right, you will have to arrange for darshan tomorrow morning. Okay? So, guys, if somebody is finding it difficult to get a darshan, get the KRAS quiz right, and then we'll go ahead. Okay, so prognosis-wise, it's bad. Okay, we spoke about the different alterations. I showed you a very crowded, confusing slide. Never mind. Telisotumab vedotin. Anybody wants to talk about telisotumab vedotin? Okay, look at
FDA
Vanita.
approval. It's FDA approval. We don't have it, but it is approved.
Yes. So, which setting, Vanita? So, this is a slightly different one compared to
some protein. So, if you have IHC MET positive protein, it is approved, I believe, if I'm not mistaken, and correct me if I'm saying something wrong. Yes. And if there is I think FISH also, amplification also is part of the approval.
So the TELISO-V study looked at patients, they underwent IHC, and then if you had a 2+ or a 3+ in more than 50% of patients, you were eligible. But keep one thing, or rather remember one thing. This is one place where the MET-targeted therapy did not work in EGFR mutated patients. In all the settings, we would talk about MET as a resistance mechanism for patients with EGFR, especially MET amplification and overexpression. There's a lot of overlap between these two. But telisotumab vedotin is a drug that is approved in non-EGFR mutated MET overexpressing patients. Okay, I'm glad you brought that up, Vanitha, because that's a totally different, it's kind of very off. In fact, the arm was discontinued because there was no activity in the EGFR mutated patients, which is something that is actually surprising because you would expect that that's the group that's likely to benefit the most. Excellent. Very good. We've done 2. Same patient, KRAS, G12D, non-smoker with headache. So the quiz is here. So we'll open the quiz to our panelists first and then to the audience. What does KRAS stand for, Prashant?
You don't have it there?
No, I've just given you some pictorial clues, okay?
You want the full form of RAS?
KRAS.
Kirsten, rat.
Kirsten, rat. No, the rat is separate. RAS. And then...
Kirsten is correct.
No.
Nahin.
Gary Kirsten is there, but we
galat
come
hai.
to Gary Kirsten. You will get only a drop at Alipiri. Okay, not beyond that. First we start with RAS and then we go to the 3 RASes. Not the asses, the RASes. Okay. Okay, so I put a, pardon? Correct, so it's not, so we didn't ask Kirsten at the moment. We didn't go to KRAS at the moment. We started with RAS, so it's rat sarcoma, right, which is exactly, so the gene was first isolated in the virus that causes this particular, change. That's one. Okay, anybody wants to take, what are the 3 RASs that you have? K, N, G. Your return ticket is cancelled. G, okay. Okay, KRAS, NRAS, correct, HRAS, okay? So let me, okay, Kirsten is over. I put Gary Kirsten there, South African cricketer, Indian coach after that. So Kirsten is gone. What about NRAS and HRAS? You're close by, you get to halfway, you don't get the darshan. Neuroblastoma, lovely. So I put kids there because N stands for neuroblastoma or RAS. Very good, Prashant. We'll talk to Sandhya and get one done. It's okay. Rajiv and Ashay. Who's the one on the top right? Looks like Abraham Lincoln or somebody, Newton types. Okay, so that's William Harvey. It's okay. So he's the one who discovered circulation. So the H stands for Harvey, right? So these are the Kirsten, the Harvey, and the neuroblastoma RAS. So this is something that I have to buy. I had to keep telling myself 3 times last night when I went for darshan this morning so that I don't bungle it up, right? Anyway, so that is just trivia to break the monotony. Okay, we'll come back to where we were in terms of our discussion. So we've got 3 types of RAS. 85% of all of this is KRAS. Multiple other malignancies also have RAS alteration. Okay, so we come to G12C versus G12D. Adeno versus squamous, smoker versus non-smoker. Is there any difference in terms of the way it occurs? Ashay, you want to take that?
So basically, G12C I think is the only where you can think about
yeah,
targeted
we'll come
treatment.
to that in a moment. You're right.
So
some targeted therapy for
think about.
Smoker versus non-smoker. Is there any difference in the kind of RAS mutation that happens?
So I think the smoker will be more inclined, and these are the population maybe responsive to more immunotherapy as compared to
okay, Vanitha or anybody else? Smoker versus non-smoker, adeno versus squamous. Our patient was a non-smoker, so he had G12D.
So I think slightly more in smokers from the Western data, but it's very less from Asian and Indian data.
That's a very important point. So a lot of this RAS is actually taken up by EGFR.
Yeah, so I think it's 20 to 30% some of the Western studies, very high, but I think because we're part of the Lilly study with KRAS, but we're hardly getting patients. We're screening so many, we're hardly getting the G12C actually. So it's less than 5% is my feel, but I don't know, maybe it's around 5
Correct.
to 10%.
In general, it's about 12 to 15%. Yeah, Vanitha, you might have lots of data. Go ahead, you tell us about.
I think different cohorts is different, but between 9 to 12% is about
correct.
our
9 to 12% is what we see. It's much lesser than what you would see in the Western data. And Prashant, I'm glad you made that point. We are also part of the crystal study. We are struggling to, get patients, but, that's where we are. Okay, so non-smokers, adenos, more often you would see G12D, right? So G12C is more often in patients who smoke, and that kind of also leads us to the question of IO, which all of you were pointing out earlier. Smokers, G12C, better activity for IO. So KRAS is actually a predictor of activity to immune checkpoint inhibitor. Vanitha, you wanted to add something? Yeah, go ahead.
Agree.
Okay, right. So we said mutations, we pick it up with NGS, and first line treatment would be chemo IO if you're not having a clinical trial that's enrolling at your center. So the first line would be chemo IO. In fact, if you have a RAS and a P53, we don't like P53 with EGFR, but a P53 and a RAS puts you at even higher likelihood of responding to an immune checkpoint inhibitor. So that's one place where you would like to see, or not, I would not say like to see, where you would be not upset seeing a P53 mutation, I would say. 60-year-old non-smoker, same headache. BRAF V600F. What would you do in the first line? Bhavesh?
Chemotherapy.
Chemotherapy, IO?
Plus IO.
Chemotherapy plus IO. Why did you decide not to use dabrafenib and trametinib for our junior colleagues?
For the mutation, V600E would be ideal.
Lovely. So when we see a V600E, we would think of the TKI, but when it is a non-V600E, we would not use a TKI. TKI first or chemo IO first?
Some data coming up that, chemo IO may also do equally well even in BRAF V600E. And then you can use dabrafenib, trametinib.
Okay.
But in practice, most of us try to use targeted therapy to start.
Very good. So this is the data set. Actually, there are two interesting data sets. One data set showing that they do equally well. You're right. That's the data set on the top. But the more interesting one is the data set at the bottom. Both of them are real world data sets. These are not prospective randomized studies. And the bottom one actually is showing that if you use a TKI first, you have detrimental outcomes, right? Any thoughts on why this might be actually happening, Bhavesh? Yeah, go ahead, Bhavesh.
I think that those patients who have opted or those who were been given an offer for TKI, probably they were PS-wise not good.
Okay, but they get better when you give
chemo IO combination will be given to a fitter patient.
Okay.
So I think that is why
so they continue to remain fit. And Vanitha, you had some EGFR data earlier akin to this, right? Patients who took chemo and then went to an EGFR TKI did slightly better compared to patients who started with an EGFR TKI and then went to chemo. The initial.
Back, I think.
Yes, way back.
PEM versus Jeff study. Yes. Pemetrexed versus Jeff.
Yes. So
I guess it's hard to make
sense
figure out
this.
what happened, but
Correct.
I think exposure to the TKI is important. Exposure to chemo and IO is important. Perhaps the patients who started on the first line TKI at progression, a fair number of them may not have been able to receive chemo IO.
Correct.
I think the bottom line is patients need to get exposure to all the available therapies. I think.
Lovely. Very nice summary.
So I think, this is what I think we have seen in our study with PEM-JEF, the upfront JEF.
Correct.
Second line, because I think when you are giving chemo, I think probably you are more stringent with RECIST. And when you actually giving TKI, you are always saying a patient is symptomatic, and probably then you lose that window where you can offer second line therapy.
That's correct. So that's probably, Rajiv.
It's slightly different from the melanoma data with BRAF V600, where, if you use targeted therapy first, they do better than if you...
That's correct, which is what you would logically. So I think two important points. One is if you're using a targeted therapy first, make sure you've got a very close watch on your patient. When they worsen, you want to jump to your chemo IO or chemo only as quickly as possible. One. I think Vanitha made a very important point. It's important to expose these patients to the TKI combination. The lovely thing about, BRAF TKIs is that whether you use it in the first line or the second line, the numbers are absolutely the same in terms of overall response rate and median PFS. Response rates around 60-65% and median PFS, which runs somewhere around a year. First line versus second line, there's absolutely no data at all. So it's important to get them exposed to the TKI combination, very important. If you're using the TKI first, make sure that you're keeping a close watch and jumping to chemo plus minus IO the moment there's a small inkling that this patient is starting to progress. So that's the way I would, yeah.
Can I ask a question? So we haven't addressed the patient's brain met for any of these cases. So I just wanted to ask you, you would do RT? Am I allowed to ask the moderator or?
Good question.
You do an MDT and
so that's
because this is
so
not,
what
this is not
happened
easier
in
for
this,
an ALK,
yes.
right?
So what happened is patient, I'll tell you, Vanita. So since it was a cystic met, there was a lot of discussion in the MDT as to whether you should be, doing radiation, watching what's happening, because he was asymptomatic. So this patient actually ended up having an excision of the brain met and then some radiation therapy to the tumor bed. That's what happened in this patient. And then later he had some radiation to the chest. He's actually doing well. He's not driver mutated at all, right? See how I can dupe you for half an hour.
You used a case for all of this which did not even have the mutation. But I think the point I was trying to make is that other than EGFR and ALK, most of these other targeted treatments don't have that good CNS penetration. So earlier you should think about addressing the brain mets earlier.
Right, absolutely well taken. So I think we'll wind it up. We're running short of time. So for me, just like COVID times, test, trace, treat, and probably triumph is what I would think. So keep doing this, and then don't forget the patient at the end of the day. That's what Vanita probably remembered and told me, what did you do to the patient? So don't forget the patient at any point in time. These are expensive things, okay? A lot of our patients, at least a lot of my patients can't, access dabrafenib, trametinib, capmatinib, and all of those things. But we kind of somehow navigate through this, complexity and give them whatever we can at whichever point we can. But wherever, whenever possible, don't forget what we discussed today. Thank you.
Thank you to the panel for such an energetic discussion. I request the panelists, the moderator, and the chairpersons to gather on stage for a group photograph. I now invite Dr. Praveena Woona for a talk on advances in the treatment of non-squamous metastatic non-small cell lung carcinoma.
Good morning, everyone. First of all, I would like to thank organizers of NALCCON, Dr. Prashant sir and Dr. Lakshmi Sanjay ma'am for giving me this opportunity, and also MST. In this session, I would like to discuss the role of pembrolizumab in metastatic non-squamous non-small cell lung cancer. This is the overview of my talk with main focus on Keynote 024 and Keynote 189 studies. In yesterday's sessions, about epidemiology and biomarker testing was extensively discussed. As we all know, according to Globocon 2022 data, it is the most common cancer in men and second most common cancer in women worldwide. Around 84% of lung cancers are non-small cell lung cancers. If you see the Indian data, lung cancer is the fourth most common cancer in incidence and mortality, according to Globocon 2022. So, as we all know, lung cancer is most commonly diagnosed in advanced stages. Almost 80 to 85% cases are diagnosed in stage 3 and stage 4. Nearly half of cases were diagnosed with distant metastasis. So, PD-L1 expression is the most important biomarker to predict the response to anti-PD-1 and PD-L1 antibodies. It is assessed by TPS, which represents the percentage of viable tumor cells that show membrane staining. If you see the data from keynote trials, around 67% of patients are PD-L1 positive, and 28% of patients have shown high PD-L1 expression, that means more than or equal to 50%. This is how to calculate the PD-L1 TPS score. Number of PD-L1 positive tumor cells by total number of viable tumor cells into 100. So this can be utilized to identify disease most likely response to first-line immunotherapy drugs. This is the real-world evidence prevalence of PD-L1 expression. Express studies was a large real-world study in patients with locally advanced or metastatic NSCLC evaluating PD-L1 expression. In this study, total 2,368 tumor samples from 18 countries were studied. Out of these, 52% has shown PD-L1 positivity and 22% has shown high PD-L1 expression, that means more than or equal to 50%. So this slide is showing timelines of FDA approvals for immune checkpoint inhibitors in lung cancer. If you see the pembrolizumab approvals, in 2016, it was approved in first-line NSCLC patients having PD-L1 expression more than or equal to 50%, whereas it was approved in combination with chemotherapy in squamous and non-squamous metastatic cases in 2018. So, wherever required in appropriate settings, PD-L1 testing should be considered as part of the initial diagnostic workup, especially when treatment with immunotherapy is being planned in first line. So, pembrolizumab is indicated as monotherapy, single-agent therapy in first-line treatment of metastatic NSCLC patients whose tumors are expressing high PD-L1 TPS score, that means greater than or equal to 50% with no EGFR or ALK mutations. Like that, it was approved in second line in patients having PD-L1 TPS. It is approved in combination with chemotherapy in first-line patients of, along with platinum and taxane combination in first-line treatment of patients with metastatic squamous NSCLC. It was approved in combination with platinum and pemetrexed combination in first-line metastatic non-squamous NSCLC, provided there are no EGFR and ALK alterations. So it is pembrolizumab is a selective humanized monoclonal antibody designed to block the interaction between PD-1 and its ligands PD-L1 and PD-L1. By blocking this interaction, it leads to activation of T cells, which further kill the tumor cells. Coming to Keynote 024 study, in this study, PD-L1 high, that means TPS score greater than or equal to 50% NSCLC cases were enrolled. In this, pembrolizumab single agent was tested against chemotherapy. If you see it's an open label randomized phase 3 study. If you see the eligibility criteria, patients with untreated stage 4 NSCLC with PD-L1 high PD-L1 score were enrolled, and patients should have good PS with no EGFR or ALK alterations, and no untreated CNS mets or active autoimmune disease should be there that required systemic therapy within 2 years, and like other trials, measurable lesions should be there according to RECIST 1.1. It was total 305 patients were enrolled and randomized in 1:1 ratio, 154 in pembro arm versus 151 in chemotherapy arm, and treatment was continued until progressive disease or unacceptable toxicity in pembro arm, whereas in chemotherapy 4 to 6 cycles were given, and crossover was allowed in this study. Primary endpoint of this study was PFS. Secondary endpoints were OS, overall response rate, objective response rate, safety, and exploratory endpoint was duration of response. If you see the PFS, 5-year PFS analysis, 5-year PFS was 12.8% in the pembro arm, whereas no evaluable patients were there in the chemotherapy arm. Median PFS was 7.7 months versus 5.5 months, which a hazard ratio of 0.50, which was statistically significant. If you see the OS data, the 5-year OS rate was doubled in pembro arm versus in the chemotherapy arm, 32% versus 16%. And the median OS was 26 months in the pembro arm versus 13 months in the chemo arm, which was, that means more than 1 year OS benefit was seen with the pembro arm. So it has shown durable and clinically relevant, statistically significant OS benefit. If you see the adverse events, so high-grade adverse events were seen in 31% of patients in pembro arm versus 53% in the chemo arm. That means favorable toxicity profile, and no new safety signals were identified with the long-term follow-up. I would like to show one example, one case. This is a 70-year-old male patient having multiple lung nodules on CT scan and doing PET scan, found to have light-sided lung tumor, mediastinal nodes and multiple bone metastasis. HPE was reported as non-squamous, non-small cell lung cancer. Patient is having history of type 2 diabetes mellitus with the ECOG performance status of 1. So finally, it's a metastatic non-squamous, non-small cell lung cancer. NGS was negative for targetable mutations. PDL1 was 60% TPS score, and the patient was reluctant to go for chemotherapy, and PDL1 expression was also high. This patient, pembrolizumab single agent was given this for this patient, 200 mg every 3 weekly. So at first follow-up, after 3 cycles, patient was found to have stable disease as per RECIST criteria. After 14 cycles of treatment, he developed some oral ulcers, which was resolved with antifungal medications, and he has remained progression-free for 24 months. So elderly patient, high PDL1 expression, by giving single-agent immunotherapy, adverse events associated with chemotherapy were avoided, and he has, were able to prolong his lifespan for up to 2 years with favorable toxicity profile and good quality of life. Coming to keynote 189 results, in this study, metastatic NSCLC patients were enrolled. In this, pembro plus chemo combination was studied in non-squamous NSCLC patients. If you see the eligibility criteria, stage 4 non-squamous NSCLC, no EGFR ALK mutations. Remaining criteria are same, good performance status, should have measurable disease, and life expectancy should be greater than or equal to 3 months, and should not have any active autoimmune disease or active CNS metastasis. In this, total 616 patients were enrolled. It's a double-blind, phase 3 double-blind study. In this, total 616 patients were enrolled and randomized in 2:1 ratio. With the one arm patients receiving pembro plus chemo combination up to 4 cycles, followed by pemetrexed plus pembro combination until disease progression. In another arm, placebo plus chemo combination was given, followed by placebo plus pemetrexed maintenance. In this study also, crossover was permitted, and pembrolizumab retreatment was also allowed in this study in patients who are having response of stable disease or better after completing 35 cycles of pembro. If had progressive disease, then retreatment was given, and also patients who had stopped trial treatment after achieving CR and after having received greater than or equal 8 cycles of treatment, such patients also retreatment was allowed. Stratification factors are PDL1 expression, smoking status, platinum. Primary endpoints were PFS and OS. Secondary endpoints were safety, overall response rate, duration of objective response rate, duration of response. Exploratory endpoints are effect of PDL1 expression on efficacy and patient-reported outcomes. So this pembro plus chemo combination significantly improved OS and PFS versus placebo plus chemo combination in these patients, and median follow-up was 64.6 months. Effective crossover rate was 57.3 months. Despite of having a significant crossover rate, this pembro plus chemo arm has shown significant OS benefit. Median OS was 22 months in the pembro arm versus 10.6 months in the placebo arm, with a hazard ratio of 0.60, which was statistically significant. And the 5-year OS was 20% in the pembro arm versus 11% in the chemo arm, and the benefit was more in patients having high PD-L1 expression. That means having greater than or equal to 50% score. 5-year OS rate was 29.6 months in the pembro arm. Then 5-year PFS data, if you see, the median PFS was 9 months versus 4.9 months with a hazard ratio of 0.50. And 5-year PFS was 7.5% in pembro arm versus 0.6% in the chemo arm, which was placebo arm, which was statistically significant. If you see the response rate, ORR was almost 50% in the pembro arm versus 20% in the placebo plus chemo arm. This is in patients who have completed 35 cycles of pembrolizumab. Around 70% of patients were alive 3 years after completion of 35 cycles. That means approximately 5 years after randomization. That is the beauty of immunotherapy. Durable response can be achieved. In these patients, the ORR was 86%. If you see the toxicity profile also, no new safety signals were identified and toxicities are well manageable. So it has shown significant OS and PFS benefits regardless of PD-L1 expression. And these results support the combination of pembro plus chemo as standard of care in stage 4 metastatic non-squamous NSCLC without EGFR or ALK alterations. This is another case. This is a hypothetical case given by MST. In this 60-year-old male patient found to have left upper lobe mass and bilateral lung nodules and mass in the sacrum. Biopsy was reported as non-squamous NSCLC. TPS score was 6 and NGS panel was negative. This patient, pembro plus carbopemetrexate combination was given once in 3 weeks. After 3 cycles of combination therapy, response assessment was done. After 3 cycles, response assessment was done and patient performance status improved, subjectively improved well. Left upper lobe lung mass was stable, but the size of small bilateral lung nodules had increased. Suspecting pseudo-progression, further same treatment was continued. After 3 more cycles, CT scans showed complete regression of lung nodules with stable lesion in the upper lobe. And this first line therapy was, this pembro maintenance was continued till 35 cycles. Coming to the guideline recommendations, if you see NCCN guidelines for patients who are PD-L1 negative, pembro plus chemo combination was given as category 1 option in both squamous and adeno. In low PD-L1, that means PD-L1 1 to 49% also, pembro plus chemo was category 1 option. In high PD-L1 cases, single agent pembro was also added as category 1 option, preferred options. This is ESMO guidelines also showing pembro plus chemo combination in first line option. It also recommends pembro as standard first line options in patients with high PD-L1 expression. So NCG guidelines also added IO plus chemo combination in first line and for patients having high PD-L1s as monotherapy. So to conclude, these keynote 0, T4, 24 and 189 studies demonstrated the efficacy of pembro as monotherapy and as combination therapy in first line treatment of metastatic non-squamous non-small cell lung cancer. NCCN, ESMO and NCG guidelines also recommend the use of pembro as first line treatment. Thank you.
Thank you, ma'am. I request the chairpersons and Dr. Praveena ma'am to gather for a group photograph. I now invite Dr. Saurabh Radhakrishna to talk about the treatment options of non-mutated metastatic non-small cell lung carcinoma. We welcome you, sir.
So, good afternoon, everybody. We have had a long discussion on molecular and germ, the different targeted agents that we have. So, I'll be looking more at the remaining of the patients, or what we call as the majority of the patients which most of us have. I think there are many students also here, and that is patients who don't have any actionable mutations. So, as we have found out, the lung cancer remains one of the most common, and like with all solid tumors, with each line the survival comes down, and with lung it is much worse than any of the other solid tumors. So this is the landscape as of today with all the driver mutations and others which are present, but looking at it, the problem here is majority of the patients, that is nearly 70, do not have any identifiable mutations. And if you go into squamous cell carcinoma, we all know that it's much more less. So this remains the true factors. So nearly 70% or 2/3 of the patients do not have any actionable genomic. These are mostly Western data. We have some papers on retrospective in Indian situations also, which mostly goes along with what the Western data have shown there. So for many of these patients, they have many things. I'll just put this slide up first. This is some of the major trials which have not yet achieved any major endpoints which they were seeing for second line or beyond in metastatic cancer. We'll come to the successful trials later on. So one can see that many trials have failed in many situations in these patients. So as of now, this remains our problem. That is mostly advanced stage diseases and nearly 70% of patients having no actionable genomic alterations. So here is where the role of PD-L1 comes in, and initially it was thought that only the patients who had a strong PD-L1, that is more than 50%, had a role for anti-PD-L1 agents. Now we know that is not the case. So why is this? So we have two sets of predominantly the classical PD-L1 agents. One is the anti-PD-1, that is a nivo-pembro, and the other is the anti-PD-L1. So they have different actions, but all of these are theoretical, and we know that many of these are overlapping features which we have. So why is PD-L1? PD-L1 basically downregulates the anti-cancer immune system and prevents priming and activation of T cells. So based on this, certain concepts were there, and based on that we have these situations where we can use IO monotherapy or IO with chemo. Now, the key point here is for patients whose PD-L1 is very low, let's say less than 1% or less than 50%, why does adding the chemo work? So two things. One is once you give chemotherapy, the chemotherapy destroys of a lot of cancer cells and you get a lot of release of tumor antigens. And the PD-L1 expression will prevent activation of the immune system against these antigens, and if one can block, then you have the situations. So based on this concept, came the concept of using IO with chemotherapy for NSCLC. So this is a bit crowded slide. These are the major trials where this concept has worked out. If you can see it out, most of the major studies we have mentioned are the keynote trials. The important ones here would be the keynote trial and the Empower 130, 150 and the 110 trial, and the newer one, that is the Empower Lung 1 and 3, which based on semipilimab. And for the second line and beyond, some of the older and some of the newer one, especially the Oak and Poplar trials, and our older ones, that is ramucirumab with docetaxel in the Revel Good trials. So if one looks at the first line chemo, not all of them had a very good. Some had negative outcomes, some had non-inferior outcomes, but the major positive ones were for non-squamous were the Keynote 21 and Keynote 189. Along with the Empower 130 and the Checkmate 227. Checkmate 227 actually had a negative study, and we come to the combined this thing, that is squamous and non-squamous. We had the Poseidon, which was the first time that durvalumab came into the picture in lung and in other solid tumors. You also had the Checkmate 227 study also. For the squamous alone, we have very little drugs or agents which we have. They are the Keynote 407 and Empower 131. But overall meta-analysis of all of these agents, atezolizumab, semipilimab, nivolumab, the combination of nivo with ipi, that's IO-IO combination, or pembrolizumab, all have shown and proven the concept that a combination of IO with chemo is better than giving chemo alone. And the difference is in where the survival thing is more based on what are the cases that present and what was the data and knowledge we had from our previous studies. So what were the trials again? The Keynote 024, Keynote 424 pembrolizumab, and for combined ones, that is a squamous, non-squamous, irrespective of histology, we had the Keynote 189 and 407. For atezolizumab, as I said before, again slightly crowded because I made it in the MAC. I think it is becoming slightly crowded, but Empower 150 and 110 and 130. The other slightly controversial one was the checkmate trials, not as much this one as the others, but still they have the approvals. Again, a bit toxic in some patients. We think we can avoid chemo, but the combination is sometimes more toxic. More interesting to us is the newer ones which have come, which are more cost effective and better. That is the semipilimab one. The Empower Lung 3 trial especially, where irrespective of the PD-L1 and irrespective of the histology of NSCLC, the studies have shown better survival with the addition of semipilimab to chemotherapy. The other large major drug, that is durvalumab, we had the Poseidon trial, and going back to the older agent, we had the Revel trial. Lumlung was a good trial, but unfortunately nintedanib is still not available in India, so for practical purposes it's not an option for us. Whereas ramucirumab is available and we can always consider that. Two other things which I will touch upon before going forward is, one is what to do for patients who have done actionable mutations and then have progressed. So EGFR or ALK and patients have gone, that's only two major trials which have had this. One is the Empower 150, which was a major one. Keynote 189 had some patients which had progressed. Similarly, Keynote 189 and Empower 150 also had visceral metastasis, especially liver metastatic patients. So in this situation, for patients who have progressed beyond EGFR, ALK and other things, it is only the ABCP combination would be a reasonable, the only one where the patients were there. And maybe to an extent, to a lesser extent, much lesser extent, I would say the Keynote 189. So among the successful trials, this is the situation as we have today for previously treated NSCLC. The atezolizumab, we have second line for all comers, Poplar and the Oak showing the benefits with atezolizumab monotherapy. Nivo, again we have checkmate 017 and checkmate 057. Pembro is one agent where in second line and beyond, they have only one trial, probably because it was the earlier one, much successful with first line. Many of us would not be using Pembro like second line and beyond because it would have been used up already, but still for those who want to use, we have the Keynote 010. The other major third line, we start coming to the bottom. The predominant agent here and the proof one remains the Durva with the Atlantic and the Arctic trials. So the only one with squamous here was nivolumab, and so for that matter, nivo remains an agent where we have. I'm not going to the side effects and others. Slightly going towards the other factors which we have, and that is the ongoing immunotherapy trials which we have. Some of this will have major implications for us and our patients. One of the things which we are all waiting, I think, is the Choice 01, which is a toripalimab with chemo versus chemo alone. Entire thing, irrespective of histology, non-squamous, squamous, it didn't matter. They have gone, it's an ongoing trial. We do not know what will be the outcome, but initial data have been somewhat supportive of this. Similarly, we have the Evoke 03, which is saclizumab with Pembro, another non-chemo combination. Again, both histologies, squamous, non-squamous, everything has been there. Coming back to our the further modifications of the Empower 130, that is 131 and 132. So of these things, the two major things from an Indian perspective would be the Choice 01 and Evoke 3. Evoke 3, unfortunately, however, we do not have saclizumab. Would be an ideal situation if we had the drug at a lower cost. So the one major thing, I guess, to watch out where we have all the agents available and at a lower cost is the toripalimab combination. And two other newer agents which may come into India and maybe this thing and maybe cost effective is the Orient trial drug, that is a sintilimab. The Orient 11 and 12. The peculiar thing about that is they have used the Orient 11 for entirely non-squamous histology, and the Orient 12 for entirely squamous histology. For the non-squamous, they have used permetrexate, and for the non-squamous, they have, for the squamous ones, they have used gemcitabine. An interesting situation, one of the only times where a molecule has been based on two phase 3 trials, having two different histologies, looking into a situation where there are not much other options, especially in squamous cell carcinoma. So this is what I will say about these things now. One is we have a recommended as of today for patients without any first line mutations would be chemo with immuno, and the immuno agents we have started coming, cost has come down. We have the Chinese drugs, some of them do work very well, and in the second line and beyond is without an actionable mutations, we are struggling here. And the only agent as of today for which a study exists, although probably other agents would also work, is atezolizumab for patients who have had a previous mutation, that is EGFR and ALK based on the IMpower 130 and 130. So as of now, for first line, the Empower Lung 1 has given approval for semipilimab also. For the second line, we have the monotherapy based on the Auken Poplar with atezolizumab, the Keynote 10 for pembrolizumab, and nivolumab based on Checkmate 017 and 057. The two agents which many times end up being overlooked is the ramucirumab, which is ramucirumab dosi combination with the Revel trial. So this remains a good options for majority, which will be what our majority of our patients would be ongoing here, because of the factor that nearly 70%, as I mentioned before, do not have any genetic alterations. So coming back to the initial slide which we had, majority do not have any actionable mutations, and probably irrespective of PD-L1 expressions, we have a role for immunotherapy in these patients. And with this, I would like to stop that. Thank you.
Thank you, sir. I request the chairpersons and Dr. Shorab sir to gather for a group photograph. I now invite Dr. Krupa Shankar to take us through where bevacizumab stands in this era of immunotherapy.
Sorry. Can I use this? So very good afternoon and a warm welcome to everyone. At the outset, before I begin, I'm going to take the opportunity to congratulate the organizers and also thank them for the opportunity. So I'm going to probably try and resurrect bevacizumab over the next 15 minutes or so, because I think it's a very interesting topic as we were just discussing about. Does bevacizumab still hold a role in the current era of IO where we're spoiled for choices with VEGF TKIs, and so does VEGF inhibition still have a role? So I think that's probably the current status of bevacizumab. Is it still needed? And we're going to look at addressing that over the next 15 minutes. I'm going to look at revisiting a few of the bevacizumab trials and looking at whether there's still a role for EGFR TKIs plus bevacizumab in the current era. And what about the current ASCO recommendations, which say that PEM plus bevacizumab probably is out, as far as even maintenance is concerned. And I'm going to compare it with ramucirumab and the other VEGF inhibitors that we have, and the new kid on the block, which is ivonescimab. So we're going to look at doing all of that, and we're going to go deeper. So why then are we talking about bevacizumab again? We're looking at repositioning it in 2025. We know we are currently in the era of immunotherapy, right? I mean, like wherever you turn, whether it's PD-L1 less than 1, more than 1 to 50, 49%, or more than 50, we're always talking about IO. But what does VEGF inhibit? So I think it's all about the synergism. You're making a cold tumor microenvironment hot, because by doing a VEGF inhibition, you're actually starving the tumor cells of blood supply, which in turn actually upregulates PD-L1 expression. Thereby, it's the synergism that actually still holds key, and that's why we're still talking about VEGF playing a major part in the management of non-small cell lung cancer, albeit in different forms, albeit be it with VEGF TKIs or even with, in combination with ramucirumab or even the bispecific antibodies like ivonescimab as well. So it's no longer just a case of doing this. So this is definitely not what I'm going to propose. I'm going to say that bevacizumab does definitely have a role even in the current era because of the mechanism and the rationale behind it. So I mean, like, what does it do? It drives abnormal vasculature, and then looking at the vessel density and the endothelial dysfunction, which it normalizes. So like I said earlier, you're talking about the tumor microenvironment being modulated by VEGF inhibition, and the immunosuppressive cells are also reduced. Like we always talk about the TILs and TAMs, right? TILs are good. The higher your TILs, the more you're likely your immune checkpoint inhibitors are to work better. But the higher your TAMs or your Tregs or the T regulatory cells, the higher incidence of them, you know that your IO drugs may not work as well. So it's no longer just a case of just looking at the PDL1 or the MSI and TMB alone. You've got to move away from that and start looking at the tumor microenvironment as well. And that's where I think VEGF comes into its own, and especially when it's paired with IO as well. So I think that's an idea whose time has definitely come. It's been there for a long time. It's just that needs to be repositioned in the current era as well. So let's look at a few of the pivotal trials which led to the approval of bevacizumab in the first-line setting. This was the ECOG study, looking at again paclicarbo and the addition of bevacizumab, 15 milligram per kilogram. And the other thing is, I think how many of us in practice are willing to do 15 milligram per kilograms of bevacizumab? I think more often or not in practice, most of us would do 7.5 milligram per kilogram as far as non-small cell lung cancer is concerned. But nevertheless, all the data that we have in non-small cell lung cancer is for 15 milligrams per kilogram. And if you look at the overall survival, yes, this was statistically just a statistical jugglery done here, primary endpoint of PFS being met. And this is what led to only for adenocarcinomas. And squamous cell carcinomas, bevacizumab, we know that there's always an increased risk of bleeding and hemorrhage that can happen, which is why it wasn't really repositioned there. So histology does matter. But I'll talk to you about why probably ramucirumab is approved even in squamous cell carcinomas in the second line setting based on the REVEL data. I'll take you through that because there's a difference in the mechanism of action between bevacizumab, ramucirumab, and ivonescimab, and I'll take you through the key differences between them. But again, global validation was based on the AVAIL trial. We had European data and then the Chinese data. You can't keep them out of it, right? The BEYOND trial, which also looked at paclicarbo plus bevacizumab, did show an improvement in overall survival as well, which was both statistically significant. So you're getting to see Asian cohorts as well, well represented across these trials, and that's what led to the approval of bevacizumab. So, don't disregard Indian data. I know we're all drawn towards the US and the UK, but let's not disregard Indian data. So what about choosing when not to use bevacizumab? Like I said earlier, probably, in squamous histology, somebody with an active bleeding, uncontrolled hypertension, significant proteinuria. We talk about the nephrotic range or nephritic range proteinuria, more than 2 to 3 grams per day, nephrotic range proteinuria. You're not going to use VEGF inhibition in those sort of settings. So those are the key contraindications. Now what about optimizing chemotherapy combinations? We talk about continuation maintenance and then switch maintenance as well. So wherever you're talking about continuation maintenance, if you've gone ahead and started off with pemetrexed, carboplatin, on bevacizumab or pemcis and bevacizumab, should you do pemetrexed and bevacizumab? Or, would you do even, napacli with carbo and bevacizumab? Would you look at continuing the bevacizumab as maintenance strategies? And that's what we're going to look at. And has that actually led to an improvement in survival? So I think, the good old chemotherapy, they said, still good for your health. So I think that's absolutely there. These were a few of the key trials, the AVAPEARL and the Point Break trials, which led to maintenance bevacizumab with pemetrexed. So again, both the trials did show an improvement in progression-free survival. But again, this was Bev plus pemetrexed, but then the overall survival, it was actually inferior on the experimental arm. And this is one of the reasons as to why, if you look at the current ASCO 2025 living guideline, it just says that pemetrexed plus bevacizumab no longer recommended. I mean, like even though the NCCN gives that as an option, as a less preferred option, or a category 2B recommendation, pemetrexed plus bevacizumab, and I'll take you through that data as well. So this was the PEM plus BEV combination as far as the AVAPEARL study was concerned. The primary endpoint you could see was almost double, 3.5 versus 7 months. The primary endpoint was met. But nevertheless, with longer follow-up, you could see that the overall survival was actually inferior in the experimental arm. And that's one of the key reasons as to why ASCO came out with the recommendation saying that PEM plus bevacizumab no longer a great option. And again, this was a head-on-head comparison, the Point Break study, PEM plus BEV versus pacli and BEV. So, and you can see here, Pacli plus Bev actually did, as far as the PFS was, absolutely marginal, 6 versus 5.5 months, and no overall survival benefit, which is why still, if you're looking at using bevacizumab, the taxane backbone would actually be the way to go forward, and not pemetrexed. So just to compare between both the trials, did show an improvement in PFS, but no overall survival benefit, and this was only in adenocarcinoma. You're not talking about squamous cell histology as well. So that's probably, your reaction when you say it's probably FDA approved. Yeah, it is FDA approved. But nevertheless, you look at selecting those patients who might benefit the most and looking at using the drug carefully in that setting. So what are the lessons that we have learned from maintenance pemetrexed plus bevacizumab or maintenance bev as continuation? So I think it did show a PFS benefit, no overall survival benefit, and head-on-head versus nab-pacli or paclitaxel plus bevacizumab, you could see that the overall survival was inferior with pemetrexed plus bevacizumab, and hence the current ASCO recommendation saying that you're not looking at doing that for all your patients. And again, so there is a Japanese data as well showing that there was an PFS improvement. But remember, bevacizumab has always been a drug in search of a disease. And that's the classical way of describing the drug. But nevertheless, I think in non-small cell lung cancer, especially with the cost constraints available for other expensive molecules, with the advent of biosimilars in the Indian scenario, it does definitely hold a role. And the ASCO 25 update as well tells you that nab-pacli plus bev still remains a combination. And I'll take you through other combinations a little bit later on. So this is in a nutshell as to what the ASCO 25 does recommend. IO plus chemo, definitely here to stay, not denying that. But what about the ABCP regimen? We're talking about a quadruplet here as well. Atiso, bev, pacli, and carbo. And again, there is data, I'll show you through that as well, where you cannot look at substituting paclitaxel with pemetrexed. You can't do ABCP where the P is pemetrexed. That hasn't actually shown any benefit. So it has to be a pacli-carbo background with atiso and bev. So what does bev, the addition of bev actually do? I will go ahead and take you through that. And what about if you have contraindications to immunotherapy? Somebody with active autoimmune disease or somebody who's not eligible for IO, definitely bevacizumab comes into its own there as well. So it's absolutely on precision, looking at identifying the right patient who's going to benefit with VEGF inhibition. So I think that's the gold standard. What about in EGFR mutant disease? Do you still have a role for VEGF blockade? The same still holds good. Like I said earlier, you're looking at making whole tumor microenvironment hot, and that's where the synergism comes in. Because whenever we talk about EGFR mutation, remember the downstream signaling pathways, the ERK-MEK pathway also gets activated, and then you're coming into its own because VEGF inhibition does act on the tumor vasculature, and that's why you're looking at combining EGFR TKIs with, again, VEGF blockade as well. And you have a host of trials that have led to the approval of those, so the biology definitely does matter. So the earliest of them was the Japanese data, JO20. This was again phase 2 data. Nevertheless, did show an improvement in PFS, 16 versus 9 months, something that we've seen across the board with all the TKIs in the first line setting. Then again another Japanese trial, but this time phase 3 data, NEJ026. There again you could see that the PFS benefit did seem magnitude of benefit was slightly lesser when compared to the phase 2 data, but that's actually what happens whenever a trial goes on from phase 2 to phase 3. And all of these trials they never showed any overall survival benefit, which was one of the major criticisms of all of these trials. And even if you look at ramucirumab plus the RELIA data, ramucirumab plus erlotinib did show an improvement in PFS, but no overall survival benefit. And again, the key thing, they excluded patients who had brain metastasis. So I think, key question is the efficacy of bevacizumab in patients who have brain metastasis. That's always been another question mark and a challenge as well. So, which is why, again, what about if that was the issue, then why not add osimertinib plus bevacizumab? Do we have data to do that? There have been a lot of trials looking at addressing this question as well, phase 2 and phase 3 data as well, presented at ASCO 24, the WJOG trial as well. Unfortunately, they were all negative trials. So that's why you don't get to see that combination of osimertinib plus bevacizumab being approved. And again, a couple of trials looking at osimertinib plus ramucirumab as well. The OSIRAM and the RAMOS trial. OSIRAM was Japanese and the RAMOS was again US trial. So both of them phase 2 trials, but again, the RAMOS trial looked at using bevacizumab 3 weekly, did show an improvement in PFS, 25 versus 16 months, whereas the OSIRAM actually did poorly. The primary endpoint of PFS was not met. So you're getting to see mixed results when you combine osimertinib with either bevacizumab or ramucirumab, and which is why none of those combinations have been approved. It's only the ramucirumab plus erlotinib combination that's approved based on the RELIA data. So I think probably less actually is more. You don't necessarily have to combine it with VEGF inhibition as far as EGFR disease is concerned. And again, the data that I was just alluding to earlier, CNS efficacy does remain a question mark as far as the VEGF inhibition is concerned, as far as EGFR plus VEGF inhibition is concerned. And I've already talked to you about why we should probably look at adding VEGF plus IO as well. So I think, it definitely does. The synergism is important as far as VEGF plus IO. You're basically starving the tumor of blood supply, and thereby you're making the immune microenvironment more conducive to checkpoint inhibition. You're releasing the brakes of the immune system. Thereby you're helping to identify, seek out, and destroy the tumor cells by your T cell activation. And VEGF definitely helps. It upregulates the PD-L1 expression as well. So absolutely no denying the fact that it's absolutely hard right now. And this was the ABCP trial. Like I said earlier, what does the addition of bevacizumab do? Why can't you just do Atizo and Napacli and Carbo? I'll take you through that. But remember, probably, stratification factors here were important. So you're talking about patients who had a large volume of disease, more than 2 metastatic sites, and liver metastasis as well, and patients who even had a PD-L1 less than 1. So these were the 3 subsets that actually did seem to benefit even in this trial as far as the subgroup analysis. Albeit they were not powered adequately enough to look at answering this question, but at least a couple of them were pre-specified subgroup analysis. So it could be meaningful as far as hypothesis generating is concerned. So somebody with, perfect, couple of minutes. So I think, somebody with liver metastasis, large volume of disease, low PD-L1 expression, you justify it in adding or doing the ABCP regimen if they have no concerns with the toxicity. So it's no longer just about your NCCN guidelines, and liver mets, patients with liver mets definitely did seem to benefit, albeit based on a subgroup analysis. So men not have much of a choice there looking at doing the ABCP. And what about combining it with pemetrexed? Like I said earlier, well, then you're not going to getting to see the same benefits, and that's been across the board with even Atizo, Napacli as well. You can't switch even Napacli instead of Pacli. That also did not seem to benefit. So if you're going to look at using the ABCP regimen, stick to taxanes, do not switch over to pemetrexed. Napacli plus Bev in the second line setting, again, there is data to do that as well in the second line, but nevertheless not very strong data, phase 2 data, but again has shown improvement in PFS. What about other Bev and taxane regimens? Again, instead of nab-paclitaxel, you could use conventional taxane as well with bevacizumab. Key concerns are with toxicity, neuropathy, hypertension, and proteinuria. And what about ramucirumab? Can you use bevacizumab instead of ramucirumab? Key thing to understand is the difference in the mechanism of action. So bevacizumab, we know, acts on the ligand, the VEGF-A ligand, whereas ramucirumab works on the receptor, the VEGF-R2 receptor. So, even though ultimately you're talking about targeting the VEGF pathway, they work in different ways, which is why it's not right for us to actually look at substituting the drugs, in practice as well. And also another reason as to why you get to see the approval even in squamous histology for the REVEL data. This trial included patients with squamous histology. Around 25% of patients had squamous histology. Albeit you're getting to see a PFS benefit, overall survival, not really great. And what about the real world data post-IO? Again, ramucirumab did show an improvement as far as the PFS was concerned, but OS, again, not very striking. So the histology matters. Indian biosimilars, we now have access to a lot of biosimilar bevacizumab. Remember 3 A's, availability, accessibility, and affordability. I think those are the key as far as low middle income countries like India are concerned. So absolutely justified. We still have the role for bevacizumab, albeit even, when you're talking about extrapolating the data and using it with nab-paclitaxel in the second line setting when somebody's progressed on your first line IO plus chemo. I think key considerations here are, let's not forget about the cost. The cost definitely plays a huge role in the Indian scenario. So I think all said and done, science is science, but this also is relevant. So toxicities, again, nothing much to write home about. The routine hypertension, proteinuria, bleeding, and you're looking at holding the drug at least for 4 to 6 weeks prior to surgery and restarting it at least after 4 to 6 weeks. So what about ivonescimab? I think that's probably where I'm going to finish or end up here. So is it the same as doing Atizo and Bev? Or is it something different? It's a bispecific antibody, and it depends on, the key term there is cooperative binding. Cooperative binding means that it's greater than the sum of its parts. What happens is that, like I said earlier, VEGF upregulates PD-L1 expression and increases the binding affinity to the PD-L1 receptor. So this drug actually has a higher binding affinity to the PD-L1 receptor by more than 10 times as compared to your routine IO drugs. which is why it's not the same as just giving Atizo plus Bev together. Ivonescimab is in a class of its own. It's a bispecific antibody looking at targeting PD-1 plus VEGF. Definitely yes for me, and it's probably the only trial, only drug Asvar that's actually shown an improvement in PFS head-on-head against King Keytruda or pembrolizumab. So I think, exciting times ahead. We'll wait for the overall survival data on that trial, the Harmony trial. But nevertheless, even in the EGFR setting, in the second line, looking at combining it with chemotherapy has led to an improvement in PFS. So the algorithm, as of right now, stands at IO plus chemotherapy, default, ABCP even post EGFR TKI progression, again based on post hoc analysis, hypothesis generating, and again second line options, your ramucirumab plus docetaxel, again ninditanib as well, LUM trial. In the Europe, EU has already approved it, not yet FDA approved as well. And looking at the future with ivonescimab, PD-L1 plus VEGF, bispecifics are here even in solid tumors. Sounds good to me. So I think I'm not going to get into that. I'm going to conclude, get to my trial. So I think, there are a lot of evidence gaps, limited randomized data on second line. You need probably larger real world evidence. Ivonescimab probably is the way to go forward in the future. So I'm going to conclude by saying bevacizumab definitely is not obsolete, even in the current scenario. We're spoiled for choices with VEGF inhibition. It's still here to stay, just that it has to be carefully selected only in a select subgroup of patients. Like I said earlier, somebody with a large volume of bevacizumab. And again, even in EGFR positive disease, EGFR 19 versus 21 exons. Exon 21 L858R mutation, probably yes, there's still a role for doing the combination. Exon 19 deletion, probably monotherapy alone is good enough. So I think the key probably lies in individualized approach. There's absolutely no one size that fits all. So I think we'll have to look at finding the right fit for each patient. So with that, I'll conclude and say thank you all for your patient listening. I'll be happy to take any questions if there are any. Thank you.
Thank you, sir. I request the chairperson, Sir Dr. Krupashankar sir, to gather for a group photograph. Moving on, I now invite Dr. Senthil Rajappa to give a talk on the topic Transforming the Unresectable Stage 3 Non-Small Cell Lung Carcinoma Landscape from Pacific to LAURA.
Good afternoon, and for one last time you will have to put up with me. So I'm going to talk on two specific things and some very broad issues that I'll try and address. I thought I'll try and concise everything that you've listened over the last 2 days as far as locally advanced lung cancer is concerned, so that it'll be easy for you to carry this home. I'm sure you've seen this table on the left side multiple times in the last 2 days. It tries to tell you about what is unresectable, resectable. People would have also told you that these are gray areas, it's blurring, and then based on the systemic therapy, resectable moves to the other way around and unresectable moves to resectable, and so on and so forth. It's important to make sure that you do multidisciplinary care. So here are the questions I think we should ask when we see a patient with locally advanced lung cancer. Is it operable or not? Is it biomarker driven or not? If inoperable, is this patient fit for definitive chemoradiation therapy or not? And then finally, as I said during my earlier panel discussion, is the patient willing for this particular intervention or not? So operable or not, biomarker driven or not, if inoperable, fit for chemoradiation therapy or not, is your patient willing for this particular intervention or not? So that quickly takes us to the Pacific study. This is in patients with locally advanced inoperable. Now when I say inoperable, it is inoperable at the time that this patient was diagnosed with non-small cell lung cancer. And if your patient had not progressed following definitive chemoradiation, these patients within the next 1 to 42 days post chemoradiation were randomized to durvalumab for a year or placebo for a year. The co-primary endpoints were PFS and OS. This is the 5-year follow-up of the Pacific study, clearly showing you a 9% improvement in the overall survival, 0.72 the hazard ratio, which means it's a 28% risk reduction of dying if you took durvalumab versus not. The PFS is also better. The 5-year PFS benefit, 33 versus 19%. So I think if you have a patient who fits into this criteria, this is the intervention to go behind. Now, there are a couple of sets of patients who actually do not benefit well with this intervention. One is if you have an EGFR mutation. This is the forest plot for overall survival. This is one of the co-primary endpoints. The other group that doesn't seem to be benefiting as well is a patient who has a PD-L1 that is 0. There's a lot of criticism regarding this PD-L1 analysis. In fact, in Europe, you have only an approval for durvalumab if you have a PD-L1 that's positive, but I don't think that's the most scientific way of interpreting this or the forest plot for PFS. I think it should be for all comers at this point in time, but if you are in a healthcare system and you want to prioritize, you want to give a patient who is most likely to benefit from this intervention, then I think it's okay to take the PD-L1, but for that, I think it should be a broad approval. The other concern that all of us have when we do this intervention is radiation pneumonitis. Fortunately, the radiation pneumonitis, whether you start durvalumab early or whether you start durvalumab late, that's less than versus more than 2 weeks, the incidence does not seem to be any different. But as you can clearly see, it is much higher than what you get with placebo. So that is something that we should keep a watch on and make sure that you do the adjustments, stop on time, steroid, whatever is necessary to make sure that your patient is comfortable. What more data do we have on the Pacific study? We have Pacific 5 and Pacific 6. Remember that in the Pacific study, there were only a small set of patients who had sequential chemoradiation therapy. So what did we know from the Pacific 5 and 6? That the benefits were similar whether your patient had concurrent chemoradiation therapy, which is the standard, or sequential chemoradiotherapy, which is something that we do in patients if they have a large mass and you can't do concurrent chemoradiation on day 1, patients whose performance statuses are not that very good. So these are patients where we would sequence. So whether you sequence or you do concurrent, the benefit of durvalumab seems to be there in either sets of patients. We also now have meta-analysis and a lot of retrospective real-world data to say that this intervention is very much doable in the real world, and the results are very much similar to what you get in the pivotal study. But the question is, where do we go from here? Can we manage EGFR or other driven patients with unresectable non-small cell lung cancer? We'll come to this question in a moment. Now, what else can we do? What else have people thought about? One intervention that people have thought about is, instead of completing your concurrent chemoradiation and then starting durvalumab, can you also add the durvalumab to the concurrent chemoradiation phase? And that is what Pacific 2 tried doing. But Pacific 2, though in terms of its hypothesis was expected to be a huge success, unfortunately it was a huge failure. So if you brought that immune checkpoint inhibitor during the concurrent chemoradiation phase, you actually got into more trouble rather than helping the patient. Now, there are many reasons why we think this has happened, but remember that it was not the increased incidence of pneumonitis when you added the immune checkpoint inhibitor concurrent with radiation therapy. It was a higher incidence of sepsis, it was higher incidence of hemoptysis. These led to some fatal events, hence compromising the outcome for these patients. So doing concurrent chemo, radiation, immunotherapy has failed, and that is not an intervention that we would want to use on our patients in the clinic. Now, if concurrent has failed, let's go one step ahead. Let's try and do some neoadjuvant chemoimmunotherapy, then do chemoradiation therapy, and then do the immune checkpoint inhibitor. Right? Pacific was chemoradiation therapy followed by the immune checkpoint inhibitor. That's Pacific 1. Pacific 2 is concurrent chemo, radiation, immune checkpoint inhibitor followed by an immune checkpoint inhibitor, failed. The third intervention, concurrent chemo and immune checkpoint inhibitor neoadjuvant, and then you go and do your concurrent chemo radiation and then follow it up with immune checkpoint inhibitor. Now, the more important question that we would like to ask here is that if an unresectable patient becomes resectable, should you still put that patient through radiation therapy or should you put that patient through surgery? In fact, there's a lot of debate that happened in the morning. There's some early evidence starting to emerge based on some phase 2 data that if your unresectable patient becomes resectable, surgery might be a better intervention compared to radiation therapy. Now, these are small data sets, so this is not something that we would routinely do in the clinic. In the clinic, we will stick to the guideline and decide inoperability at diagnosis and take it from there as the guideline algorithm would suggest. But this is an area that we need to keep watching for more data. We left Pacific 1 asking the question, what do we do if somebody has an EGFR mutated disease? And that is what this study called as the LAURA study tried to answer. Very similar to the Pacific in terms of design. These were patients who were unresectable. Instead of doing durvalumab, you did osimertinib. Durvalumab stopped at 1 year. Osimertinib continued endlessly. So those were the differences. So there you had some EGFR patients, they didn't benefit. You did durvalumab for a year. Here you're doing osimertinib endlessly. Now, a very important question that comes up many times during discussions is, should you have had a third arm where you didn't have concurrent chemoradiation at all? Should you have just done osimertinib, and would your patients' outcomes have been similar? I think that was not the question that these people were trying to answer. We would have loved to see that, but that's not what it was meant to be. The other important thing is that about 50% of patients post-chemoradiation therapy had a PET CT scan, which was typically not the case in patients who were enrolled on Pacific 1. Now, you do a PET CT scan, there's a higher probability that you will upstage a lot of these patients, but it was the similar percentage in both of these arms, so we would expect that they kind of evened off and would not impact the outcome. Third point, 86% of patients in the control arm took osimertinib when they progressed. Why is this important? Because this can confound the overall survival results in the LAURA study. Typical set of patients, concurrent versus sequential, most of them had concurrent. Common mutations were taken for this. The predominant was stage 3B, a sprinkling of 3C, and some of them were 3A. Now, this is the kind of Kaplan-Meier curve that you would love to see in a study. You can drive an A380, you can put a giraffe in between these two curves, whatever you want to do, right? Hazard ratio of 0.6, that's something that's a dream hazard ratio for any drug, okay? 86% risk reduction. Overall response rate, 57 versus 33. Things which you cannot really dispute, you really can't talk much about this and say, I don't like this about this Kaplan-Meier curve. It's a dream Kaplan-Meier curve, progression-free survival benefit. Again, nothing much to read from this forest plot, everything favoring the osimertinib arm compared to the standard. Now, why is it that osimertinib did better? Systemic failures were lesser in patients who took osimertinib. This is number of patients, okay, 22 versus 68, that's not percentage. So 3 times higher number of patients who were on the placebo failed. 3.5 times higher patients failed in the central nervous system, with this very important place that you expect these patients to fail, and you want to protect these from these failures. The overall survival is not mature. It is not positive at this point in time. And I also said we may have a lesser likelihood of showing this because majority of patients who progressed crossed over to osimertinib. Do we need to give indefinite osimertinib to these patients? Can we use ctDNA in order to personalize? I don't think we have answers to any one of these questions. What about adverse events? There were interruptions in just over a half. 1 in 6 patients actually ended up discontinuing their osimertinib. There was pneumonitis with osimertinib, so we need to be very careful when we are using this intervention. Keep a watch and act appropriately depending upon what complication you're seeing. Neoadura is something that's raised a lot of eyebrows. Again, should you be using neoadura? First thing, neoadura was done in a set of patients who were operable. They were not inoperable non-small cell lung cancer. Very interestingly, if you look at the arms were randomized to either osimertinib plus chemo or chemotherapy alone. The results, I would say, are a little disappointing. The primary endpoint was major pathological response, a quarter on osimertinib and osimertinib plus chemo. So chemo doesn't seem to be adding much to that set of patients, but the MPR in the chemo arm only was about 2%. Pathological complete response, not much. Downstaging was there. Margin negative resections, no different. So you seem to be downstaging a set of patients, but is this likely to give you an improvement in the long-term outcome is something that we don't know. So would you use neoadura in a set of patients? Probably yes, a bulky N2, a place where the surgeon thinks he's not very confident about getting around the tumor. So these may be some areas where you may want to do neoadura, but in the majority, we would not use this intervention at this point in time because of the endpoints that we have looked at and lack of long-term outcome data. So that's how I would put neoadura. Before we end, what about other driver mutations? Suppose you find a MET exon 14 skipping, what would you do? Suppose you found a RET, what would you do? It's very intuitive to say that I would use the targeted therapy, but do we really have data to do that? We don't have at this point in time. The only study that has been closed because of a positive outcome is one of those libretto studies. But interestingly here, patients took either surgery or radiotherapy. So this is a lot of patients who had multiple interventions into one study and then consolidating them with sulpercatinib, showing that there was a betterment in the outcome. So we really don't know. We have to wait for the publication or at least presentation in a meeting before we say, okay, if you have another mutation, I may want to use a TKI, I don't want to use the Pacific strategy, and so on and so forth. We can discuss it if we have some time. So to conclude, Pacific established durvalumab consolidation as the standard of care post-definitive chemoradiation in unresectable, that word is very important, unresectable. EGFR mutant patients derived very little benefit. LAURA, which is consolidation osimertinib, achieved much better PFS. The overall survival is not significant at this point in time. The majority crossed over, so we may not find an overall survival benefit. Osimertinib is now the approved standard of care for patients with unresectable stage 3 disease, and hopefully we will get better, more robust and scientifically backed answers to many of the other questions that we are asking, especially to the question of whether you would use a TKI to consolidate responses to either chemoradiation or as an adjuvant post-surgery in loco-regional disease. Thank you so much for that very patient hearing, and if there are any questions, I can take.
Thank you, sir. I
think
yes.
For want of time, we will not take questions.
We now move on to session 4, and we start with a cross-panel discussion on brain metastasis in non-small cell lung carcinoma. I invite the moderator for this session, Dr. Prashant Ganeshan, and I also invite the distinguished panelists, Dr. Krupa Shankar, Dr. Bhavesh, Dr. Tejeshwar, Dr. Divya Khosla, Dr. Prahlad, and Dr. Kranti Kumar.
Thanks very much to Prashant and Sandhya for having us all here. It's been a fantastic 2 days. And so we'll get on with it. It's called the cross-stack panel. Currently, I think the only cross is between the stomach and your brain. So we'll get on with it. So we have a mix of people. Instead of Dr. Ullas, we have Kripa. So we'll get on with it. What we're going to do is discuss about brain metastasis. We just basically discuss the who gets it and how do you work up. Some of these things were touched upon a bit in the previous panel discussions. And then we'll talk about neurosurgery, radiation, and then the systemic therapy. So the case is a 75-year-old female presented with cough and X-ray showed a mass. A PET CT looked like a lung primary, multiple bone metastasis, and some suspicious brain lesions. So she had an MRI which showed 3 small lesions. She is absolutely asymptomatic for the brain lesions. So we'll start with a very basic question. Tejeshwar, how common is brain metastasis at diagnosis in lung cancer, and how many are symptomatic, how many are asymptomatic?
So overall, the incidence is going around in between 20 to 25%. But basing on the age group and all those things, it will change, and mutations somewhat higher. So the symptomatic, in my practice, I'll say nearly 60% or around the patients are symptomatic, because mostly they'll come with headache, or that is most common presentation sometimes. And around 40 to 50 will be asymptomatic.
So it all depends on how you go chasing after it. If you're doing MRI and you're chasing, you're likely to get more asymptomatic metastasis. And if you're only doing basic investigation, CT or something, you're getting more of symptomatic metastasis. So the question, Bhavesh, what is your practice? Do you do MRI for everybody? We heard today morning Sujit was telling in his practice that you do MRI for all patients. So otherwise metastatic patient, CT scan is not showing brain metastasis. Do you do an MRI or not?
So in asymptomatic, we will not chase it further.
Okay.
We'll stop at a PET scan, PET-C CT scan, which will pick up. If it is not picked up and if it is asymptomatic, we will not chase it.
Kripa, anything else?
No, agreed, sir. I think, I mean, like if the patient is completely asymptomatic, I don't necessarily push them towards getting an MRI if they've done a whole body 18 FDG PET CT.
Yeah, I think that's more or less aligns with the recommendations also, unless you're in a trial or something where you're very keen to pick up even this asymptomatic ones. You don't have to push for it. If you do it, it's not wrong, but you will probably pick up another 5 to 10% extra. So the question is it going to really change your management if you pick up one very small met? That is the question here. So we'll come to that. So does it depend on the type? Because Tej, you did mention that if you have some certain subtypes, your risk of metastasis is higher, like some targeted, some mutated lung cancers. So if suppose a patient has got an EGFR mutation, would that push you to do an MRI, or you're okay?
If the patient is having an EGFR mutation, so I would like to do, and planning, for example, he is not having any metastatic disease. So in that situation, I would like to get an MRI for this patient, because sometimes if he is having an metastasis in the brain, so I would like to tend to give an osimertinib-based therapy. So in that way, it will help me if the patient is having an non-metastatic disease at baseline. And also, otherwise, in an asymptomatic patient, apart from this, if he's not having any driver mutations, I will not ask for any MRI for in a routine practice.
So this is a study from All India Institute of Medical Sciences, Prabhat and group. So this is patients with newly diagnosed non-small cell carcinoma. Again, in this study, only about half of them actually had the brain imaging done. And a very small fraction actually had an MRI brain done at baseline. So this is something like what reflects the real world. And about roughly what we talked about, 1/5 of them, when you imaged, you found brain metastasis, and roughly half are symptomatic and roughly half are asymptomatic. Solitary in 41%, 2 to 4 in 19, and more than 4 in 38%. And at baseline, leptomeningeal disease was extremely rare, only 1%. And you get all these kind of presentations in the brain metastasis. It can be hemorrhagic, midline shift can be there, but most of them is just some lesion with perilesional edema, some contrast enhancement. They looked at what factors predicted brain metastasis. They found it's more common in younger age. Persons with worse ECOG, probably just reflecting more disease load, and slightly more in adenocarcinomas. This is very well known. And it was not associated with the extracranial stage, at least in that. But again, they would have mostly imaged advanced cases. And they could not find an association with EGFR and ALK, but numbers were less, so we really don't know. Anyway, so this we already talked about. With MRI, you can get up to 35%. And if you have higher nodal burden, you get more metastasis. And some studies in EGFR, ALK have shown up to even 50 to 60% brain metastasis. So that might push your this thing. So now we go to the actual management in this patient. We'll start with Dr. Kranti Kumar. Sir, what are the indications for surgery in a patient who comes to you with brain metastatic disease? When would you want to come in and operate?
Yeah, definitely when the patient is symptomatic and solitary lesion. I think there is no controversy in that. This absolute indication is a solitary lesion with this thing. And we can debate about stereotactic radiosurgery versus open surgery depending on the size of the lesion. Okay. So if the lesion is sub 3 centimeters, then radiosurgery is absolutely fine. So what modality of radiosurgery is depends again availability of the machines and affordability of the things. And if the number of lesions are more, then again I would push for radiosurgery rather than open surgery. But again, when the number of lesions are more, if we can resect all the tumors in a single setting, and if they are not suitable for radiosurgery, say for example we have some 5 centimeters lesion and 2 or 3 small lesions which are smaller ones and closed by. No, I don't need to turn over the patient, do another craniotomy on the left side, or I have to do posterior craniotomy. Then the thing would be different. But if I can resect all tumors, then surgery would be definitely better, and if the lesion is greater than 3 centimeters.
Okay, I was about to come to that. So anyway, since you brought it up, Dr. Divya and Dr. Prahlad, so any of you can take this. So where would you want to come in? And then we'll come to this multiple things later. There's something which I specifically wanted to discuss that.
So the solitary lesions in the eloquent areas can be taken up with SRS. So okay. That is where the surgery becomes difficult. Also depends upon the performance status of the patient. So larger tumors with mass effect, yes, surgery can be done. Otherwise, SRS can be done easily up till 4, and now studies are coming up till 10 brain metastasis as well. Okay. But then you have to be very careful regarding certain constraints, including the brainstem, optic chiasm, and the V12. So that is what we do. Okay. And even if the patients underwent surgery, the resection cavity should be treated with post-operative.
Yeah, we will come to that. So after surgery, we'll come to that. So upfront, the message is for the residents, whoever this thing is that if it's large, midline shift, solitary, symptomatic, prefer surgery. Something smaller, which is going to be in some very crucial area, patient is not fit to go for a surgery, then SRS is probably the way to go. Dr. Prahlad, you agree with this?
Cystic lesions, they don't respond so well to radiation, or at least they take a very long time.
Okay.
Or if it has bled, these are strong indications when we would towards surgery.
One important thing which Dr. Kranti brought up. So you have one, let's say you have one big lesion, and then you have 2 or 3 smaller lesions. Let's say one is 5 centimeter, you have another 2 centimeter, 1 centimeter, something like that. In this situation, surgery, stereotactic, or whole brain, how do we make the call? Where does whole brain radiation come here at all? Does it come here at all, or is it all SRS? I mean, the facilities are available. How do you place this?
So, yeah, like if I can resect a single craniotomy, or say, for example, when I go into surgical nuances, say, for example, there are two lesions in both in the frontal region, it is easy to resect in a single time.
Okay.
So if I have multiple lesions side by side, I can do an extended craniotomy, I do a big craniotomy and then take out the tumors. Still, one is large, provided one is large. There is no debate about SRS in that.
Okay.
So surgery is the ideal thing, because post SRS, the edema develops more for a brief period of time. So the risk of worsening the neurological deficits is very high. Okay. So that is when I always go for surgery. So this is, but if there is one big lesion on one side, say for example anterior on the right side, and the other one is somewhere sitting in the posterior, small ones, then we can use multiple modalities, both SRS and surgery or whole beam. Again, the debate of SRS versus whole beam is a bit
that's separate. Okay. So Dr. Prahlad, you agree? So I think it's an important thing to discuss in MDTs. Because you can tailor the therapy regarding the patient's requirement, and you can bring in two modalities also. Yes. So I think that is very important here. Again, going back to my question, in a patient with up to how many, you brought it up, Divya, but up to how many are you comfortable giving SRS, and at what point you will say that I'm just going to give whole brain radiation to this patient?
Patient has diffuse metastasis, whether you find that there's no point of doing SRS and you're not able to save adequate brain parenchyma or not able to achieve constraints, you move to WBRT. And in that cases, you can do hippocampal avoidance for that patient. Okay. But in my practice, I have safely treated up till 5 brain metastasis.
Up to 5 you can do.
5 is a good number for somebody who's starting off. Now there are papers saying even 15 brain metastasis can be treated with SRS.
But do we have data to say that when you are giving 5 separate SRS, that is better than giving whole brain radiation?
Absolutely. I mean, the cognitive decline is not there. Okay. Otherwise, the overall survival remains.
It's not going to change, but the toxicities are going to be lesser. Yes. Okay. So whenever possible, SRS. If not, then whole brain.
If not, hippocampal avoidance, whole brain RT. If not, worst case, whole brain RT with memantine.
Yeah. Okay.
If not, just whole brain RT.
Okay, great. I think that was very clear.
Small addition I recollect. If there is a debate about surgery plus GKS or whole beam radiation therapy when there are multiple lesions, I would also give one contrary picture where I can take out the symptomatic one, the non-resectable, asymptomatic, I call them asymptomatic. If they are good chemo responsive, especially when so many of you are discussing about non-small cell where there are so many receptor additions and good chemotherapy is providing, then I can just go with the rest with the chemotherapy, because surgery plus GKS or whole beam, overall patient's long-term cognitive decline and all those things coming to the play. Then monitor the patient while on chemo about the progression of the asymptomatic ones.
Okay. We'll come to that systemic therapy part. Kripa, you want to add?
Sir, one small point, sir, sorry. There is emerging data that surgery can lead to up to 20% risk of leptomeningeal metastasis. So the new concept is pre-operative SRS, where we give SRS if there's a very good harmony between all the departments in the oncology department, neurosurgery, all of them. Pre-operative SRS is coming up in a big way to reduce the risk of leptomeningeal spread after surgery, which is almost to the tune of 20%. So
plus the tumor volumes are also small. When you're giving it post-operative, you are radiating the cavity along with the dural aspect. So the volume becomes larger.
But doesn't that bring what Dr. Kranti brought up? You have a fairly large metastasis, let us say, and you already have edema and issues, and you give some pre-op. Isn't there a risk of worsening in that patient if you give?
In selective cases, not all the cases.
Not all cases.
Not, frankly, symptomatic patients, bleeding patients, not those. If surgery
Some
is being planned,
relieves the symptom faster than.
If surgery is being planned, pre-op SRS might be a better option than post-op SRS is what the guidelines are going towards.
So I'm just showing one. This is a very old study, which I mean, in lung cancer terms at least, this was published in 2010. So this is adjuvant whole brain RT versus observation after surgery or radiosurgery of 1 to 3 cerebral metastases. And this study showed that there is some reduction in intracranial relapses and neurological deaths after adding radiation after your local treatment. So keeping this in mind, and this is not specific for lung cancer, this is in any patient with metastatic brain tumors. So where do we place after Dr. Kranti does the surgery? When do we give additional radiation to these patients? To all, or is it selected, or where does this place?
All patients.
All patients.
So, okay. So based on this data, at least, it reduces, there is no, again, there's no difference in overall survival in this paper, but it reduces the intracranial recurrence rate. So in that situation, what do? You do radiosurgery or
Cavity
you do
SRS.
whole brain RT?
Cavity SRS.
Cavity SRS.
So many times we do fractionated SRT. So
Okay.
because the size of the cavity and the preoperative tumor we have to take into account.
Okay. So I think the message here is that even if you operate based on this data, it's a good practice to give radiation additionally because it reduces the intracranial recurrence. But again, you have to place in the context of what kind of tumor subtype is it. So because I think we mentioned that. So nowadays you have some very good systemic therapies for certain subsets. So we really don't know in the current era whether it adds something, but based on this data, yes, if you do not have some very specific mutations and all those things, you should consider additional radiation. Yeah, I think we talked about that. If the patient has got otherwise oligometastatic disease, is there a resection for, is there a role for resection of brain metastasis with a curative intent?
One large symptomatic and one small symptomatic. Yeah, definitely. Because when there is a mass effect or symptoms, the risk of rapidly progression is, again, we have to, this is a tricky area where I have to talk to the patient what they are expecting, and putting some patient under the knife of a neurosurgeon is not an easy decision, and we have to discuss about the multimodality of treatment. Many times by the time patients in neurosurgery's perspective point of view, I say anterograde and retrograde, how the patient is moving. If he is moving from neurosurgery department to oncology department, I would be happily to operate and then send him away. But if the patient is coming from medical oncologist to me, then I would tread a bit carefully, because surgeons think alike, physicians think alike, and none the medical oncologist, there is a whole set of physicians. So I tread carefully there. So I have to discuss with the patient and tailor it to,
Okay. So, yeah, I think the current era, we again had the discussion in the previous panel discussion. There is a lot of push for curing, trying to cure or trying to extend survival. So, pushing more and more local therapy even in the metastatic setting. So, I think we need to rethink whatever oncology we have learned. And so, that's where it is.
So, regarding whole brain RT, sir, I've had even one bad patient can give you a nightmare. Just like, say, for a medical oncologist, one extravasation can make you start thinking of ports for as many, virtually all patients. Now, survival is good in even in brain metastasis. Earlier, we used to say 3 months, 6 months. Now, people are regularly, routinely living to 2.5 years. And whole brain RT patient, I've had a young man, whole brain RT. At that time, I thought, he's not going to live long. We'll give whole brain RT. 2.5 years, year later, he's still okay, he's doing well, but his cognition is so bad. He's just a blank, staring look, at the family, and the families. Then now, today, 2.5 years later, they say, sir, you could have thought of other things. You should have thought of other, they've heard, they've read SRS, hippocampal avoidance. So, one bad patient can really make you start thinking that, you should have done things better. Now, survival is better. The indications for whole brain, full whole brain without hippocampal avoidance is quite less, unless there's a lesion at the hippocampus or very close where you can't give a good enough dose to control the disease. Otherwise, hippocampal avoidance or at least memantine, but memantine really doesn't do much. So hippocampal avoidance is one of the only ways to save.
I think it's a very important point. So it's not a dismal prognosis for a brain metastatic lung cancer anymore. So many of them do extremely well, 2.5. I think we all have in our experience patients going on for 4 years, 5 years also now. So it's important to limit the toxicities as much as possible. So I think that's a very important message. Thanks for that. Now, this patient turned out to be EGFR exon 19 deletion. And so the local therapy for brain metastasis, I think we already touched upon that. Which are the specific situations where you need not give local therapy? Tejeshwar.
So definitely EGFR mutated and ALK positive. So these are the two conditions definitely I'll consider not giving a local therapy. Now emerging data is there for pembrolizumab also, where pembrolizumab plus chemotherapy is having very good response in patients with asymptomatic disease. So this is the one which these are three groups I will consider. I don't have any experience with BRAF mutated patients.
So my question is, osimertinib, do all patients afford and can they take, I mean...
Suppose you cannot afford. So I think the guidelines are very clear here. Only in situations where you are using the corresponding TKI. So for something like gefitinib, this is not applicable. So I think that we should specify that.
So if this is only for patients who can afford the ALK inhibitors and EGFR inhibitors, especially second generation, third generation ALK inhibitors also. If the patient cannot afford, so in that thing we'll go with an, so mostly in my practice I will use chemotherapy plus or minus, gefitinib plus or minus chemotherapy. So in that situation, if a patient is having an asymptomatic disease at the baseline, what I am practicing is I will closely follow up those patients, and if they become symptomatic, then at that point of time I am consider giving radiation.
Okay. So Bhavesh, your standard patient EGFR mutated cannot afford osimertinib, and you are starting the same patient which I showed you, starting gefitinib plus chemotherapy, let's say. You would give cranial directed therapy, or like Tejeshwar said, you will do a close follow-up on this patient?
For asymptomatic, will not radiate, because that is not going to add anything to patient's survival or the quality of life. In fact, it may deteriorate the quality of life in asymptomatic patient. So we'll wait, we'll observe. Obviously, these patients are going to undergo CT scans or PET scans after every 2 to 3 months. So we'll anyways keep a close watch.
But if they are symptomatic, you will give the, if you are not using osimertinib.
Kripa, we'll lose patient.
In asymptomatic also, we'll, like I'll also see in MDT we'll discuss regarding the characteristics of the lesions also sometimes.
Okay.
So basing on the location also, sometimes in asymptomatic patients also consider giving an baseline radiation if there are any high risk features.
Okay. Kripa, any experience with immune therapy in this brain metastatic patients, non-mutated?
Yes, sir. I think if they have asymptomatic brain metastasis, then I think, combination of IO plus IO or NIVO plus EP, adding a CTLA-4 inhibitor also does help with the CNS penetration. So the intracranial response rates, we've seen that even in melanoma as well, where the intracranial response rate with NIVO and EP, are very efficacious, of course, as far as, even in non-biomarker driven or no actionable genomic alterations are concerned. But one point that I wanted to make about the earlier discussion, we know there are multiple scoring systems that are available that can help us differentiate between SRS or, even surgery as well. Are we still using them in practice, like the disease-specific GPA, the recursive partitioning analysis, the Rotterdam score, SIR score, and so on and so forth? There are multiple scoring systems that are available, but are we using them in practice to look at, looking at the number of, as far as choosing? Okay.
So the lung molecular GPA many times to tell about the estimated survival and the prognosis.
Okay, so sometimes, but not in common use. Yes. Okay, fine. So I think the message here is that if you have some very specific mutation and you're using the corresponding CNS active drugs, you don't have to push for local therapy, but please remember you have to be very specific here. That's the guideline actually. So this is just to show that
if you're using only gefitinib without chemotherapy, then strict follow-up of at least MRI alone.
If they are asymptomatic.
If they are asymptomatic, only follow-up with MRIs alone.
Okay. So this is the data in the FLORA trial and then the ALEX trial, where I'm not going into the details, which shows that you do pretty well whether you have CNS metastasis or not when you are using the second generation agents. Similarly, this is a meta-analysis, pooled analysis actually, not meta-analysis of all the pembrolizumab trials, again looking at the brain metastasis versus no brain metastasis. And here again you can see that there is the survivals are not hugely different actually. So if you use a good agent, you can get away without local therapy. Now this patient was started on pemetrexed plus carboplatin, and she could afford osimertinib, so we put her on osimertinib. Initial some toxicity, she was quite old, so she had to come down on the dose of osimertinib. She ultimately settled on a dose of 80 milligrams on alternate days. The pemetrexed we continued as maintenance. Now after 4 cycles, she had a partial response. The CT brain was normal. We didn't do an MRI at that point. And after 18 months of therapy, she came back with a headache. PET CT, no systemic progression, but in the brain there is a 3 centimeter lesion with some edema. At this point, how would you manage this patient? Dr. Kranti, will first start with you, and then we will go on to the others.
So this is this is a recurrence then. Then if it is 3 centimeters lesion with edema, either I would like to wait and watch and how bad the neurological deficits are. If it's just an headache, I think we can put her on steroids and wait for how the edema is progressing, how her neurological status is going on. But if it's worsening in her neurological status despite of the anti-edema measures, steroids or dehydration therapy, then I think we have to consider surgery.
But she has never got any cranial directed therapy earlier. This is the, I mean, baseline it was asymptomatic. We have just started on osimertinib chemo. She's done well. Now there is a definite progression in the brain, but she is on a dose of, it's not a, she's on a half dose of osimertinib. So keep all these things in mind. I'm going to ask about all these things. So.
Because now I would look at the symptoms of the patient.
She has got only headache. That's
headache.
It.
Yeah. Now again, if this headache is one area where it is very difficult to define headache as a symptom for brain tumor, because there are many brain tumors which doesn't come with headache, or many brain tumors and many headaches does not have brain tumor. So that is why I would like to look at how she is progressing, how her symptoms are.
You would treat with some local therapy.
Local therapy should be added now, and steroids and medical decompressive therapy should be given because she's symptomatic now.
Okay. So medical oncologists agree with this? Yeah. So at this point,
one thing is, what is the definition of symptomatic? That is a gray zone, as actually
no, but a patient
is having
brain met with a headache, we will attribute it to the brain met only.
So it is brain met.
In our practice, that's how we would look at it.
I think. But anyway, in my practice, most likely it can be because of the disease. So we'll go with and address the brain metastasis. But in the general medical terms, or in the trials also, they use the term as a symptomatic. But what is the definition of symptomatic is not clear. So sir is telling that for him headache is not a symptomatic. Not much symptomatic.
So that's a clinical judgment. So that's what I said. So when we see the patient, that's a new onset symptom, you'll take it as part of the metastasis. Okay, we'll move on.
Little longer. This 3 centimeter will become 4.5. She'll start having neurological deficits. She'll have worsening.
The definition of the symptom is not clear.
So let's all agree that we will do some form of local therapy since we're coming to this end of this. Now, how do you tailor your systemic therapy at this point of time? The patient has got progression only in the brain. Suppose you have given local therapy, you continue osimertinib, but she was on 80 milligrams alternate days osimertinib. So are you looking at adding something here, or you are comfortable with the same dose? How do you go with this now, Dr. Kripa?
So I think you said the CNS oligoprogression alone. I mean, like extracranial metastases are definitely very well controlled. So local therapy and then continue with the same systemic therapy backbone, given that the patient has actually responded well at all the other extracranial meds. I think that's what I would probably.
I'll give you a different scenario. Suppose the patient has got multiple brain mets now, and you are not, you're worried that more are going to pop up. Would you change your systemic therapy?
So even then, if that's the only site of disease and it's already been addressed with some sort of local therapy, let's say for example, even hippocampal avoidance, whole brain RT has already been done. Okay. Then I think I would still look at continuing
the same systemic therapy. So where do you place higher doses of TKIs? Do you use them in practice at all? It's mentioned, but in practice, does anybody do? There are some small papers, but does anybody do?
Yeah, I think like you rightly said, the Bloom study, which is looking at 160 milligrams of osimertinib, especially in patients with even leptomeningeal disease as well. But unfortunately, they're all very small numbers, not phase 3, level 1 randomized data there. So I think in practice, it's very difficult for us to actually look at going beyond 80 milligrams, and we don't do that even in atypical mutations or apart from EGFR exon 19 and 21. There is some data there as well to use a higher dose of osimertinib. But nevertheless, I don't think most of us don't do that in practice.
Okay, both of you agree? Have you ever tried a higher dose of this thing? I also not use, so anyway, that's this thing. Kripa, specifically to you, huh? Yeah, Bhavesh, anything you want?
At 160, it becomes difficult to tolerate after a couple of months.
Yeah.
That is what we have seen, and then again we come back to 80 milligrams.
Correct.
So that
I mean,
we
this
have
patient
started,
couldn't
but
tolerate 80 also, so yeah, so I know. Kripa, this is for you.
So I think, I mean, like, I went through a lot of data as well for that. So somebody with even EGFR mutation disease, when they progress on the first line, you know, I think that's one area where we would look at VEGF inhibition, definitely comes into its own. The IMPAR 150, the ABCP regimen also, if somebody's progressed on the first line and probably can't go on to amivantamab plus lazertinib or, you know, any of those other,
It's one more option when you want to add more
systemic
systemic
an
therapy.
option there,
Yeah, I think we already talked about supportive care. All these, I think Dr. Prahlad already mentioned about some use of memantine. It's there in all the guidelines, I think. And anti-epileptics, when do you use? Any of you? Doctor?
So the conventional wisdom is that we use anti-epileptics for all brain lesions. Whenever we find a brain lesion, be it benign tumor, malignant tumor, METs, head injuries, wherever we find a lesion in the brain, prophylactic anti-epileptics are used. But many a times, literature says that, we can only do EEG and then decide for anti-epileptics. Because the older anti-epileptics had a little bit the toxicity profile, with the newer anti-epileptics are coming with very least toxicity profile. So still there is a lot of gap on use of anti-epileptics between common practice versus the literature.
So I think practically we all, unless somebody has a seizure, I don't think we are starting prophylactic anti-epileptics now anymore. And so I think that we all agree with that. I think because we have to end, I'll just stop here. Sorry, it's like, yeah, I think I had one more case of oligometastatic, but that's okay. So, yeah.
N staging and T staging? Or would you say that I would only, if it is T1, T2, N0 or N1 with a brain met, I would treat with radical intent? We all talk about oligometastatic, but my question is, if you have, let's say you have a T3, N2 with an oligometastatic brain.
So I had that one. I had a question, and that's in an oligometastatic disease or in a limited stage disease, and you have a brain met, do we treat that with a curative intent? That's your question.
Based on the N staging. So otherwise it would have been technically 3B if it was not an oligometastatic. So that's where, because the controversy of treating with definitive treatment itself is, in an N2 disease. So that's the controversy.
So I think, like you rightly pointed out, single station N2 non-bulky disease, then probably, it definitely does come under the purview of surgery even at that point in time. I'm talking about the T and the N staging as well. If it is still single station, non-bulky, less than 3 centimeters, then probably, there's a chance that, we could go ahead and contemplate some form of local therapy even there as well.
And now sequence. So would you do the brain lesion first, followed by NACT, and then do the lung, or how do you want to do it?
So if the patient is definitely symptomatic for the brain metastasis, go ahead and address.
Asymptomatic brain metastasis.
Yeah, asymptomatic brain metastasis also probably lead in with systemic therapy, because especially we have advent of all the systemic therapies with the third generation EGFR, TKIs and ALK inhibitors that we have at our disposal. I think we would want to look at leading that. We know systemic therapy definitely is the cornerstone, even if it's stage 4 oligometastatic disease. So I think there we would look at leading in with systemic therapy, at least reassess after a couple of months. Responders versus non-responders. Responders definitely consolidate with local therapy.
Thank you.
I think most important part here will be the biology of the disease. So if we have a driver mutation, we'll go all out. But if we do not have a driver mutation and we don't have a very good systemic therapy, better not to go for it. It's going to be a failure.
One small query and comment regarding the ESCO guidelines in asymptomatic brain metastasis. It states that in asymptomatic where there is a targeted therapy, brain penetrating, the level of evidence is weak. It is informal consensus, not A, B, C. So with this level of very weak level of recommendation, informal consensus, do we still, if they are small, like tiny 2-3 millimeter METs, that's a different case. But there is no standard guideline for asymptomatic. If it is a 1 centimeter located in an eloquent area, asymptomatic, so are we still willing to wait for it?
So I think that's what I think some of the panelists mentioned. So you take it, you start something and you keep a close follow-up. If they're asymptomatic, they've got a 1 centimeter lesion and let's say it's in EGFR exon 19 deleted. You start osimertinib chemotherapy and then you see after 2 or 3 months, they're doing well, you're okay.
You agreed for sub-millimeter, but what about like centimeter when the level of even the evidence is weak and informal consensus guidelines? So are we going to forego SRS in patient of 1 centimeter brain mets asymptomatic? So I don't want to like forego. In our tumor board, we always go for, even if it is 1 centimeter asymptomatic, we go for upfront SRS followed by, even if the patient is ALK positive, ALK range or EGFR positive, can afford even osimertinib, because the level we are acting trigger is level even C or D level of recommendation.
In trial, in turbo NSCLC in patients with EGFR and ALK mutations, they say that if brain metastasis more than 1 centimeter, they have better local control, CNS control.
Even
It's
asymptomatic.
TKI plus SRS versus TKI alone.
So I think it has to be definitely discussed case by case, I think. Thank you very much to all the panelists for the great discussion and brought out very important points. Thanks to the organizers once more for giving us this chance. Thank you.
Thank you for a wonderful discussion. I request all the panel members and the moderator to stay back for a group photo. So we have with us Dr. Sri Hari, Chairman of APMC, and we would like to felicitate him, and I request Sir to kindly come upon the dais. I request Mr. Kumar Nandula, CFO, TCCF, to felicitate Sir, and also Dr. Prashant, Director Speaker. Thank you, sir. Now we move on to our next panel discussion. The moderator for this panel is Dr. Ashish Singh, and the panelists are Dr. Sarvana, Dr. Venkatesh, Dr. Shyam Bist, Dr. Srinivas, Dr. Prashant Penumadu.
So very good afternoon. Thank you all for staying here so late. I know this is the last session, but we'll try to keep it as engaging as possible. So I don't see my surgeons because this is all for the surgeons. Dr. Sarvana is around? He's in the video. Okay. So all the responsibilities on the able shoulders of Dr. Prashant. So right from day one, from feeding us to making us, giving food, water, shelter, he's done a wonderful job. I think you should just give him a round of applause for, and even for the last session, if you see the number of people who are sitting, this itself is not something we see commonly in oncology meetings. Okay, so the topic today, we have, okay, so the topic today is actually treatment of oligometastatic or oligo-residual or oligoprogressive disease. So in general, we're going to talk about advanced stage disease, right? And when I just say advanced stage disease, what comes to our mind? Advanced stage disease is something which anyway is incurable, metastatic, and nothing can be done. But when we talk about early stage disease in lung cancer, what comes to our mind? We loosely use these terms like, okay, the intent is curative. We are going all out. right? But when it comes to lung cancer, if you just look at the Kaplan-Meier curves on there, and I don't know, the font is too small, but if you see here, maybe in the next slide, depending on what, can someone help me? How do I move the slide? Yes. So this figure I just took from our last TNM8, UICC TNM8 classification. And based on what are we staging these patients, and this is with treatment, if you look at 5 years survival. So it's, if you look at, just focus on stage 3 alone, it is dismal, right? And so therefore, basically what we learned in our school so far, in our training so far, is that this is what we all learned when we learned oncology, that how do we approach lung cancer? We approach lung cancer, early stage disease, as the moment we become stage 3, the standard therapy, so this is not what we learned in colon cancer or breast cancer. Stage 3 is still, majority can be cured, we need to go all in. Surgery is the most important curative therapy, and after the surgery is done, then we think about, okay, how do we reduce the risk of relapse? And but then if in lung cancer, it is chemoradiation, right? And I think I have 2 radiation oncologists on my panel, Dr. Shyam and Dr. Srinivas. And this I feel you guys would always say that this is like this because show me the data that surgery gets better outcome, right? And as surgeons, we were never able to show that data. This is in olden days.
Yeah, even the olden days also, we were still able to show the data. If you see all the trials which actually compared CTRT versus surgery in locally advanced or stage 3, unfortunately, majority of these patients actually underwent pneumonectomy, which was the cause for the early mortality in this group of. We know that pneumonectomy by itself is a disease. So there was a lot of mortality. And the neoadjuvant treatments weren't great at that point of time. So that is one of the major reasons why the surgery trials failed to show importance.
Sure. So what Dr. Prashant is telling is that we cannot compare an earlier era with the current era, the earlier techniques, the earlier staging modalities, the earlier. However, I mean, if you look at any guidelines, it is still chemoradiation. And that is again because, I'm not saying surgery gave us inferior outcomes, but none of the 2 modalities could give a better survival. And as you said, that if you have to resort to a pneumonectomy, then it's probably patient is better served by doing non-operative treatment. Now let's fast forward, right? So where are we coming from? Now this is in this slide is almost 20 years old, difference between the 2 large phase 3 randomized. Earlier in our meetings, we used to say, okay, we have a new drug called gemcitabine, pemetrexed, docetaxel, maybe we'll improve outcome as compared to etoposide and vincristine and all that. But we failed miserably, right? But then things have changed. Now, in those 2 slides which you see, the first one is with what immunotherapy can do in the absence of driver mutation. And that one is the crown trial, lorlatinib. Now, those 2 are these are all, right? So we are definitely have already entered, we are living in an era of other cancer. The advances are made in advanced disease and that moves forward into adjuvant and then maybe neoadjuvant. And we are already there. So I think we have colleagues from JIPMER, they are already running a trial, a first-line trial of this drug called olomorasib along with chemoimmuno in KRAS mutated lung cancer. And would you believe this is a waterfall plot of a patients with stage 4 lung cancer? Literally every patient is responding to the therapy. Yeah. Now the question is, we're still learning, okay, how durable this response is going to be and whether this will have implications on what local treatment we offer to these patients, right? So we can, so there are 2 main questions we have to answer today is, should we do local treatment in patients who were deemed unresectable at the baseline? That could be an unresectable stage 3, that could be a synchronous metastatic disease or a recurrent metastatic disease, oligoresidual or oligopersistent. Recurrent metastatic disease, oligoresidual or oligopersistent, right? So in general, we talk about it. Now the question about utilizing good treatment upfront is important in oncology, right? We have seen this across drugs, across cancers, right? Even now we are seeing, like in breast cancers, now they're saying use trastuzumab deruxtecan upfront. Why? I mean, why can't, this is a good drug, why can't I reserve it for later? In general, the concept is that if you have a tumor which is, because the tumors evolve over time, heterogeneity, resistant mutation, escape pathways, and we have seen this across even in whether in lung cancer per se, whether you take it as any targeted therapy or even immunotherapy. Immunotherapy works best, at least in terms of responses, when you use upfront. So now let's come back to how we look at a patient, right? Now, when we look at a patient, again, I put the slide up, this is from UICC 9, is because most of the time in meetings like this or in MDTs, we just discuss tumor-related factors. What about host-related factor? What about environment-related factors? And this is not my slide, this is just copy-paste from UICC stage 9 manual. So maybe I can just ask my panel, because everybody sitting in the audience, we work in different environment. Our patients have different setups. So a same stage 3 or a stage 4 oligometastatic, does your plan change based on host-related and environment-related factors?
Sir, definitely the performance status does matter, 100%, and also the socio-economic status. In the environment-related, that is the main cost constraints we see. Yeah. And coming to host-related, performance status and comorbidities. These will be considered in addition of therapy and what to give and all. Definitely.
And for the students in the audience, and these two factors are actually very well controlled in a clinical trial. Definitely. So when somebody gets up and says level 1 evidence and level 2 evidence, that is in the setting of extremely good host and extremely controlled environment-related situations where you don't have to worry about the food, water, shelter, finances, time, everything is taken care of. But then the challenge in real world is how do we put all these things in a patient in front. Now, okay, so I had one slide on staging. Now, before we get to staging, let me just get to a case and then we go back to staging. Okay, so this is a patient, this is the baseline scan. As you can see on the slide, is a 58-year-old male, February 2025. He came with some chest pain and some coughing on the anterior upper chest. And this is a CT. And any one of you want to, Dr. Shyam, you want any more information, you can ask me, I'll provide.
So this is a tumor which is there invading the chest wall, going to the mediastinum, and there is approximately looks to be more than 5 centimeters. By virtue, it can be T3, T4 because T3 because chest wall and T4 because of the mediastinal invasion. Yeah. And there is a node right level 2L. It is at the junction of 2 and 4, so it's almost around 2 centimeters.
Right. And on this report, they have reported there's a suspicion of SVC being abutting or involved. I mean, I know we can't make out on these images, but there was that. And do you think there's a sliver of fluid around there?
I think minimal.
Minimal fluid.
Yes, minimal fluid.
Yes, Prashant?
Yeah, I would consider that patient is in supine, so that's a significant. It would be somewhere close to around 400, 500 ml if you actually see. If you're seeing fluid still in the upper thorax, it's still, it's good. So there is a sliver of fluid. Right. SVC on this image, it's very difficult to tell, but yes, it might be.
Let's do an MDT on him now. Let's do an MDT on him now. So, Dr. Venkatesh, because Dr. Prashant has already said I significant fluid. So he's still labeled him as stage 4. So what would you do now? You will say, MDT is over, come to my OPD tomorrow, I'll make systemic therapy plan, or you still want to discuss some important issues here in MDT?
No, so molecular testing that has to be done as biopsy, proving the biopsy.
Sure, biopsy is adenocarcinoma.
And now because he's in SVC, symptomatic management.
Would you want anything else, like for the students here? Do you want MRI brain? Do you want PET CT? Do you?
So because now with him being SVC and symptomatic more than MRI brain, I will first try to optimize him if he's symptomatic for the SVC syndrome.
No, SVC is not obstructed or blocked. Okay. It's just a abutting.
Then as a part of workup, yes.
Yeah, and that's more in terms of surgical things. So Dr. Prashant, if SVC is infiltrated,
so first and foremost, I would like to get a pleural fluid cytology and I want to prove whether he is really metastatic or not. If the pleural fluid cytology is negative, then I have not given away my hopes on the patient.
Right.
So then I would work up this patient on with a PET CT to look for other diseases. Yeah. And of course, MRI, we have discussed whether you want to get if it's stage 3 and PET, it is non-metastatic, then an MRI brain mandatory.
So we did do the PET and the PET showed an N2 subcarinal single non-bulky lymph node.
Okay.
Yeah, and local was just about T3, T4 lesion, and fluid we could not tap. It was minimal.
Minimal, yeah. So then it's not.
So my Dr. Venkatesh said you want molecular testing. Does it change your treatment today as of now?
No, so if, just it will give some time so that we start working a process, but if symptomatic and metastatic has already, if it is, then...
So any of my radiation colleagues, would you want to do upfront CT-RT?
Ashish, I cannot see any signs of SVCO in this case.
There's no obstruction at all.
No
It's just
obstruction.
abutting the vein.
Abutting,
Yeah, abutting the vein,
But-
maybe infiltrating.
So any comment on the level 2 lymph node, which is round? Well,
So you are seeing whether it can all be encompassed
can
in
be
one
encompassed.
radiation portal. Yeah. So that is how, so if I can tell you, this is like an upper side. So it was not possible to encompass at the moment. And let's for a moment assume the fluid is negative. So would you all say for the Medong to start on systemic therapy?
no, we will do a complete staging before concluding. So what is the
So
accurate
we have already done MRI and PET.
and what is the complete T and N staging of this?
So N is N2 single non-bulky.
So I think
and no distant metastasis.
T3, T4, N2, I would go for a CT-RT. That's the standard. If it is M0,
So it doesn't matter if there's some fluid, doesn't matter if the field is large.
You told there is no fluid.
Right.
There's minimal fluid.
Right.
So
So
we'll go
anybody wants to contest that?
Yeah.
My dong, I'm looking at you.
So I think only surgeon has to contest right now. I'm sorry, I think just because of SVC,
Yeah.
if you ask me, SVC is one of the easiest structure that I can, resect, especially T4.
Right.
So I need not even go on pump. I can just do a cross clamping so that I maintain the circulation,
so this
cerebral
is what
circulation.
even I have seen in my MDT. Now the surgeons have become very confident. And
No,
the
they were
Medongs
always
have become
confident,
super
Ashish.
confident. The
So they
Medongs
were-
have become super confident because we are like, show me the molecular profile and I give you a fantastic
Exactly.
response
So
here.
I would take help of Venkatesh and say, come on, do something before rather than subjecting patient to CT-RT because it's single station N2. If you would have given me in a tricky situation after EBUS and said that it is multi-station, multi-zone, I would have been worried. Then yes, I would have left to Shyam or Srinivas to take care of the patient
So
nicely.
this again. Correct. So touching upon the lymph node point, so if you see, this is how we stage all the lymph nodes. And another thing which actually has a lot of cost implication is we always discuss, should we spend our money, do that EBUS, TBNA, prove the node is positive? As you said, tap the fluid. So we used to definitely do it earlier because earlier our treatment would vary. Maybe prognosis varies based on proper staging. But if you're working in a limited constrained environment, maybe a small town where we don't have all these available, are you okay going ahead with just PET and MRI, or it's mandatory to spend that 50-60K and get an exact nodal station?
At least minimum CT upper neck, thorax and abdomen, PET done. Okay. So ideally you can go with chemo IO followed by surgery. That would be a good option.
Ashish, I would still get an EBUS because 30% of the nodes in India are still because the outcome, I agree how much it changes in the management, yes. One thing is if it is T4 N0, the outcomes are much different when compared to a T4 N2. And again, single station N2 versus multi-station N2. So it's going to, if it is multi-station, multi-zone, as Shyam actually rightly brought up, you have an upper paratracheal node with a lower.
Sure.
I'm not
so,
very
so
keen.
if you look at the slide now, the picture in front of you, so in each of these situations, they may all be 3B or 3As, but you can have different permutation combination, right? And each of these should be treated the same way with CT-RT, and they should be, I'm sure what's coming out is that individual patient needs to have a different input, and we don't have time to go into each scenarios here, but that's what we are doing. Also, another thing I think about is we are looking at only anatomy here, right? Favorable anatomy, unfavorable anatomy. What about biology? And now the third part, even your own anti-tumor immunity, right? Immunology, right? So do we have a situation where, so do we all agree that if you have an unfavorable anatomy, like for example, a patient like what we just discussed, and you do something and you make it favorable, that means the SVC is clear and the node reduces, effusion goes away. You're making an unfavorable anatomy into a favorable one, but does that mean that you're changing biology? What do you think, the medical oncology? Just because your tumor is shrinking, does that mean you go and operate? Even lymphoma shrink, right? We don't operate.
Unfortunately, that doesn't work for solid malignancies much.
Okay, so you feel that we should go and resect.
So wait and watch policy as of now, I think is limited to rectum. So we don't have any data on wait and watch. You know, the clinical complete response rates in the era of immunotherapy is so high that we have no data as of now that we should be observing this group of patients. We would still go ahead and operate these. Operate in the sense, I would say, definitive treatment.
So Dr.
If it's
Prashant,
feasible.
This slide is for you. I mean, I hope Dr. Saruna was also there. Has he come? He's not come, right? So this is just different surveys were done or different criteria, EURTC, STS, and then that's from some of the Asian countries. And if you can see on the slide that there seems to be the gray zone between resectable and clearly unresectable. And a lot of surgeons, they are not agreeing amongst themselves. A lot of it is potentially resectable. And as of today, we want to put our patients in this bracket of resectable, unresectable right up front. Is that the right approach moving forward?
Yes, I wouldn't call them as early and locally advanced. We divide them as resectable and unresectable. The unresectable patients straight away, go in for radical CT-RT followed by maintenance immuno. But the resectable patients, I would put upon, some form of neoadjuvant therapy and then get these patients.
So I knew you will give this answer, so I put this slide only for you. This is one of the surgeons now recently concluded meeting where they're trying to, I don't know if you recognize him, I don't. So they said the resectability is some subjective, right? It's in the eye of the beholder. Right?
Exactly.
And also in a very important, in the same session, he also said this. So it's basically, as one of the panelists said, we will go ahead with CT-RT. But what does CT-RT achieve? I mean, if you see some of these older series where surgery was performed after CT-RT, PAT-CR rates are only in about 20 to 30%. So we are all accepting CT-RT where we are leaving residual disease in say 70%, but we are not accepting a surgery which is going to be R1 or R2, maybe in 20% or 30%. I know I'm making controversial statement, but I want the fight to be between you both, not with me.
But we all know the R1 is a sin. R1, R2 is a sin.
But this is also R2. Your CT-RT is also R2.
It's not R2. Actually, no. It's actually because whenever we are doing a surgery, for example, head, neck, anyway, if we are doing R2, we are exposing those blood vessels to residual disease, and there is a very huge drastic metastasis, whereas in case of when you are doing
so what you're telling is show me the data that R2 is also beneficial for the patient, which at the moment we say if you're going to get it R2, yes, we should not do. Yeah, that's right. That's absolutely right. But I'm just putting a thought in your mind. And so now also if you see recently, even in terms of the staging, people are trying to divide N2 into N2A and N2B. And I think all this is just to kind of properly define resectable from clearly unresectable. Right, we'll come back to our patient. So,
she's one thing. Like in the 8th AJCC, they have given the N1, N2 and N3, but they have also given a glimpse that this end stage might change in the 9th AJCC, like N1 single station, multi-station, skip, without skip. And but when we see the 9th one, we see there is no change in N, but there is a change in M, M1A, M1 B, and C.
We'll come to that. So that's the oligometastatic they're dividing now.
So because
okay, let's finish with this patient. We jump to metastatic. So this patient luckily had an exon 19 deletion. So this is the response you see after 4 cycles of carbopemetrexid and osimertinib, right? So Dr. Prashant, this is the scan now.
It's clearly operable. Yes, it was clearly operable then, and it's better now.
Right. So now the question is, okay, this has a driver mutation. He has responded well. Can we definitely say with confidence that surgery will definitely add to his survival? And also, okay, let's assume the pleural fluid was positive. This patient, we did not do the pleural fluid. Because our topic is metastatic, oligometastatic, let's assume the pleural fluid was positive. At this point in time, because this is a common question we all have, it's like my radiation colleague asks me, I can radiate. My surgeon says I can do surgery, but should I do now or shall we wait? If wait, how long?
Okay, so among all the oligometastatic diseases that you see, pleural fluid is the only area which is actually controversial. So if you have solid oligometastatic...
Suppose there's an adrenal. There was one adrenal nodule.
I would 100% operate on both adrenal as well as the lung too. Yes, adrenal, brain, I would definitely operate.
Right.
Even if I have oligomets to bone I would, surgery, I would treat with radical intent in the form of this thing rather than leaving this bit. But pleural fluid, yes, the role of high torque is evolving.
So Dr. Srinivas, now I want you to, you wanted to do upfront chemoradiation.
Yes.
Do you want to do it now and tell the surgeon not to operate?
If pleural fluid is positive or negative?
No, if it was not positive, upfront the SVC was closely maybe infiltrated. Would you want to still do CTRT? So do you make your decision based on the original scan or the current scan?
In setting of this, we will use it to contour the post-chemo volume. So volume will be less.
Okay.
So we will usually consolidate the pre-chemo primary and post-chemo primary.
So the
and
message is that you guys don't need to fight
so
with
that,
each other. Maybe
so
you should
that,
work as a team.
So that volume is less and less complications, we can go with the chemoradiation is my opinion in that sense.
So you should work as a team, and when you work as a team, you can improve outcomes. I'll just show you, this is from the last ESMO. This is the North Star phase 2 trial, but randomized trial. So being randomized trial, it is very useful. All patients with metastatic EGFR mutated lung cancer, and they were all started on osimertinib, no chemotherapy. And then once they have if they had no progression, they were randomized. And this is not only for oligometastatic. So if you see the number of metastases there, greater than 3, almost 71%. And some of them even have up to 10 metastases. Even pleural fluid, pleural effusion, everything was included, right? It didn't matter what you started with. And if you see here, this is what I was telling. 29% more than 10 mets, 6 to 10 mets in 43% of patients. In this kind of patients, in today's day and age, I think you should commend them for randomizing them into loco-regional treatment versus no treatment. And here, this is what I was saying about we don't have to fight. I mean, you have to basically choose between surgery and radiation, right? And sometimes both. But usually you should not do both. And you should actually, and majority of them, 1/3 of them had surgery. And here again, if you see lobectomy, wedge resection, segment adrenalectomy, as Dr. Prashant was saying, pneumonectomy is something you should not do. That itself is a disease. And then the radiation ones. And if you see the median progression-free survival was more than 2 years, 25.3, just by doing loco-regional treatment. And this itself now consolidates what we just discussed for our patients earlier, that even if you have, now again the panel is for oligometastatic disease, but this again, what is oligo and what is poly also depends on the biology, right? If you have a tumor where you don't have good medical treatment, a stage 3B may have a worse outcome as compared to say an ALK positive. So we have only 5 minutes left, so we'll go fast. Okay, and then the benefit was seen across. Right, and so now let's come to some definitions. I mean, are these definitions still important? Do you all follow some definitions in your practice? What is oligometastatic? What is polymetastatic?
So, like there are even different definition. If you see the EORTC, it says 5 up to 3 organs. If you see ESTRO, ESMO, it says up to 3. NCCN 2 to 5. And the International Lung Society, it adds one more thing, that up to 5 beds.
So basically what's coming out is that again these definitions are varied across trials, and then these definitions are not linked to the biology.
So as long as my surgeon and my radiation oncologist is comfortable and I am comfortable giving local LCT after the therapy, I don't find these definitions
But then if you say one patient with 1 brain met, 1 adrenal met, and 1 bone met, this is also oligometastatic, as opposed to 1 patient with 5 liver mets. Okay, so 3 organs, 1 lesion each, versus 1 organ, 5 lesions. All these are oligometastatic, but we think differently about these 2 patients, right? So that's again it's not very clear. So there's a lack of general consensus on uniform definition, and therefore no single therapeutic perspective across institutions. So across institutions this may vary, and therefore the oligometastasis, even though it's an older term, I mean, we can just think about it as a state of limited disease burden despite the presence of distant metastasis, right? And it's about picking patients who will do well with surgery. And this was another review where surgery was done on a cohort of about 52 patients, all metastatic disease. And if you look at those Kaplan-Meier curves, agree it's a well-selected patients, but then I just showed you a randomized trial. This is only surgery. There's no radiation here. So what Dr. Prashant says also has point that if you have a patient where you can demonstrate change in anatomy, change in biology, and you have your Medong thinks that the treatment is good enough to the response to be durable, that is the way to go. Okay, now let me just come again to some immunotherapy, right? Now we know immunotherapy has changed the way we treat resectable lung cancers, and these are the landmark 5 trials. We won't get into that. And if you look at here again, these are all stage 4 polymetastatic, first line patients, almost 6 drugs, similar outcomes, and 2-year event-free survival is almost 60-70%, right? And overall survival is not mature for many of them, but we are seeing overall survival also for some of these patients. Yeah, so 2 minutes left. So let me bring another controversial area. Suppose our patient had clear SVC obstruction, right? So as Prashant said, no problem, I can remove it, but sometimes if it's a pan-coast or a chest wall, it's pretty difficult, right? So upfront, should we rule surgery out is the question. As of today, yes, that's what we do. But this is again a small study, but a good study to know. Here they did induction with chemoimmunotherapy with serplulimab, 3B, 3C, clearly unresectable disease upfront, right? They did induction and then they restaged. Based on the restaging, whether you would be downstage or not downstage, you are randomized into surgery versus radiotherapy. Now here I am putting you both against each other, right? Who is better? Surgery, this is clear, upfront unresectable, good response to chemoimmuno, surgery versus radiation therapy. And if you see here, this is the response in, so they were able to do surgery in about 98 patients. There were some patients who got randomized into radiation, but they refused, right? And their surgery was finally done. And they're just showing you this is the overall MPR and PCR. So almost about half the patients, 47.6 had a PCR, 61.9 had MPR, radiological response in 75%, and this is overall cohort. And yes, and here you could see that these are, again, if you look at the overall survival at 2 years, almost about 75-80%. Now this is not what we achieve with upfront chemoradiation. So now again, this is small numbers, but I'm just telling you that we all need to probably relearn how we managed non-metastatic or even limited metastatic lung cancer, provided we have good responders, and that good responders depends on what systemic therapy we are giving them. Okay, so I think is not positive. That's what I want to say. That because if you look at this NRG LU, the second last from the bottom, this was a trial where most patients received immunotherapy, and then they were randomized. But again, this was not based on biology. They were randomized right up front, and they could not demonstrate an improvement in survival. So we await more data.
I think this Energist trial, if I'm not wrong, they didn't take a baseline PET and MRI are not mandatory.
Yeah, so there were some controversies related to that. So basically, without a driver mutation, at the moment we are still a little careful. The way I look at it is that if you have a therapy which is giving you PAT CRs in 60-70%, maybe you do surgery, don't do radiation, doesn't make much difference. But so you get that with immunotherapy, but you don't get that with osimertinib or something like that. So that also the biology may be different. We will learn as time goes along. Right. So I think we had quite a good discussion, and time is up. I don't want you all to miss your flight. And once again, thank you for staying up so late, and thank you, Prashant. Bye.
Thank you. Thank you for such a lively panel discussion. I request the panelists and the moderator to gather for a group photograph. I now warmly welcome Dr. Praveena Voona to give a talk on the role of Tecentriq in first line with advanced non-small cell lung carcinoma not eligible for platinum-containing regimens.
Good afternoon to all. I would like to thank NALCCON organizers and Roche for giving me this opportunity. In this session, I would like to discuss with you regarding role of atezolizumab in first-line patients with advanced NSCLC not eligible for a platinum-containing regimen. We all know that all first-line immunotherapy trials have enrolled patients with good performance status and who are eligible to receive platinum-based chemotherapy. But there remains a large subset of patients who are elderly, associated with poor performance status or associated with comorbidities who are not eligible for platinum-based chemotherapy. Such patients are usually excluded from these trials. So there is an unmet need for treatment options in these patients to identify novel treatment options. So many factors have to be taken into account when platinum eligibility is assessed. These are age, performance status, comorbidities, and social factors. Most of the times, in majority of cases, combination of these factors contribute to the decision making for or against platinum doublet regimens. Physician's clinical judgment is the guiding principle across trials and clinical practice. If you see the data from the retrospective observational study, Moon OSS trial, the main reasons to avoid platinum-based regimens were older age, comorbidities, poor PS, family or social issues. In most of the cases, around 88% of cases, a combination of these factors was considered to guide the treatment decision. This slide is showing table regarding the criteria to define patients who are unfit for chemotherapy from, according to an expert panel. So this slide is showing overview of first-line single-agent chemotherapy trials in patients who are unsuitable for platinum-based chemotherapy. It has shown trials in which gemcitabine, vinorelbine, docetaxel, and pemetrexed was given. If you see, the median OS was in the range of 4.7 to 9.8 months. So the evidence for single-agent immunotherapy in frail patients has been scarce. There are no randomized phase 3 trials investigating first-line pembro. Only single-arm phase 2 trial was there, that is PS2 trial. In this, regardless of PD-L1 expression status, patients were enrolled. Total 60 patients were enrolled, out of which 24 patients were first-line patients. Median OS in first-line patients was 7.9 months. Whereas Nivo plus Ipi combination was also tested in a phase 3 study in patients who are elderly and who are having poor PS. But that recruitment was stopped early because of high mortality rate. And Durva also studied in SAC 19/17 trial in patients with poor PS and PD-L1 greater than or equal to 25%. So it resulted in a high number of fatal events, hence the enrollment was stopped. So now I would like to discuss about IPSA study. Already Vanitha ma'am has discussed about this study. Now I want to discuss it briefly. It's a phase 3 global multi-center open label randomized study. It was done in 91 sites across 23 countries in Asia, Europe, North and South America, in which TMSG is one of the sites. In this, single-agent Etejo was compared with single-agent chemo in patients who are considered unsuitable for first-line platinum doublet chemotherapy. So as I said, many of these poor performance status patients are excluded from the first-line immunotherapy trials. So in these poor PS patients and who are elderly with comorbidities, to examine the efficacy and safety of Etejo versus chemotherapy, this study was designed and planned and designed. In this study, treatment-naive stage 3B to 4 NSCLC patients were enrolled who are having non-squamous or squamous histology, platinum eligible either because of PS2 or 3, or in patients who are having good PS who are greater than or equal to 70 years of age with substantial comorbidities or other contraindications to platinum were enrolled, and EGFR and ALK positive patients were excluded, and patients with treated symptomatic brain mets were permitted. Total 453 patients were enrolled and randomized in 2:1 ratio, with one arm patients receiving Etezo 1200 mg 3 weekly, other arm patients were receiving gemcitabine or vinorelbine until progressive disease or loss of clinical benefit. Primary endpoint of the study was OS. Secondary endpoints was OS rates at 6 months, 12 months, 18 and 24 months, PFS, ORR, DOR, and OS and PFS in PD-L1 positive subgroup. These are the baseline characteristics. Median age of the patients was 75 years and greater than 80 years patients are seen in around 30% of patients in both arms are greater than 80 years of age. Most of the patients, that means around 75% are having PS of ECOG PS of 2 and ECOG PS 3 patients are also included, 6% in atezo arm versus 11% in chemo arm. If you see the PD-L1 expression, high PD-L1 expression, that means TC greater than or equal to 50% are seen in only 17% of patients in both arms. If you see in the atezo arm, PD-L1 negative population are higher compared to chemo arm, 50% versus 40%. If you see the OS data, median OS was 10.3 months versus 9.2 months in the chemo arm with a hazard ratio of 0.78, which was statistically significant. If you see both curves with longer follow-up, the curves were separating. That means the OS benefit was evident with the longer follow-up. If you see the 24-month OS, it was doubled. That means 24% versus 12% in the atezo arm versus chemo arm. It is doubled. This is the subgroup analysis, and this atezo has shown consistent benefit across all subgroups irrespective of age, PS and PD-L1 status. These curves are PFS curves. Median PFS was 4.2 versus 4 months in the chemo arm. There is no difference in PFS, but with the longer follow-up, the PS was numerically better in atezo arm versus chemo arm. If you see ORR and DOR, both are doubled. ORR was 17% in atezo arm versus 8% in chemo arm, and the median duration of response also 14 months in atezo arm versus 7.8 months in the chemo arm. This picture is showing quality of life data. Atezo arm patients remain stable across all domains, whereas in chemo arm showed some deterioration in functioning scales. Coming to quality of life data, quality of life was improved in atezo arm, whereas it has shown deterioration in chemo arm. This slide is showing time to confirm deterioration of chest pain, which is better in atezo arm. So this slide is showing adverse event data, and patients, high-grade adverse events were seen only in patients with around 16% of patients in atezo arm versus 33% of patients in chemo arm. That means it has shown favorable tolerability profile, safety profile. Toxicities are very less compared to chemotherapy. And treatment-related SAEs were seen in 11% of patients in atezo arm versus 15% in chemo arm. Whereas AEs of special interest, high-grade AEs of special interest are slightly higher in atezo arm compared to chemo arm. Overall, it is associated with favorable safety profile. So, by this data, we can say that single-agent atezolizumab has shown very good efficacy, safety profile, and good quality of life in patients who are not eligible for platinum-containing chemotherapy. That means who are having a poor PS or elderly with comorbidities. So that's why atezo has been incorporated in NCCN guidelines and ESMO guidelines for these patients, irrespective of PD-L1 status. So to conclude, as I said, it has shown significant OS and PFS, OS benefit compared to single-agent chemotherapy in these patients who are not eligible for platinum doublet chemo, and then benefit was consistent across key subgroups. 2-year OS rate was nearly double, OR and DR are also double, and quality of life was well maintained and improved. Toxicity profile is favorable, and this is the first randomized phase 3 study to show significant OS benefit with immunotherapy in these poor performance status patients. The main strength of this study is this has included patients who are usually excluded from immunotherapy trials, and the main limiting factor is the platinum ineligibility criteria is not stringent. Thank you.
Thank you, Praveena ma'am. Although this was the last presentation, you managed to capture our attention. I also want to thank all the delegates who remained with us till the concluding session. Your commitment to learning and participation is deeply appreciated. We now invite all of you for lunch, and the valedictory function will follow after lunch. Thank you. We'll play some educational reels in the meanwhile.
Breathless, a journey from fear to hope. Meet Ramesh, a 60-year-old man who never smoked a day in his life, yet he breathed smoke for 40 years, and secondhand smoke kills more than 1.3 million people each year. Myth 1, only smokers get lung cancer. Fact, even breathing others' smoke raises risk by 20 to 30%. Myth 2, fasting or herbal cures can treat cancer. Fact, there's no proven shortcut, and early detection saves lives. Myth 3, screening is only for people with symptoms. Fact, low-dose CT can find cancer before symptoms appear, reducing deaths by 20%. Low-dose CT scans are recommended for adults 50 to 80 with smoking or exposure history. At 60, Ramesh underwent a low-dose CT scan, which found his tumor early when it was still curable. It's never too late to quit. After 1 year, heart disease risk drops by half. After 10 years, the chance of dying from lung cancer falls by up to 50%, and your lungs start healing within weeks. Today, lung cancer care has transformed with targeted therapies, immunotherapy, and precision radiation, giving patients real hope. These advances give patients real hope for a new life. Early diagnosis and modern treatment together save lives and restore hope.
Warning, this is a message from your lungs. They can't take the smoke any longer.
I'm giving up. I have time for scrolling but not screening.
Why so sudden?
Sudden, I have given you so many symptoms but you ignored.
What? What are they?
There can be multitude of symptoms, most common being persistent cough that does not go away, sometimes blood in sputum, and later on it can progress to chest pain, exertional dyspnea. Most people ignore these symptoms and land up in trouble.
So how does lung cancer form and how can you prevent it? Cigarette smoke contains thousands of chemicals, and about 70% of those chemicals are known carcinogens. Each puff of smoke you take fills your lungs with these toxins. Over time, these toxins can build up and damage your cells, eventually causing lung cancer. So how can you prevent lung cancer? Well, the first thing to do is avoid smoking at all costs. The next thing is to avoid passive smoking. The next thing is to have a healthy diet. And the last thing is to limit alcohol consumption.
But you have good news. Lung cancer is completely curable like any other cancer if detected early. What do you have? We have low-dose CT scan, which can be done in a high-risk group of patients who have the risk factors for developing cancer. Detected early, surgery and immunotherapy and targeted therapy definitely have an answer which can cure the disease.
Youngsters follow the footsteps of their elders. So let's prevent the future getting addicted and losing productive life to lung cancer. Jai Hind, Jai Arogya Bharat.
So now we have come to an end of the program, and all good things have to end sometime. We thank all the people who have helped us behind the scene for bringing up this meeting to a very meaningful ending. So now we will announce the winners for the ISSLC paper presentation, and I would like to invite Dr. Divya Khosla ma'am to hand over the prizes to the winners. Though the first prize is by Dr. Murlidhar Pardasardi. Murlidhar Pardasardi, if you are here, or we can hand it over to you later on. The second prize is by Dr. Pavan Nagarkar. Dr. Pavan. The third prize is by Dr. Biswajit Nath. Dr. Biswajit Nath. So I'm announcing the winners for video presentation. First prize by Dr. Sai Nagashri, Dr. Anaparthi Rasagna, and Dr. Madhu. Congratulations to the winner. Dr. Divya, Dr. Murlidhar is here. We can hand over the first prize. So we call upon Dr. Murlidhar for ISSLC Paper Award. Congratulations for the first prize. And we also have Dr. Biswajit Nath, who has won the third prize for the ISSLC Best Paper Award. Now the winners for e-poster presentation. First prize has been won by Dr. Sharmila BV. Second prize by Dr. Prasad H. And third prize by Dr. Manish. So the first prize for video presentation, Dr. Sai Nagashri. So the next session is on Best Paper Presentation by NALCCON 2025, and the first prize goes to Dr. Prosenjit Das. Dr. Prasanjit. Second prize goes to Dr. Iniganti Nitin Sai. And third prize goes to Dr. Rohan Kapoor. The second prize winner is here, Dr. Iniganti Nitin Sai.
So we have some special awards for the reels. So all of them who actually sent the reels would get a special appreciation from us, because this was a very new initiative from us, and so we will be handing them a cash prize for all those who have sent reels across to this thing. Okay, thank you.
We call upon Dr. Prasanjit. He has won the first prize in oral presentation for NALCCON 2025. I also call Sharmila Bibi, who has won the third prize in e-poster presentation. So we are announcing the quiz winners. The winners of quiz are Team 1, Hemashri, Vishnu and Biswajit Nath, and the team who are runner-up are Manish, Bhavita and Shubham.
So I request Dr. Prakash, our quiz master, to actually please accompany in giving away the prizes, because he has taken lots of efforts.
We call the runner-ups. Dr. Manish, Dr. Bhavita, Dr. Subham.
Our organizing team will be getting in touch with all the award winners and we will be sending across your prizes soon. Let me congratulate each one of you all for your participation and making this event a grand success. And thank you one and all as we come to the end of NALCCON 2025 and for a new beginning. And on behalf of ISSLC, I would encourage all members to become members of, those who are interested in lung cancer, become members of ISSLC. And also on behalf of Kanpur, that's Dr. Anand, the next meeting will be at Kanpur. Thank you. Thank you.
Bitch, you know,